Welcome address speakers, starting with Mr. Genedis, who is representing the Prime Minister of the Hellenic Republic and is also Minister of Health of Greece.
First of all, good morning. I want to welcome everybody from abroad and to wish a very fruitful conference here. For official reason, you will permit me to address the Greek language, but I want to make everybody that came from abroad to feel very welcome here. So thank you very much. Το κάνει λίγο φασαρία αυτό και θα είναι κουραστικό. Λοιπόν, εκ μέρους του κυρίου Πρωθυπουργού, του Κυριάκου Μητσοτάκη, και ως Υπουργός Υγείας Ελλάδος, είμαι εδώ για να χαιρετήσω το συνέδριο αυτό. Κυρίως διότι, ιδιαίτερα στον τομέα της υγείας που εσείς κάνετε έρευνες και εκπροσωπείτε ανθρώπους που ασχολούνται με αυτά τα θέματα τόσο πολύ επισταμμένα, γίνεται μια πραγματική επανάσταση αυτή την περίοδο που ζούμε. Μια επανάσταση που είναι τελείως βέβαιο θα φέρει θεραπείες για ασθένειες που μέχρι σήμερα θεωρούνται τελείως ανίατες, που θα δώσουν ζωή σε ανθρώπους που πριν από λίγο καιρό δεν θα μπορούσαμε καν να φανταστούμε τόσα χρόνια και ποιότητα ζωής.
And giving quality of life to people who otherwise wouldn't have it. So this new world that is opening up in front of us is a very exciting world in which Greece wants to be present. And this is why we thank you for this conference. Greece of Mr. Mitsotakis of the last 5 years is Greece who wants to be present in global innovation. It gives motives for research and innovation. We will give out even more. And the Ministry of Health, which I have the honor of representing during this time period, is keen on creating an environment that will make your activities even better. Also, with my last mandate as Minister of Research and Innovation, and with the current Secretary General of Research and Innovation, who is present today, this goes to show how much the government is keen on promoting all these values and this research. I thank the Secretary General for being here today. And we would like also to give out new motives for continuing research and innovation. Personally, I feel deeply honored to be a leader in this ministry that advances in innovation, that creates medicine and therapies, creating hope for a lot of people. So I wish you all good luck, and you're very welcome in Greece.
Ευχαριστούμε πολύ για τα καλά σας λόγια. We would like to continue with Mrs. Zoe Rapti, Deputy Minister of Development of Greece.
Αξιότιμοι καθηγητές, αξιότιμοι υπουργέ, κυρίες και κύριοι, θέλω καταρχήν να συγχαρώ
Minister, professors, I would first like to congratulate
του εργαστηρίου της βιοπληροφορικής, αλλά και εξαίρετο επιστήμονα, τον κύριο Παναγιώτη Βλάμο,
Mr. Panagiotis Vlamos, who is in charge of the BHELAB laboratory in the Ionian University. And of course, I would like to encourage him to continue this very important fight of innovation and a fight of scientific research on neurodegenerative diseases. This institution that you represent and that brings us all here today is all about giving motives to new scientists and to innovate in the field of therapies for neurodegenerative diseases. Of course, since the beginning of this mandate, Mr. Mitsotakis always had innovation in science and medicine as a high priority. And that is why, as Deputy Minister of Research and Innovation, I very much support this effort. I see a lot of young people amongst our guests.
Ότι το Εθνικό Κέντρο Τεκμηρίωσης αναφέρει ότι η επιδραστικότητα των δημοσιεύσεων των Ελλήνων ερευνητών μας, αλλά και των Ελλήνων της Διασποράς,
It is deeply well known that Greek scientists occupy among the first places globally for scientific research. That's because our country has a lot of great scientists, greatly qualified scientists, and numerous university departments on biology and medicine with different specializations all across the country. Of course, since I am responsible for research and innovation, I could not mention the research that has been done during the last years by the Academy of Athens and other institutions across the country, like the Egeta Foundation and bioinformatics laboratories all across the country. I would also like to mention the collective work that is done by many across the country. So our ministry supports innovation and research with funding and also in other ways. And let me remind that during the last years, great sums of money have been invested into research and innovation on medicine, like, for example, accuracy medicine, drug development, and also entrepreneurship on medicine topics. It is notable that from 2019 till 2022, as noted by Eurostat, the sums invested in innovation and research have been raised in Greece, and it is true that enterprises do take part in this raising of money for innovation and research. We also get support from the European Union, which we're deeply grateful for. What I would like to mention for our young scientists and professors is the Horizon program. We're now in 8th position for funding, with more than 1 billion euros as funding. And in the framework of the 2021-2027 program financed by the European Union, Greece will occupy, according to current data, will occupy the 7th place, meaning our research centers, our universities, and our scientists is developing and is establishing its part in innovation. I don't have the time to go on even more on the different programs that are financed by the government and by the European Union. I will only mention two. We have the Center of Research on Neurodegenerative Diseases, but also molecular behavioral research center, which we're planning to finance with a big sum of funds by the Alexandros Fleming Foundation. Drug research is also carried out by the University of Athens, and they have done great progress during the last years. I couldn't even imagine where we are now some years ago, and it's important for us now to hope and see the future in a hopeful way with the support of the government and, of course, with the help of many institutions and conferences like this one we are gathered here today for. With all of this, I'm sure that people will notice how much you can change lives with the work that you do, helping people in their daily lives, giving them quality of life and making their life easier. That's why I am proud of our research community, and I would like to congratulate you for all our partners who support us to create a new world that human imagination and AI and politics
Ευχαριστούμε πολύ. We will continue with Mr. Christos Taikouras, Minister of Infrastructure and Transport of Greece, who unfortunately couldn't make it here with us today, but he sent us a video.
Αξιότιμοι διοργανωτές, ομιλητές, αξιότιμοι διοργανωτές, ομιλητές και συμμετέχοντες. Είναι τιμή μου να απευθύνω χαιρετισμό στην τελετή έναρξης του 6ου Παγκόσμιου Συνεδρίου στην γονιδιωματική, στις νευροεπιστήμες, στη θεραπεία και στην καινοτομία με χρήση δεδομένων. Θα ήθελα πολύ να είμαι μαζί σας, αλλά βρίσκομαι εκτός Αθηνών αύριο το πρωί, εκπροσωπώντας την κυβέρνηση. Ως Υπουργός Υποδομών και Μεταφορών, θα ήθελα να συγχαρώ τις προσπάθειες των διοργανωτών, καθώς και των ομιλητών, ειδικούς στον τομέα τους, από κορυφαία ιδρύματα στην Ελλάδα και το εξωτερικό, για τη συνεχή διαρκή συμβολή τους στη βελτίωση της κοινωνικής ευημερίας. Παρακολουθώ ενεργά και συμβάλλω, από όποια θέση κι αν υπηρετώ, την τελευταία δεκαετία, την πορεία των ερευνών σας. Μια σημαντική πορεία και χαίρομαι διπλά, ως συνάδελφος πανεπιστημιακός, αλλά και ως ενεργός πολίτης, που βλέπω αυτό το Παγκόσμιο Συνέδριο πραγματικό ορόσημο στην επιστήμη να εξελίσσεται, να εμπλουτίζεται και να διευρύνεται με την πάροδο των ετών. Το συνέδριο, όπως είναι και ο τίτλος του, επικεντρώνεται στην έρευνα αιχμής για τις νευροεπιστήμες, τη θεραπευτική, με ιδιαίτερη έμφαση στις προσεγγίσεις που βασίζονται στα δεδομένα. Η θεματολογία του συνεδρίου είναι σύγχρονη και καινοτόμα, με ομιλίες που αναδεικνύουν τις τελευταίες εξελίξεις σε αυτούς τους τομείς. Προωθεί την καινοτομία και τη συνεργασία, διαδραματίζοντας καθοριστικό ρόλο στη διαμόρφωση του μέλλοντος της υγειονομικής περίθαλψης τόσο στην Ελλάδα όσο και πέραν αυτής. Θέλω να τονίσω την εστίαση του συνεδρίου στην νόσο Alzheimer, καθώς οι συμμετέχοντες σε αυτό το συνέδριο επιτελούν πραγματικό, ουσιαστικό έργο που συμβάλλει στην πρόοδο της διάγνωσης, της θεραπείας και της φροντίδας των ασθενών με Alzheimer και συναφείς διαταραχές. Οι προσπάθειές σας συμβάλλουν στη βελτίωση της ποιότητας ζωής τόσο των ασθενών όσο και των φροντιστών τους, αντιμετωπίζοντας μία από τις πιο πιεστικές προκλήσεις της εποχής μας στον τομέα της υγείας. Το Υπουργείο Υποδομών και Μεταφορών και εγώ προσωπικά υποστηρίζουμε σταθερά αυτές τις προσπάθειες και προσφέρουμε βοήθεια με κάθε δυνατό μέσο. Σας εύχομαι ολόψυχα καλή επιτυχία στις εργασίες του συνεδρίου.
Πολύ. We'll continue with Mr. Tassos Gaitanis, General Secretary of Research and Innovation.
Κύριε Υφυπουργέ, κύριε Πρίτανη, κυρίες και κύριοι καθηγητές, αγαπητές και αγαπητοί συνάδελφοι, αξιότιμε κύριε Ευλάμο, κυρίες και κύριοι, θέλω να ευχαριστήσω για την πρόσκληση να συμμετέχω στο συνέδριό σας, αλλά και να σας συγχαρώ για αυτή την πρωτοβουλία. Είναι ιδιαίτερα αξιέπαινο, κύριε Ευλάμο, ότι μιλάμε για το 6ο συνέδριο. Πολλές φορές στην πατρίδα μας ξέρουμε εμείς οι ερευνητές, γίνονται προσπάθειες, γίνεται το πρώτο συνέδριο, γίνεται το δεύτερο συνέδριο, κάπου εκεί σταματά. Το γεγονός όμως ότι υπάρχει 6ο σημαίνει ότι αυτή η προσπάθεια έχει βάθος, έχει ουσία και σας συγχαίρω και για τη διάθεση και για τις αντοχές σας να τη συνεχίζετε. Είμαι λοιπόν ιδιαίτερα χαρούμενος που μου δίνεται η ευκαιρία να μιλώ σε ένα τέτοιο συνέδριο το οποίο έχει εξαιρετικό ενδιαφέρον και προφανώς είναι προς όφελος όλης της κοινωνίας. Θα ήθελα να επισημάνω ότι και η δική μου ερευνητική δραστηριότητα είναι σε αυτό που θα λέγαμε τον τομέα της ψηφιακής βιοιατρικής και συγκεκριμένα στην ανακατασκευή και στην επεξεργασία εικόνων σε PET, καθώς και στην ανάπτυξη ραδιομικών και ραδιογενομικών δικτών, κυρίως για τον καρκίνο. Συνεπώς, κατανοώ πλήρως τη σημαντικότητα του συνεδρίου σας και το χαιρετίζω τόσο ως επιστήμονας, αλλά και ως Γενικός Γραμματέας Έρευνας και Καινοτομίας. Άλλωστε, το θέμα το οποίο αναπτύσσεται, όπως είπε και η Υφυπουργός, η κυρία Ράπτη, υποστηρίζεται πολλαπλώς από τη Γενική μας Γραμματεία. Χρηματοδοτούμε ερευνητικά προγράμματα, κυρίως από δράσεις όπως ο προηγούμενος κύκλος του Ερευνώ, Δημιουργώ, Καινοτομώ, ή μέσω των εμβληματικών δράσεων και επιπλέον υποστηρίζουμε ιδιαίτερα συμπράξεις στον τομέα των βιοεπιστημών, αλλά όπως γνωρίζετε το πρόγραμμα των ερευνητικών υποδομών. Τέλος, η πολιτεία μέσω του Υπουργείου Ανάπτυξης και της Γενικής Γραμματείας Έρευνας και Καινοτομίας έχει ιδρύσει σε ένα από τα μεγαλύτερα ερευνητικά κέντρα της χώρας, το Ινστιτούτο Πνευματικής. Ως πολιτεία, λοιπόν, θα συνεχίσουμε να στηρίζουμε τις ερευνητικές προσπάθειες στον τομέα της υγείας με κάθε τρόπο. Θέλουμε όμως, πέρα από αυτό, να διευρύνουμε και την παρουσία μας σε ένα ακόμα πεδίο στο οποίο ως χώρα υστερούμε και πρέπει να δώσουμε μεγαλύτερη έμφαση στο μέλλον. Επιθυμούμε να μετατρέπουμε περισσότερες ερευνητικές ιδέες και αποτελέσματα σε καινοτόμες λύσεις προς όφελος της κοινωνίας μας. Και εδώ ο στόχος είναι διτός. Αφενός, θέλουμε να αντιμετωπίσουμε τα προβλήματα των πολιτών και στον τομέα της υγείας αυτό είναι ιδιαίτερα σημαντικό για προφανείς λόγους. Και αφετέρου επιθυμούμε να ανοίγονται νέοι επιχειρηματικοί δρόμοι και που αποτελούν διέξοδο για τους επιστήμονες της χώρας μας, αλλά και βελτιώνουν, βοηθούν την οικονομική ανάπτυξη του τόπου μας. Για τον λόγο αυτό, ως κυβέρνηση, τα προηγούμενα χρόνια αναζωογονήσαμε τα γραφεία μεταφοράς τεχνολογίας και μάλιστα τώρα πολύ σύντομα βγήκε μια νέα προκήρυξη για τη δημιουργία δικτύων γραφείων μεταφοράς τεχνολογίας, ώστε να είναι πιο εύκολη μετατροπή ενός καινοτόμου ερευνητικού αποτελέσματος σε μια καινοτόμα εφαρμογή και φυσικά να μην ξεχνάμε το νομοθετικό πλαίσιο που δίνει τη δυνατότητα σε πανεπιστήμια και ερευνητικά κέντρα να φτιάχνουν εταιρείες τεχνοβλαστών και spin-offs που θα υποστηρίζουν αυτού του είδους ενέργειες. Θέλουμε λοιπόν αυτές τις δράσεις και αυτή την υποστήριξη να τις συνεχίσουμε να τις κάνουμε και μάλιστα θα αποτελούν και μέρος της Εθνικής Στρατηγικής για την Έρευνα. Πολύ σύντομα το Υπουργείο μας θα ανοίξει το δημόσιο διάλογο. Θέλω και πάλι λοιπόν να σας ευχαριστήσω για την πρόσκληση να απευθυνθώ σήμερα μπροστά σας.
To be here with you in front of you today. I would like Mr. Vlamas to remain here for the rest of the conference to watch it from a scientific view, and I want to wish for everyone here to be healthy and to be again here for the 7th and 8th conference. Good luck. Thank you very much.
Ευχαριστούμε πολύ.
Thank you.
We will finish our welcome addresses with Professor George Dedousis, Dean of Harkopio University.
Καλημέρα σας. Αξιότιμη κυρία Υφυπουργό Ανάπτυξης, κυρία Ράπτη, αξιότιμη Γενική
Good morning,
και Τεχνολογίας, αγαπητέ Τάσο, κύριε Γαϊδάκη.
Deputy Minister of Research and Innovation, Secretary General, dear professors from abroad and from Greece. I'm very happy to be here today on the opening ceremony of this conference on neuroscience and neurodegenerative diseases. As professor of medicine at Harkopio University, we teach that all genotypes have, all genomes have a reason, and during an era of population aging, innovation and research on activities that have to do with the reasons for the neurodegenerative diseases is very important. As a professor at Harkopio University, with having done a lot of work on innovation and research, we came in second on research in the country. I have great experience on research on this topic, and I am extremely honored that this conference takes place right here in Kalithea, in the Stavros Niarchos Foundation. And I wish all the best to your conference. It is a great topic, and I would like to watch it for as long as I can. Thank you very much.
Ευχαριστούμε. Moving forward, I would like to invite to the stage Professor Paul Schultz from McGovern Medical School of University of Texas, Professor Panagiotis Vlamos from Department of Informatics of Ionian University, and Thrasiboulos Karidis, CTO and co-founder of DeepCure. In the meantime, will allow me to remind you that today we're also celebrating the 10th year anniversary of Genedis 2024. As you can see, we chose to showcase this time the fact that there is a common theme surrounding our conference, and we did that by creating a brand. And as you can see, there is a common theme all around us. And it's not just because pink is my favorite color. The color palette was inspired by the hues of the brain and the skin. Also, as you will notice, our logo can be presented as an abstract visualization of the cerebral hemispheres, but also we wanted to showcase the timeless Greek spirit, which was through the Minoan labyrinth, which was the initial inspiration of the logo. Moving forward, we'll have the welcome panel and finish this. I would also like to take this time to extend my heartfelt thanks to my colleagues and supervisor from Johns Hopkins, because their support and unwavering understanding made this all possible. The Bioinformatics and Human Electrophysiology Laboratory, and a super special thanks to Professor Vlamos for trusting me and giving me this opportunity. And last but not least, the people close to me, my family. Thank you mostly for putting up with me these past few months. Hello. Thank you for being with us. I'll start with you, Professor Schultz. This is your first time at Genedis. I would also like to let our audience know that you had the chance to collaborate with the Bioinformatics and Human Electrophysiology Laboratory for quite some time now, which was established with an MOU and was significantly recognized at the Faro Summit. So how was your experience collaborating with the Greek lab?
Yeah, thank you very much. I think that prior to the pandemic, it would have been difficult to envision collaborating with folks 12 hours on the plane or 8 time zones different. But a lot has changed, and the Zoom calls and so forth have allowed us to speak together and also show each other documents, work through things. Things have changed a lot, in other words, and now collaborating from several thousand miles away is very possible. You do learn a lot about your collaborators, their sleep schedule, their work schedule, because to have 8 hours time zone difference, one of us has to pick the morning and one has to pick the evening. And, you can guess which one of us likes which of them. This has allowed us to take advantage of 2 big areas. One is the science, and as you all know, genetic, epigenetic changes are a really hot area right now. And it's allowed us to think about differences between Alzheimer's disease and the contributions, risk factor-wise, of genetic epigenetics in Greek patients versus American ones. And even in the days now where you're going to be hearing a lot today and tomorrow about disease-modifying therapies, understanding who responds to them or not, and understanding who gets the side effects or not, will be it'll be very interesting to see the genetics, epigenetics underlying that. So the science is something we do together, and the second thing is education. We're setting up and applying for grants to send American students here to Greece and vice versa. I don't think we're going to have a problem getting American students to agree to come to this lovely country to study.
I think you will just tell them how nice the weather is and how amazing the organization of everything Professor Vlamos does, and they will be sold. Thrasivule, it's also your first time joining us at Genedis, and you have quite unique experiences in both academia and industry. You were in academia through MIT, and then you went on to start your own startup. How would you advise the young researchers in our audience if they're still struggling to decide which way to go? And based on your experiences, what are the pros and cons of each of those fields?
Thank you, Konstantina, and thank you very much for the invitation. It's extremely exciting to see conferences like this happen in Greece and also organized from Corfu, where I'm actually from. Let's see, so let me briefly describe my experience. I was born in Corfu, did all my school years there, and then went to Patras, took my undergrad degree in electrical and computer engineering, and then I was at MIT in Boston working on molecular biology. It's a very diverse topic. And around 2018, we decided with a lab mate to pretty much abandon our PhDs in the middle of or almost finishing them and start our own company, DeepCure. It was a great decision, I think, because DeepCure now is a pharmaceutical company working on inflammation and autoimmune therapeutics, and we actually have our first potential drug on the way to the clinic. And we employ more than 40 people in 4 countries around the world. So I guess my first point is that it's never too late to decide what you want to do. Even if you're in the middle of your path, it's always, if the opportunity is there, it's always better to take it and do what you really want to pursue. Now, in general, I think that having the privilege to be at an institution like MIT allows one to pursue a deep exploration of a subject, to really ask hard questions, to dive into research and development cycles that could take multiple years. While, in contrast, in a startup, it's always, what results can we prove, what can we demonstrate, what's the impact that we will have in the next maybe 6 months to a year, because then you have to raise the next funds, then you have to actually prove to the world why you're working on that startup. So it's much faster cycles and very direct relationship from the research that you do to the actual deployment and impact that it will have in the society. Now, I think that my advice to young researchers would be that take your time to figure out what you want to do. Are you excited more about answering big questions, diving deep into topics, asking more questions than providing answers for most of your life? If yes, then academia is a great environment for that. If you're on the other side, willing to work in a very fast-paced, stressful environment like a startup and be very closely connected in the way that the ideas and technologies that you develop are deployed in the society, and willing to solve everything else apart from the technology, so all the societal and organizational and bureaucratic, in some sense, elements of making sure that what you developed is helping the world, then a startup might be a great place to do.
Thank you so much. Professor Vlahos, like we've been hearing all morning, this is the 10th year of organizing Genedis 2024. And for quite some time, I had a front row seat in the difficulties that surfaced. So my question to you is, how can these difficulties be identified and solved?
Let us imagine what we really wanted to have. So 10 years ago, what we are trying to have is to have a conference where we could express the research that could be developed in our country, in our labs, in our universities. This was not an easy task to do. At first, there should be people that could represent this vision, and the other is that we had to gather people from all over the world that will be top scientists and that will be eager to contribute. The second one, surprisingly, was more easier than the first one. People from all over the world and top scientists like the ones that you will meet during this Genedis came over and really embrace Genedis. So we start thinking about 3 different axes that we tried to achieve. One was the one that the General Secretariat said to have sustainability, to have a conference that will be alive not only after 2 years, but also during the period between. This was a great help from people that are contributing with the satellite events that we're doing, and it's a lot of them, and they are very open. Through that, we start building a community of top researchers that we knew, and we knew their work, and we knew how they could share this work with us at the very edge of innovation. And the second one is that this community became very friendly to us. They became friends, and between them and with us. And you will experience that in our Genedis. The second one is that we wanted to build this platform of communication of high-impact results in research, innovation, application. Also, this could be achieved. This was achieved with a different effort from our side, a different planning. This was the 2 days continuing presentation of keynote lecturers. We have 49. It's a huge number, and it's one after the other. They are speaking through panels. They are giving the best of their work, but it's a continuous presentation of excellence through the conference. The third axis, was to make the impact of the results applicable in society, and of course the Greek society, which needed the most. This was very important for us, and it came as a gift through Professor Liketsos and the Hellenic Initiative of Alzheimer disease that really has an impact in our society in Greece. And the second one is promoting the research to new researchers, and this is what we are experiencing now with non-expecting attendance with full room. Thank you.
Thank you. Back to you, Professor Schultz. So I've been talking with our audience and the young researchers, and a question that always keeps coming up is that of funding. So, but it involves everyone, not just young researchers. Established researchers also always are struggling and trying to apply for grants and funding, and you have vast experience on this field. So, what are the tips I would ask for young researchers and also established researchers?
Yeah, I think those of us in the room with gray hair have figured out a lot about how to get funding. And so most of what I'll say briefly will be for the younger folks. I was having a conversation with a colleague last week after a meeting, and we were talking to a student who was asking us exactly that question. And she said to him, you know, in my first 2 years after being a postdoc, I applied for 10 grants, and I only got 2 of them. And she was making the point that when you first start out, it's tough to get over that threshold. And I thought to myself, oh my God, 2 out of 10 is not bad when you're first starting out, honestly. So number 1, it is difficult, but you get over that threshold. Number 2, if you don't apply, you definitely don't get funded. Number 3, stick to it. It will be challenges along the way that you'll learn from. Number 4, get advice. To this day, when I talk to other colleagues, I'm constantly shocked by the thoughts that they come up with that I hadn't thought about as an angle. Number 6, collaborate with people. None of us has the expertise for everything now, and so when a clinical translator, translational scientist gets together with a bioinformatics guy, all kinds of things happen. There are no written rules about writing grants, and so you learn as you go, and by taking all these points into account, oh, and one other is, this is often one when people start out, remember that when you get your criticisms back from the reviewers, number 1, have a really thick skin. My skin is so thick it's hard to get through the door right now because I've been through the school of hard knocks. So you always want to say, hey, that was a great idea by the reviewer, and this is how we've incorporated it into our revised grant. All of those, plus many others, I think, are the secrets to getting and maintaining funding.
Thank you so much. You mentioned collaboration, and I would also would like to point out that Genedis also strives for multidisciplinarity, and this is evident from our sessions. We don't have only computer science or only biology. We have so many different sessions because we understand that this collaboration is necessary. Thank you. Terzivule, I would like to ask, because you were just explaining to us your unique experiences, how do you think such unique experiences will benefit Genedis?
Definitely, and I have to start by saying that I feel very happy that you pronounce my name properly. It's very rare in all of the conferences I've been to. Let's see, so one of the big pieces, I think, is the interdisciplinarity, and this is kind of in the DNA of the company that we started. We're almost equal computer scientists, machine learning scientists, and computational chemistry scientists, and biologists, pharmacologists, and all the people you need to make a drug. And I would love to share more about that experience and how do you build an organization with equal attention to both parts. The second piece is that, and I will focus on that in my talk, is there's a lot of hype about artificial intelligence, and it has clear applications in many domains in our daily lives, like face recognition or asking Siri to do something, but it's not clear yet what would be the impact on drug discovery. And I think that it can have tremendous impact, but we need to add the AI to the creative process that includes the human in the loop. And then the final piece, actually, I'm extremely excited to learn about the opportunities around neuroinflammation. Our drugs, the drugs that we design, are actually brain penetrant, which is one of the characteristics that we're really good at optimizing for. And more and more, it's been proven that inflammation is behind a lot of the diseases related, the neurodegenerative diseases, especially combined with aging. And I would love to share a few of our recent results and then hear about opportunities in the neuroinflammation space.
Thank you so much. We're really looking forward to your talk. I would like to conclude this panel with a final question to you, Professor Vlahos. And how would you describe these past 10 years from a holistic perspective?
For me, wonderful. It's a pathway, a really pathway that gives us new direction in what we do in research, and makes our work in our lab, in our universities, gain more significance for its application. Its application to new researchers, to communities, to the world, to collaborations. But the main thing for me now is when we are going better, to be the best, but with new persons and new ideas. It's time that the persons step back, the ones, and new collaborations from our lab take the lead, as you did, the organizing committee, and incorporating new ideas, innovation ideas inside Genedis. This would be my hope and my thought for the future. And also, I wanted not to be the one to conclude this panel, but you.
No, you did this to me last time. We agreed.
I always do a reverse question to her, and she does not know about it. So, saying all this, it's not me to describe what we expect, but the new researchers that we produce, we have in our lab and in all this collaboration. Konstantina was at the second Genedis in 2016 with just a talk. And after that, she came to Toronto in 2018 and helped hugely in the organization problems that we faced there in another continent with success. And slowly having the science and the excellence in science inside her, she finished his PhD, he's a postdoc at Johns Hopkins University, and now the chair of the organizing committee. So I would like you to conclude how Genedis can be thought by young researchers as you.
I can only say that the past 8 years of my life, I've been counting them by Genedis. So it's Genedis 2017, Genedis 2018. But no, in all honesty, it has been great because, like you said, this conference kept growing, and I grew with it. So from 2016, when I was just an undergrad, now I'm doing my postdoc to Johns Hopkins, and in all honesty, I owe a lot of things to you for what you did for me in my career, for all the skills that you taught me. And I am only saying this because you made me say that backstage. Thank you. Thank you very much. So I would like to invite Professor Liketsos and Professor Skarmeas to chair the next panel with Professor Roserbeck, Professor Burhanola, Dr. Kani. Thank you.
Next.
Good morning, everybody. Boy, this is a finicky mic. So I just wanted to add a couple of comments and then get into the panel itself. I think Genedis exemplifies how the vast majority of major advances come at the interface between fields. And by its nature, Genedis is an interface organization that has been incredibly successful. And it's Genedis lives all the time. So even though we get together in every couple of years and have this sort of wonderful meeting, there are a lot of satellite events and other activities that are happening throughout the year. But another thing I would like to do is I don't think we have all adequately appreciated the work of Kostadina Skolariki, who has really done an amazing job pulling this together. The view, the people, the food, everything. So Kostadina, where are you? Thank you. So this panel is going to be very practical, and as you will see, it will be at the interface of many different fields. It has to do with treatment development, brain imaging, application of complicated protocols in the real world, financing of healthcare, especially very expensive drugs. So I think it'll be very interesting in that regard. So the number of people living with dementia and their caregivers is growing rapidly worldwide due to the aging of the world population. And therefore, dementia is considered the next pandemic. Finding effective disease-modifying interventions for dementia, in particular its most common cause, what we call the Alzheimer brain disease, has been a huge challenge because the disease is complex and because there are many pathways to dementia. It's not one disease. The last several decades has focused on the amyloid hypothesis, which postulates that accumulation of beta amyloid protein is the starting point of cascade that eventually leads to hyperphosphorylation of tau, neuronal death, the triple complex of cognitive decline, neuropsychiatric symptoms, and functional losses, following eventually by the loss of the person, which in Greece is now the fourth leading cause of death. Efforts at using monoclonal antibodies, the euphemism we use are MABs, so if you hear the term MABs much today, using MABs to remove beta amyloid from the brain have been quite effective. And in fact, based on that capability, drugs such as lecanemab, donanemab, previously aducanumab, have been approved by the US FDA for use and similar authorities in many other countries. Despite being highly effective in removing A beta, these medicines are associated with very modest clinical benefits, and you will hear those quantified in a moment, when administered to patients with early symptomatic phases of the disease. Yet to be seen what happens in earlier phases. They also carry significant risks. You will hear about this new term, ARIAs, which has nothing to do with opera, but ends up being the bane of those who prescribe these medications. This symposium was originally planned when we anticipated that the EMA, European Medicines Agency, would approve lecanemab for use in Europe, but that unfortunately did not happen. The EMA rejected the application for lecanemab approval. There has been an objection put forth from the company, and we'll see, but right now the fate of MABs in Europe is, believe it or not, unsure. Despite this setback, the approval is a fact everywhere else, and it has to be considered at the very least because we have to learn a whole lot more about the use of the meds. So for one, it appears that many patients benefit from their use, and it appears that many patients have relatively low risk, and so we'd love to know who benefits and who has minimal risk so that we can focus treatment on those individuals. And this could be the final either nail in the coffin or big success, is these therapies are now being applied to pre-symptomatic individuals. People who have a lot of amyloid in their brain based on a biologic study, who are asymptomatic, are followed for many years, treated either by lecanemab or a placebo. And the question is this going to change the trajectory so that we ultimately have a preventative therapy? It's possible, and I think that's going to be the most exciting opportunity if it really happens. So today's panel is a first effort at having these discussions for Greece, with a hope and anticipation that approval will be forthcoming in the not too distant future. The panel has several presentations. Professor Skarmeas from the University of Athens will provide overview of Efficacy. Professor Rosenberg, one of my colleagues and partners in crime for the last 2 decades at Hopkins, will be talking about arias that he often sings in his sleep. And we will have a detailed look at the practicalities. I think what gets me is how much time I am spending right now in intervening and monitoring for 5 patients I have who are on these, just takes a lot of time and effort because of the complexities of monitoring for safety, and Professor Borhanela, also from my team, will be presenting. Ultimately, though, I'm looking forward to hearing from the expert in approval and financing, Dr. Khani, sorry. So our goal is to complete the presentations efficiently because we're hoping to have a good discussion, whether it be within the panel or more broadly, about the hopes, promises, and concerns regarding these monoclonals. And when we get to the Q&A, which hopefully we'll have a full hour for, I'll provide some structure by putting up a slide to sort of lay out the issues that will need to be sorted out before these meds, at least under current knowledge, are applied in Greece. So thank you, and let me turn it over to Professor Skarameas, Nico.
So thank you, Costa, for the introduction. It's a full crowd. It's my first time in Genedis as a physical presence. There were some online participations in the past. So I will talk about efficacy. I think I will skip the safety part because I think Paul will continue with the safety, and it's important to be on time for the discussion. So this is let me just make sure. I'm trying to sorry. I'm trying to check with the pointer. Ah, great. Okay, so let me go back for a second. Can I control it from here? Maybe some technical, so maybe if you can try to help me control it from here, okay, great, now it works. Okay, so I will talk about 3 different monoclonal antibodies, and then I will have a few slides on cost. So let's start with the aducanumab, developed by ASI and Biogen. So this is the main publication that dealt with this particular drug. So let's start with the biological effect. So, not everybody is a technical expert here. So what you see here is the PET scan of the brain of a person that has Alzheimer's disease. So what you see here in red is the deposition of amyloid. So although there are scientific debates in the field, most people believe, that's the predominant theory, that the amyloid is one of the main culprits for this disease. So what happens is that there is a protein, the amyloid precursor protein, that breaks down into small fragments, peptides. And then these peptides, they become from monomers to dimers, trimers, oligomers, polymers, and then into protofibrils and fibrils, and at the end, they collapse into plaques, and they create these red signal that we can see in the PET study. So this is the main hypothesis for the disease. So what these medications do is they bind to the amyloid, different stages of the amyloid accumulation. So in the case of aducanumab, it binds to fibrils, so a little bit before becoming plaques. And this drug is given intravenously once a month. So this is what it does to the amyloid in the brain. There were 2 different studies here, the EMERGE and the ENGAGE. They showed similar effects. So this is the placebo in gray, and these are 2 different doses of the drug, of aducanumab. And what you can see here is the levels of amyloid drop during the course of the study. So what essentially the drug does, it takes away the amyloid from the brain. And it's very clear that this is the effect of the other drugs too. What about the clinical effect? There were 2 studies, as I mentioned. So what happens with this drug? There was a change in rates of cognitive decline. That's what this CDR sum of boxes indicates. But there was a change only in one of the 2 studies, not in the other one. So one study fulfilled the primary outcome, the other did not. So there was a biological effect, but it's not clear that there was a clinical effect. At the end, the drug was approved to go to the market with this name, Aduhelm. And if you want to know more about the drug, in the committee, in the American Academy of Neurology, we created a summary of the efficacy, of the safety, and all that. But I'm not sure how useful would that be, because the drug, I just want to say that it got an accelerated approval. So there are two different approval pathways in the United States, in the FDA. There's this accelerated approval that is for severe diseases and that requires that the drug has some sort of biological efficacy. So in this case, the aducanumab removed the amyloid from the brain. So it's not the full approval pathway where the clinical efficacy is required. And the aducanumab did not receive full approval because, as I said, one of the two studies was not positive. But at the end, because of all these discussions in the field and there were questions, the company decided to remove the drug from the market. Okay? But, a number of patients received it, and it was the first drug approved, and it's the mechanism of efficacy, the mechanism and the efficacy that are important because it was, in a way, the prototype for the drugs that follow. So lecanemab is the other drug. Clarity AD was the big study that reported these, that reported the findings. It was initially developed by a Swedish startup company, the BioArctic, and then it was taken by ASI and Biogen. So this particular study included participants with a broad age range, 50 to 90. They had to have some cognitive deficits, but not that many. Mini mental status examination for those that are using it, 22 or more, and they had to have memory deficits. So going into the biological efficacy, similar slide like before. So lecanemab binds to protofibrils. So at a stage of amyloid aggregation, a little bit before what we saw for aducanumab. And it's given intravenously twice a month. So this was the effect of lecanemab in removing amyloid from the brain. You can see it's very similar to what we showed before. You can see actually in the pictures, here's a placebo participant, and you can see the yellow-green color is the amyloid, and from baseline to follow-up, there's not much difference in the amyloid accumulation, and here is a lecanemab participant. You can see how during follow-up, the color changes, and it's because of the removal of amyloid plaques from the brain. What about the clinical effect? This was the main clinical effect of this drug. This is the scale that includes cognitive but also some functional elements, the CDR sum of boxes. And what you can see is that in the placebo arm, there was a decline, but there was also a decline in the lecanemab arm. There was a difference of about 30%. So what lecanemab does, it slows down the rates of cognitive decline. It does not improve, it does not stabilize. There's a lot of discussion about that, and maybe we can touch on it during the next stage of the discussion. So it is available in the US under this commercial name, Leqembi, since the summer of 2023. So it's a little bit more than a year that it's available, and a few thousand participants have received it. We do not have clinical experience, but I'm sure in Hopkins they do have some clinical experience, and they can tell us about this. And here's the third drug, donanemab. Trailblazer were the studies that looked into its efficacy. It's by Eli Lilly. It's produced and marketed by Eli Lilly. So the study was not very similar to the Clarity study. I didn't tell you about that, but it's a time that I can tell you now. So it's about 800 to 900 participants in the placebo, 800 to 900 participants in the drug arm. Similar design we had in the study for lecanemab. So the biological effect, this binds to the amyloid plaques a little bit later in the amyloid cascade compared to lecanemab, and it's given intravenously infusions once a month. So So it was quite effective in removing amyloid from the brain. You can see here, this is the phase 2, but you can focus on phase 3. I will explain later why we have 2 graphs here, but essentially half the participants that received the drug had the removal of amyloid from their brain 1 year later. So actually these participants stopped receiving the drug because it was part of the protocol, so because it was not thought to be necessary to continue on the drug since the amyloid was removed. What about clinical effect? There were a couple of differences in this particular drug. So one is that to be included in the study, you did not have to have only proof of presence of amyloid in your brain, like in the drugs that I showed you before, but there had to be some measurement, some assessment of the tau levels in your brain. So the tau is the other culprit in this disease. I guess the prevailing hypothesis is that, you know, there's accumulation of amyloid, and at some point this amyloid in the brain triggers the accumulation of another substance, tau, the tau protein. So here you had to have both amyloid and tau in the brain, and we had a quantification of the tau levels. And the main, the primary target of the brain was those people that had amyloid and not very high accumulation of tau. So in theory, the drug was supposed to target better those in whom the tau had not accumulated to a larger degree, so they were somehow in an earlier biological stage of the disease. But also there were some people with higher tau accumulation in the brain. So in terms of the primary outcome, in the low tau group, there was a 35% slowing of the rates of clinical decline. They had the CDR sum of boxes, but they had also another scale that combines clinical and some functional measures too. So the clinical effect was not very dissimilar to what I showed you for lecanemab. This drug is available in the United States with the name Kisunla since the summer of 2024, so it's available for a few months. So I just want to remind to everybody who is the drug, who are these drugs targeting. So we have what we call age-related cognitive decline, normal for age, and then at the other end of the spectrum we have dementia, and dementia could be of mild, of moderate, or of severe stages. And then in the middle between dementia and age-related cognitive decline, we have this gray zone, the mild cognitive impairment. So these drugs target either mild cognitive impairment patients or dementia patients, but of the mild, of the initial, of the early stage. So they do not target advanced dementia patients, they do not target normal changes for age. So I have a couple of slides about cost, which may be an introduction to Hara's presentation later on. So there are concerns about the cost. So lecanemab, I think, has been marketed with a price of $26,000 per year in the US, without considering the extra costs of the MRI, the medical services, and all that. So we made an estimation in Europe with other colleagues about the target population, and if we apply the criteria for the drugs, we published that more than 5 million, maybe 5.5 million patients would be eligible for the drug in Europe. So if the same price was given in Europe to the one in the US, the total cost for lecanemab would be 133 billion. So that would represent 50% of the total pharmaceutical cost for all drugs, for all diseases. So it's a big population that are potentially eligible for this drug, and it's a huge financial issue, not only medical, as you can see. And for Greece, again, it would be similar. So the cost for Greece is, I think, about 4 billion per year, so it would be half would have to be consumed for this drug administration. But then there were other studies. So there was this study from Mayo Clinic that said that, you know what, yes, all these people are eligible, but if we apply very strictly the entry criteria for the study may be out of this population, finally a very small proportion would be eligible, and maybe it's an exaggeration to consider such a big population target. Many people would refuse, many people would not be eligible for other medical contraindications, so it's a very important decision. Every time we introduce a drug in the market, it's like a bookshelf, maybe another drug or some other cost of the healthcare system has to be reduced, so the money is not, there are limits. So I'm finishing with this slide. So just to give you an overview of where we stand in terms of approvals. So lecanemab is approved, fully approved in the US, and it's also approved in Japan, China, Israel, and the UK. And there are pending applications in these countries. Donanemab is approved in the US. In Europe, lecanemab has been rejected. There's an appeal process. We will learn by the end of November whether it will be a final rejection or not. Donanemab will be judged by the EMA in the beginning of 2025. So this is where we stand in terms of approval. So we enter this area where, like in rheumatologic diseases or multiple sclerosis, immunological therapies may be useful for degenerative diseases like Alzheimer's diseases. I have to remind you that the most recently approved drug for Alzheimer's disease was 2003. So we have more than 20 years without approved drug. So it's the first therapeutic success with its limitations, but it's a success after 20 years. And like we did for COVID, why not for dementia? And we have, I think with these results, we have a lot of hope for the future, and I will stop here. Thank you.
Hello. Thank you, Nico. Wonderful talk, terrific summary as always. We'll hold off on individual questions, so hold your questions for later. I'd like to introduce Paul Rosenberg. Paul is Professor of Psychiatry and Behavioral Sciences at Hopkins. He's been running our clinical trials and dementia program since 2006 and has done an incredible job. So Paul, tell us about ARIAs.
Kalimera. That's 25% of the Greek words I know, so I use it a lot. I'm really honored to be here in front of such an esteemed group of professors, industry professionals, students, my friends and colleagues from US, and it's very happy to see the leadership of leaders from the Hellenic Republic. I'm going to talk about ARIAs. Sorry, I've got the date wrong, but I got the facts right, I think. And they definitely represent a challenge. Usually you flash over the disclosure slide, but what I want to mention is mostly what I'm disclosing is consulting to industry. I'm either consulting before they start a study on study design, during the study on study problems, or interpreting results. And for example, for this, I consulted to Lilly before they basically did a practice session before they went to the FDA. I'm going to talk about what are ARIAs, going to show you some MRIs, talk a little about mechanisms, risk factors, and management. What are they? Amyloid-related imaging abnormalities. These are MRI changes observed during treatment with monoclonal antibodies, anti-amyloid antibodies. They were first observed with the first antibodies tested, which did remove amyloid, but were not effective clinically. So it seems very likely that the ARIAs are associated with amyloid removal. That doesn't mean you can't decrease them or find an antibody that'll have less. But you're not likely to find an antibody that has none. Most ARIAs are asymptomatic. Don't get too happy here. They still need to be managed. And in fact, the asymptomatic ones can be as important as the symptomatic. But there are rare, severe consequences. The main thing about ARIAs is they are a lot of work and a lot of cost. They require close monitoring during MAB treatment. You may have to stop treatment temporarily or permanently. Two kinds, ARIA-E, vasogenic edema. I am not a neuroradiologist. I'm a customer of neuroradiology, but my understanding from neuroradiologists is this is not the usual edema you see when you describe a brain edema. Sulcal effusions, It's best seen on FLAIR MRI sequences, and if you have the luxury of 3D, they are apparently more sensitive. ARIA-H are lobar microhemorrhages, distinguished, let's say, from basal ganglia microhemorrhages, for example, and also superficial siderosis. These are both evidence of old bleeds. They're iron deposition. They're best seen on heme-sensitive MRI sequences. GRE is the one most universally used. SWI is more sensitive. And in general, we say you can't have more than 4 of microhemorrhages at baseline prior to starting MAB therapy. This I got from neuroradiologists. I'm not an expert. They do a volumetric sequence like MP-RAGE for co-registration, figuring out regional brain volumes. They do a 2D or 3D FLAIR sequence for detecting ARIA-E. They do some heme-sensitive sequence. GRE, SWI is preferred for detecting ARIA-H. And then they usually do a diffusion sequence in the US, DWI, to distinguish acute and subacute infarcts from ARIA-E. Your minimum time in the scanner is 10 minutes. The ones we are doing for monitoring take about 30. Hey, there's a problem here. SWI is more sensitive than GRE. If you switch scanners or switch sequences in midstream, you may pick up more ARIA-H's, which really aren't new. You just didn't detect them at baseline. There's a lot on this slide, but going to. There you go. There's a lot on this slide, too much to read, but let me just say, ARIA-E, the severity of ARIA-E is largely the size of the edematous area. If you're less than 5 centimeters, you're mild, 5 to 10 is moderate, and greater than 10 is severe. ARIA-H's, it all depends how many new microhemorrhages you see, which is why it's very important to have a baseline. Less than 4 is mild, 5 to 9 is moderate, and more than 10 is severe. And sometimes you'll see a lot, like 30. And then superficial siderosis, it's the number of areas of superficial siderosis. The clinical consequences, most are asymptomatic, and of 17% with lecanemab were transient and mild, headache, confusion, perhaps vomiting, visual or gait disturbance. What's important is they're transient. They're often treated with acetaminophen, or if they're worse, oral steroids. But in general, most resolve and are not a big deal. There are rare severe reactions. The reason I don't have a number for you is industry has not been fully forthcoming about the worst consequences. We don't quite know the numbers, but that can include edema, brain swelling, and also macrohemorrhages, seizures. Kisunla associated with, I wrote X deaths because I know there's been at least 1 death from status epilepticus, but I don't know how many more. The reason I don't know how many more, this is all anecdotal. None of this is peer-reviewed and published yet. And there have been some deaths, both in the lecanemab and donanemab studies. So here are some examples. So here's a patient who at baseline had very minimal white matter hyperintensities. You can see periventricular white matter hyperintensities here. After 8 weeks of lecanemab treatment, after 8 weeks of lecanemab treatment, she reported she had headache and confusion. She had severe ARIA. Here are severe ARIA-E. Here is a huge area, 2 huge areas greater than 10 centimeters, and then here's another one. So 3 large areas of ARIA-E, and they resolve with treatment discontinuation. For the most part, by the way, ARIA-H don't resolve. Once a microhemorrhage, always a microhemorrhage. And that's why with ARIA-H, you take a careful count at baseline. The usual standard is no more than 4 at baseline, but you need that baseline number so you know how many new ones you have. There's a 68-year-old white male on lecanemab. Where am I? Where's my point? Where's my pointer? Oh, well. Had mild temporal lobe atrophy at baseline. Not quite sure how mild that is. I would see it as pretty marked. And a surveillance MRI that was done as part of routine clinical care showed a sulcal effusion. I'm sorry, can I get this thing to work? Here's a sulcal effusion. That's an RAE. Not very large, not very impressive. You better know your neuroradiology to find this. Superficial siderosis, you see the dark area here? That on a heme-sensitive MRI. But there aren't any microhemorrhages. And she was asymptomatic. Treatment was continued. I'll show you the algorithm in a minute. You can see when we stop it. And at 7 months, the RAE was resolved. It's gone. Notice the superficial siderosis is still there. RAH is like love. RAH is like love. It's forever. But this is an example of a mild ARIA. So I showed you a very severe one. I showed you a very mild one. Potential mechanisms, we're just in early times for this, and it's actually very important because if we're gonna prevent them or treat them or reduce their frequency, it'd be nice to know the mechanisms. In general, I'm waving my hands, which means we don't know the answer. In general, people have been leaning toward an inflammatory response caused by the loss of vascular integrity and impaired clearance with an immune response in the vessel wall. And the thought is that it transiently weakens the vessels or the blood-brain barrier and leading to extravasation, basically, of fluid and blood. It can lead to edema. It can lead to hemorrhage, depending on what extravasates. The most important thing, I think, for clinicians are the risk factors. Well, the main one is anti-amyloid therapy. It's been observed with all agents in this class. I'll show you some numbers in a minute, but they're all, it seems like the more effective agents have more ARIAs, but we'll get to that. The presence of an E4 allele definitely has increased ARIAs for all the agents studied. For example, for donanemab, E4 homozygotes had a 55% incidence rate during their trial. More than half the patients had an ARIA during the trial. That's a lot, and that's a lot of monitoring. Anticoagulant use, it's an important issue for lecanemab. So far does not seem to be an issue with donanemab, and platelet inhibitors do not seem to be an issue. Baseline microhemorrhages, and the last two bullets here go together. Cerebral amyloid angiopathy is considered a strict contraindication because of an increased incidence of intracranial bleeds. It should be noticed that the bleeds from CAA often resemble ARIA-H, and so it's considered a pretty strict contraindication. There's a real worry about brain bleeds. So MRI exclusions, baseline exclusions, more than 4 microhemorrhages or a large microhemorrhage greater than 1 centimeter, an area of superficial siderosis or evidence of vasogenic edema. Then we get a little more complicated. How many strokes do you allow at baseline? More than 2 lacunes or more than 1 large stroke? And I think the hardest one, because this comes up a lot, is severe subcortical hyperintensities consistent with a Physicus score of 3. I can buy that because it's not just a matter of risk. There's a theoretical risk of increased bleeds if you have a lot of vascular brain damage. More importantly, if your Physicus score is 3, perhaps your memory problems are not from Alzheimer's, perhaps they're from vascular pathology, and the drugs may not help. Lecanemab, too much information on this slide, but let me, nope. Let me call your attention to these two rows here. On lecanemab, we've made it work. Yeah, it's my, there we go, and thank you. Thank you so much, Nick. Just want to point your attention, the rate of ARIA-E on lecanemab was 12.6% versus 1.7% on placebo, and the rate of ARIA-H 17.3% versus 9% on placebo. There are plenty of ARIA-H's on placebo. There are just more on drug. And they are more frequent with the presence of ApoE4. So in terms of all ARIAs, if you're a homozygote on lecanemab, you have 33% chance of an ARIA. Only 3% of the ARIA-Es were symptomatic, but almost 10% if you're an E4 homozygote. So E4 alleles definitely increase the risk. Donanemab has a lot more ARIAs. Not quite twice as many, but at least 50% more. The rate of ARIA-Es 24%, ARIA-H 31%, and the rate of symptomatic was also pretty high. There were 3 macrohemorrhages on donanemab and 2 on placebo. This was in their FDA registration trial. And the main thing about cerebral macrohemorrhages is to avoid giving to people with cerebral amyloid angiopathy. I've been fortunate enough to work with Steve Greenberg at Mass General Hospital, who, to make a joke, basically invented the criteria for CAA. And it actually can be kind of subtle. There are a lot of criteria. But in general, a rule of thumb is no more than 4 microhemorrhages at baseline. Management. Asymptomatic moderate ARIA can be managed by oral steroids. You may need to go inpatient. But symptomatic moderately severe ARIA probably needs some inpatient admission. They all need additional MRI scans for monitoring. Much of the cost and much of the work of giving these drugs is the MRI monitoring. Here's the schedule for lecanemab, and you'll see you need a baseline MRI, and you need them at the 5th, 7th, 14th, and sometimes at a year. So that's a lot of MRI scans. And for donanemab, you even need 1 more at week 4. It adds to cost, it adds to inconvenience, and also makes it difficult to give to patients, for example, who have pacemakers. You don't have to read this whole slide. I just want to show you the general layout. Symptomatic ARIA, you generally have to suspend treatment, repeat MRI monthly until things resolve, and you may or may not resume treatment depending on how severe they are. You stop treatment permanently for any macrohemorrhage and for basically severe MRI evidence and for more than 2 episodes of ARIA. And then for asymptomatic, you do not have to suspend treatment unless they meet certain severity criteria. It should be noted in the donanemab study, I was very struck. One of their deaths was a patient who had 3 episodes of ARIA and died of a hemorrhage on the third episode. And I was very struck. If my patient had 2 episodes of ARIA, I'm not going to give them more drug. So I think it's an important caveat here. And TPA, there was at least 1 death in the lecanemab study from TPA. So it's considered it's contraindicated to give TPA. So the take-home lessons. They are fairly common adverse events associated with MAB treatment. They occur independently and sometimes together. They are associated with E4 alleles, with anticoagulation, and with baseline microhemorrhages. They are mostly asymptomatic and mostly a nuisance and a worry. But on rare occasions, they can be serious. Strategies for management include prevention, intensive monitoring. That's a lot of MRI scans. And in many centers, that's the limiting factor for how many patients you can have on drug. In my opinion, these adverse effects are significant, but they are not daunting. And I think the most important part of this is disclosure. I think the informed consent process needs to be repeated so that patients and families have time to think about these risks and weigh them against the benefits. The reason I put the references in here, the first one in the Korean Journal of Radiology is where I took the scans from. It's an excellent review of the MRI findings. The second one here with Jeff Cummings as first author are the appropriate use criteria, which are which is what we follow at Hopkins, and the publicly available slides from Asai and Lily. Thanks to the Genedis organizers, to my close friend and colleague and boss, Kostas, to Nick, to Haroon, and of course to Dr. Skolariki. Thank you very much.
Thank you, Paul. Great job laying out the issues, and hopefully, as you think about what you just saw about ARIAs, we can come back to them in the discussion. Our next speaker is Haroon Burhanallah. Haroon is an assistant professor in our department. He has single-handedly taken on a very complex program for MAB administration at Hopkins and has done very well. My colleague and friend Justin MacArthur, the chair of neurology, every time I see him, he says, don't ever let Haroon go. We need him. He's terrific. So Haroon will tell us about the complexities of the administration, all the way from informed consent. And we'll give you some numbers from our experience. I think it's the first time you're showing our numbers publicly. So you'll get a feel for about 8 or 9 months worth of where we are with using these meds. Haroon.
Hello, everyone, and thanks for inviting me. And I'll start with our Johns Hopkins experience. So we started using the Johns Hopkins, the lecanemab as soon as this was approved by FDA. We started to set up our program. As we've already discussed, this drug was approved by FDA in August 2023, last year, July 2023. So the first thing we did was to set up a task of setting up the infrastructure. So setting up of infrastructure, basically in my slide, in Johns Hopkins experience, I will talk about 3 specific things. Number 1, setting up of our infrastructure, Johns Hopkins patient experience, and the third thing is that what we are doing is expansion, monitoring, and operational management. So I break my slides into these 3. So infrastructure of lecanemab or monoclonal antibodies, quite complex, labor-intensive, and tedious. So initially, when we set up the infrastructure, what we did was we set up our monthly meetings. There are 2 or 3 things to keep in mind, especially 3 things to keep in mind when setting up the infrastructure. What we did was, one is the regulatory, assignments. The second one was logistical, and third thing is educational. So when we did this, the first thing was that this drug was not on formulary, at Johns Hopkins. So we brought this drug on formulary by going through pharmacy and therapeutics committee. Every hospital has a P&T committee, so we set up that. It goes through different steps of committees, and finally the drug was approved by our Johns Hopkins committee. And similarly, I wanted to tell you that our Aduhelm, previous medication, the first medication which Nicola discussed, that was not approved. So this is the first one that was approved back in November 2023. The second thing was, logistical setup. So we set up our infusion centers, we set up our, MRI, and we developed an MRI protocol called ARIA protocol. This protocol was specially developed to detect the ARIA-E and the ARIA-H. Usually it takes about 45 minutes to get an MRI, but because of the volume of MRIs are so much, each patient required a minimum of 5 MRIs, 1 as a pre-infusion and 4 during monitoring. So we shortened the duration of it, but made sure that the MRI ARIA protocol is detected by FLAIR and SWI for sequence weighted imaging, which Dr. Rosenberg has earlier discussed. The second thing that that we did was developing education all around, making patient education document so that patients can make an informed decision, know about the risks, benefit, side effect profile, and then make a decision on this drug. And then, at our Hopkins protocol, there are a number of providers, number of physicians from different specialties like neurology, geriatrics, and geriatric psychiatry. So we developed a provider education model through Johns Hopkins. We have a weekly memory clinic, and as well as we developed a protocol So this protocol helped a lot in guiding us on what steps to take when choosing the patient. Then, the next thing what we did was, nursing education, nursing staff education was extremely important, because this type of drug was the first one to get approved, and nobody knew, what were the side effects. Will the side effect be at the time of infusion, or will they have side effects afterwards? So this drug does not usually have side effects, except for infusion-related, some minor side effects at the time of infusion. But majority of these ARIAs, they develop later on, around third month to 7th month during the 18-month treatment. Then also we did, education of the ER physicians, because they were also not aware of what type of side effects these patients will come through. So, and when the patients come, usually CT scan is done, CAT scan is done in majority of hospitals to rule out stroke or bleeding risk. But, we informed the hospitalists, the ER physicians and the hospitalists, that these patients will require a specific MRI sequence, and they'll tell you that these patients are on lecanemab. So this was done. So the resources involved were quite intensive. We have, first of all, the infusion center set up, the neuroradiologist, which is the core, member of, monitoring the patient side effect reporting line. So we gave them a number in case if they have side effects, they can actually call the memory clinic number, and then from there, the calls will get redirected. And a physician monitor, which I was monitoring with the committee, leadership committee. So the next thing was, getting this drug approved by the insurance. Medicare came up with the approval soon after traditional approval of lecanemab. As we know, the US has a very complex landscape of reimbursement. So initially only the drug was approved, infusion was approved, but amyloid PET scan was not approved. So in order to determine in order to determine the amyloid status of the patient, we initially did only CSF biomarker, CSF analysis to detect amyloid for the first 6 months. And then later on, it was approved in December 2023. And so in the earlier patients that we had, majority of them had a CSF analysis done. So the first infusion at Johns Hopkins was on January 31st, 2024. And since then, there have been, infusions, multiple infusions. Each day we have a capacity of around, each week we have a capacity of about 15 patients. So we have 4 infusion sites. We expanded. First, we started off at Howard County. But when the final approval came for all the sites, so we have now 4 sites for infusion, and there are 6 MRI facilities, but all within Johns Hopkins campuses, And some of these MRI facilities can do an urgent MRI because they open from 6 a.m. to all the way 11 p.m. at night. So this was an amazing help from a neuroradiologist group that they allowed us to have patients do a urgent MRI. So when the decision was made to institute this drug, we decided that each patient should get a pre-infusion visit after the decision was made that this patient qualifies. This pre-infusion visit was on the request of our infusion center or on the request of our billing department, so that all the information, because just to make a decision whether a patient meets criteria, meets criteria, and looking all through the chart will be very labor-intensive work. So this pre-infusion visit tells us or delineates the patient's amyloid status. We also make sure that the patients who are getting the drug are on the mild stage. So the QDRS score is what we use. Consent, we went over the side. We usually go over the side effects of this medication again, the patient. With this pre-infusion visit. Then we have Medicare registry in the United States that pays for this drug. So we set up the Medicare registry on this pre-infusion visit, and then go over some of the educational material and answer any questions that the patient has. So this pre-infusion visit was something that we set up on the request, and then I developed this, at Johns Hopkins. Now, I'll move on to the patient experience, which is the second part, as I said, after developing setting up the infrastructure. So we have currently 40 patients at Johns Hopkins. So to start off, we have 68 patients were amyloid positive from July last year to now, that we have got 68 amyloid positive, but 18 patients were excluded because of some of the MRI findings, because of being on blood thinners. And some of these findings were only barely 3 or 4 or 5 microhemorrhages, but after going over the risks versus benefit, the patient decided that they won't do it. So 18 were excluded there. We have 10 patients out of the 68 who are ApoE44 homozygous. So ApoE44 was not a contraindication, but FDA has recommended to use caution. But at Johns Hopkins, we decided to exclude those patients where the risk factor was extremely high for bleeding. So then we were left with 40 patients. At the moment, we have 40 patients. We're getting infusion. There were 2 dropouts, I'll tell you in a moment. So the decision of lecanemab, choosing the right patient, was extremely important. So this patient should be on mild cognitive impairment stage or mild dementia stage. I'm not going to repeat some of the things that has already been done. Something that our Johns Hopkins specific recommendation was, instead of doing the CDR sum of boxes, which is quite labor intensive, we decided to do this QDRS, Quick Dementia Rating Scale. And it's available on, you can Google it, it's QDRS, it's available without copyright. And the QDRS score of 2 to 8 was considered mostly in MCI or early mild stage. So we considered that. And this, in terms of staging, amyloid status can be determined by amyloid PET or CSF. Then patients who have TIA or stroke within the last 12 months were excluded. They were excluded in the trial, and we also excluded them. Any non-AD neurological disorders were allowed there, but were not allowed at Johns Hopkins, except for meningioma. All tumors are excluded. Meningioma, if it's stable, you can have patients give infusion on patients who have meningioma, but otherwise, everybody else who has a brain tumor or any other brain disease like multiple sclerosis, they are excluded. Anticoagulants, we decided not to choose because there were 3 deaths related to, mostly all 3 were related to anticoagulants, either because of TPA, because of being on Eliquis. So those anticoagulants were excluded. But patients still can have aspirin and Plavix, which is the antiplatelet agents. ApoE44 homozygous was also excluded at Johns Hopkins. And stable medical condition. I'll talk a little bit about just the medical condition. The only specific thing that you may need to know, that patients who are on any MAB drug for any other systemic disease, for example, rheumatoid arthritis, psoriasis, Crohn's disease, they are excluded to get this lecanemab or even donanemab, because patients cannot have 2 MAB drugs at the same time because they compete for the same epitope, and hence it reduces the efficacy of the other. So that's why it's not used. So this is our patient demographics. I haven't shown this file to anyone before, but this is our patient group. So 71, our mean age is 71 years. Majority of them are Caucasian, about 90%, 89%. We have a little bit more female here, 52% in our cohort. Almost 60 to 70% of our patients have college education, 4 years of college education. Now, in regards to breakdown on ApoE status, We have E4 heterozygous, meaning E3, E4, which is about 60%, and we have non-carriers, which is 40%. So we have a pretty clean population of no E4 homozygous. And then, as I mentioned earlier, that majority of patients in the first 6 months had CSF analysis done because PET scan was just approved last year in December. So we have 57% patients who have CSF analysis, but now more recently, most of the patients are getting the amyloid PET scan. So these are a little bit of some of the comorbidities in our patient. So about 22 patients out of the 40, which is 59% of our patients have hypertension. Controlled, most of them have controlled hypertension, majority of them have. Anyone who has uncontrolled hypertension is an exclusion. Anyone who has uncontrolled hypertension above 160 for an extended period of time. So we have those 59%. Diabetes is about 18%, and chronic kidney disease is about 27%. Please note this chronic kidney disease is stage 1 or stage 2, and at times stage 3. So we have not, although we have not excluded in our lecanemab group stage 4 and stage 5, but in our donanemab group, stage 4 and stage 5 will be excluded because advanced kidney disease can also affect memory, and hence, it also can affect some side effects. So especially like delirium. So we decided to exclude in donanemab. So we have 5 ARIAs in our cohort. Please note that none of these ARIAs are symptomatic. All of them were asymptomatic because we have 2 ARIA-E and 2 ARIA-H, and one patient has both ARIA-E and ARIA-H. Both the ARIA-H, which is the microhemorrhage, were in the moderate stage, and both ARIA-E were in the mild stage. One was in mild stage, one was in moderate stage, ARIA-E. So the characteristics of these patients were, if you note that about 40% of these patients had chronic kidney disease. I'll go to the next slide, but 40% of these patients who had ARIA had chronic kidney disease. They were a mix of heterozygous for E4 and non-carriers. There were 2 patients who had, one patient had meningioma, 1.7 centimeter, and this patient had meningioma which was quite stable, developed ARIA, but we restarted the lecanemab. So I talked to you about 2 dropouts. One of the dropout was one patient who had developed ARIA-H. Then the ARIA-H, it takes about 8 weeks for ARIA-H the bleeding to stop. But ARIA-H, you'll still see the spot on the brain, in the brain MRI. So it takes about 8 weeks. So the bleeding stopped. We gave him the infusion again, and after the infusion, the bleeding started again. So it was, second attempt for ARIA-H. So after the second try, we decided to stop the bleed. But one thing we learned during this process that ARIA-H, when it bleeds, even after you stop bleeding, it takes about 3 months to stop bleeding, because every single month I was getting an MRI report, because you have to get an MRI monthly if someone develops ARIA-E or ARIA-H. So every single month I was getting an MRI on this patient, and he kept having one new microhemorrhage until 3 months. And 3 months is also a period where patient clears 5 half-life of lecanemab. So the bleeding can happen until 5 and a half half-life. So one was, currently we have suspended treatment based on the MRI, but we will resume treatment because the recent MRIs look good. So this is number 2, 56-year-old. The second patient that has dropped out of our cohort was the patient who has advanced to advanced stage, from mild dementia stage to moderate stage, which disqualifies them. So regarding the most common side effects are not ARIAs. Most dreaded side effects are ARIAs, but most common side effects are infusion-related reaction. We have 5 patients out of the 40 who have infusion-related reaction. They were all mild. They all got better with Tylenol or Panadol. You can use it here, they were only for like a couple of hours. Majority of these patients developed chills. They had some temperature of 101 Fahrenheit, and one felt a bit, dizzy afterwards with a drop in blood pressure. And after a couple of hours, while the patient was at home, these were all, the patients are usually monitored in the infusion center for about an hour. This happened after a patient, went home, same day. So it all resolved within few hours and were back to infusion. But one developed a little bit, more side effects, still in the mild category, that lasted for about a day. And we decided to pre-medicate this patient with 1 dose of oral steroid, dexamethasone, 4 hours before the next infusion. Usually these infusion-related side effects are common in the first and second infusion. After that, majority of them do not get any side effects about infusion-related reaction. So talking about the monitoring, monitoring is everything in lecanemab or donanemab. So, okay. So the monitoring is done by the neuroradiologist and the provider himself. So it's basically when the patients are coming into a program, we make sure that patients are appropriate, as they enter the program. We make sure they're, getting the MRI, monitor the MRI schedule, and then we provide resources for ARIAs in case if they develop ARIAs. In terms of this operational management, I would like to tell smooth running of the program with strict monitoring is placed at Hopkins. Right now at MRI, we have capacity for MRI. We are expanding, but with the infusion center, we have we are 80% capacity at this time. However, we have doubled our infusion chairs for starting January. So hopefully we will be able to expand, to 100 more patients for donanemab when it gets approved. So donanemab, as you said, we mentioned that it was approved this year, but Johns Hopkins pharmacotherapy panel has approved donanemab yesterday, and it will be heard by the final P&T committee on November 6th. So hopefully this will also be a drug available for our patients. Thank you.
Thank you, Haroon. Wonderful job. So now we've done background, we've done side effects. You've heard a bit about the operational complexities of doing this. This is all US so far. So now we're starting to think about Greece. And our final speaker is Dr. Harakani, who is the head of medicines division for AOP and is ultimately going to guide us on the likelihood this could happen before we start thinking of the practicalities in Greece. Dr. Hani.
Good morning. Thank you very much for the invitation. It is a pleasure for me for being here today, although it is a different audience. I'm coming from the world of health policy and especially pharmaceutical policy. And today I'm going to briefly discuss about the evolving landscape of approval, of European approval, and of reimbursement, both in the European also and in the national level for Alzheimer products. I have non-conflict of interest, and the views I'm going to express today belong to me. As I mentioned before, the landscape evolves the last years in Europe Because we have three main initiatives in the European level. We have the implementation of the new legislation about health technology assessment. It is a regulation. We have a joint procurement initiative, which is very important for funding. And also, what is very important for researchers is the European health data space, because, as I will explain later, it gives the opportunity for secondary use of health data in the European Union. What is health technology assessment? As you know, health technology assessment, actually, it is a systematic procedure, and its main goal is to judge the value, the comparative value of a new treatment compared to existing ones. It is a multidisciplinary approach, and the value can include clinical effectiveness and safety, but also other aspects like social aspects, ethical aspects, and of course, budgetary aspects. This procedure now will be done both in the European and also in the national level. And if I would like briefly to describe the steps between the marketing authorization of a medicinal product and actually to be placed in the market and to be near to the patient, the steps are 5. The first step is the marketing authorization. The second step is that the product receives a price. This is done on a national level. And also then we have an HTA procedure, the health technology assessment procedures, which will be done both in the European and then on the national level. Then we have the negotiation, the budgetary negotiation. This could be done only on the national level. And the final, but not least from my point of view, is the inclusion of the product in the benefit package, the positive list. The HT regulation came into force, was first published by the end of 2021. It will come into force on the 1st January 2025. Now we are on the preparatory phase, and we will start with ATMPs and oncology products, and by 2030 we will have a full implementation. What is the gain to have an HTA procedure on a European level? It is very important because we will have the joint clinical assessment 30 days after the European marketing authorization. Therefore, we will have the comparative clinical assessment in the same period in all member states, and that's very important. The second thing is that we have created a framework for joint collaboration to clinical and scientific domains of HTA. And the third and most important thing, because everyone asks in Europe, if you have a European HTA, why it is necessary to have also a national HTA? What is important is that the European HTA will stop at the level of the comparison. They will not jump into conclusion. The conclusion will be done on a national level. And this is the framework, the governance of the HTA body in the European level. It is similar to the governance of the European Medicines Agency. They have a steering committee, the coordination group, in which each member state has an equal vote. It's like CHMP for pharmaceuticals. And under the HTA coordination group, we have 4 subgroups. One responsible for joint clinical assessment, another responsible for joint scientific consultation, another one for the methodology we are using, and another one for emerging technologies. Emerging technologies is a subgroup about horizon scanning, about new medicinal products that will affect the European pharmaceutical market the forthcoming years. All this body is supported by the European Commission. They have the Secretariat, and also we will have an IT platform which will have 2 parts, one part which will be public and another part which will be private for the member states. And this is just to show you that now we are on the preparatory phase and we have a lot of implementing acts. What will be probably interesting for you is the implementing act that we are discussing now, and it is about conflict of interest of stakeholders that they will take part in this procedure. There is a tremendous discussion about how the conflict of interest will be managed, because Europe would like to have independence and impartiality in this kind of procedure. And recently, based also on the Leqembi approval, 3 days ago, we have also a discussion on EMA level about conflict of interest of experts. What is the joint clinical assessment? In joint clinical assessment, actually we do a PICO exercise, like in clinical trials, but there is a difference. In trials, PICO is defined. When we do the PICO exercise in the European HTA level, each member state has to define what is the comparative treatment on national level, and also to define the outcomes that are important on a national level. And then the marketing authorization holder has to provide data and to demonstrate that the PICO in the clinical trials could answer the PICO that the regulators have raised. The second part is the joint scientific consultation. Actually, it's something like the scientific advice provided by the European Medicines Agency, but now probably this procedure will be done in parallel. And what is this? This is a guidance from the part of the HTA regulators to the marketing authorization holder, what kind of data we would like to have in clinical trials, what kind of data we request to be collected, to have a more certainty about the reimbursement of a product in the future. This is what I said about the PICO, what is the difference between the PICO in the clinical trials and the European level. And another thing which is interesting about Europe, and probably it could be applied also for products in the Alzheimer area, is the joint procurement. Europe didn't have a legacy in joint procurement, but COVID and vaccines taught us that we can go through joint procurement. And now we have established, and it is an evolving legislation about joint procurement between member states. And what I said at the beginning, European health data space, I think this is very important about research, because the secondary use allows to researchers to use data from member state and also to receive this kind of data in a very specific time frame according to the regulation, because this is a regulation. I believe they can request data and they can have the data 3 months at the latest after their initial request. What is the current status of monoclonal antibodies for Alzheimer's disease in European Union? As Professor Skarmeas mentioned, Aduhelm did not receive a marketing authorization. Actually, from a technical point of view, it was not a refusal of the marketing authorization, but the applicant withdrew the application before the final verdict. And in Leqembi, actually, from a technical point of view, the discussion is still ongoing, because the marketing authorization holder asked for a re-examination of the CHMP opinion. And of course, as you said, that we are expecting the final opinion of CHMP by the end of December. And what are the opportunities in Greece for national access, apart from the positive reimbursement list, the benefit package? We have also a special process for exceptional circumstances for individual patients, and this is done through a prior authorization procedure. And by concluding, I would like to, my take-home message is that the new evolving landscape ask for a collaboration between the European and the national level, and also I believe what is missing and what is important is the involvement and the interaction of all stakeholders during this roadmap. Thank you very much.
Thank you. That was wonderful. I'm wondering if we can do something about the noise in the back. because everybody in the auditorium side is being very quiet, but we can't hear very well because people on the other side of the bookcase perhaps could move outside as we're getting into this discussion. Could I have my one slide, please? So what I was hoping to do now is, I'll put up my one slide. As soon as it's up, I'll run through it. But I was hoping that we would first engage the panel. I'll start off with one question, and then I'll see what other questions other panelists have for each other. And then after that, we can move to engaging you all in the discussion. I hope you will come up and ask questions. I see at least 2 microphones there that you could use. And again, a plea to quiet down the space because it's kind of difficult up here. Kostadina, I don't know if you're around, but we need your help. We need people to move out because it's very loud in here. Okay, my slide, please. Let me, while we're getting this slide up, let me go ahead and ask one of the first questions. So I'm going to ask you, Paul Rosenberg, really two questions, thinking about ARIAs. One is you said that ARIA-Hs happen, so this is already a population that is at risk for ARIA-H. Why are they getting ARIA-Hs?
We don't really know why they're getting ARIA-Hs. It doesn't seem to be due to obvious factors like traumatic brain injury. The main thing is we've discovered ARIA-Hs because our MRI scanners are getting better. One of the points I didn't make was you need at least a 1.5 Tesla MRI to get a good count of ARIA-Hs. When you go up to 3 Tesla, you see more. And the chances are we've been observing them all along and haven't been paying that much attention to them.
Thanks, Paul. My slide is up. I'm just going to run through it because this is the complexity. Let's assume EMA approves. Let's assume that the country goes into the process of making these medicines available. Here's what would have to happen. We need a uniform national protocol. We need the centers that are going to be involved, the memory centers that are going to be diagnosing, qualifying people and managing patients. That's the core of it. We'll need infusion centers where the infusions are administered. If these medicines eventually become subcutaneous, we won't need those. We need imaging centers. You already heard that this stretches MRI capacity because there are so many happening. You need special MRI protocols. You need experienced neuroradiologists to read them. Then you need a process for diagnosing and qualifying. There won't be enough resources for everybody, so there will have to be a setup for priority criteria. Who is going to be preferred, if you will, to be administered the medicines? Then what's the process organically? Getting people to infusion centers, ordering and scheduling infusions, clinical monitoring and follow-up of MRIs, detection and handling of serious adverse events, defining a responder or a non-responder. Once we initiate a course of therapy, are we going to continue to give infusions forever? Are we going to get a follow-up PET scan showing that the amyloid is gone and then stop? So this issue of how long we treat is already one that's vexing us in Baltimore, and I think the broader field doesn't have a decision. And then, of course, the administrative management and funding of components. So put that up there for anybody you might want to think of questions in relationship to that. Paul, given that I asked you a question, maybe you want to ask a question of someone else, and we'll go that way. Or anyone.
Nick, what do you think about the effect size? In other words, Kostas used the adjective very modest, but I'm not saying he's wrong. There's a wide range of opinion about effect size. And thinking of, I'm going to present this to Dr. Kane also, because, in the U.S., the U.S. is not always better, and when it comes to regulation here, the U.S. is very chaotic. The Food and Drug Administration cannot take cost and cost effectiveness into account. I know this. I was on the committee that reviewed Alzheimer's drugs for a few years, and they specifically say you can't take cost into account. So the people worrying about effect size are different than the people paying for it. So Nick, I want to start with you. What do you think about the effect size?
So actually, in my mind, this this is the most important issue, and it somehow relates to safety also. Why? Because, I mean, it's a personal opinion. In my mind, I'm not saying we shouldn't be cautious, but the safety aspect is something that is clearly manageable compared to safety of other drugs that we give for other conditions and diseases. The weak point of these drugs is really the efficacy. So in my mind, if we had to choose and say, okay, if I had a drug with double efficacy and double safety concerns, I would take it. I would take it. So efficacy, so one issue is that, you know, the efficacy, 30% decline, one can think of it practically, okay, in 3 years, you gain 1. So somebody that doesn't take the drug progresses for 3 years cognitively, and somebody that takes the drug within a 3 years calendar time progresses the equivalent of 2 years. So that's a practical way to think about it. The effect of cholinesterase inhibitors that we are giving for all these years is not that dissimilar, okay? But there are differences also. Number one, you know, the trials for cholinesterase inhibitors were much shorter. Here is an effect for 1.5 years. Number two, these are more etiologic drugs, so we have a hope, a prospect for the future. Number three, the effect of these drugs is on top of cholinesterase inhibitors and memantine, so it's over and above. So it's not instead of, so we're getting something additional to what we already have. And there have been some recent data in the AIC in the summer, and I have seen some additional ones that, you know, in people who are at the really early stages, MCI, you know, mini-mental closer to 30. So in these people, there's some preliminary data that the effect is much stronger. And it goes along with the tau classification in the donanemab group. Of course, I haven't seen it yet. Maybe it's there, and but I think it's not out in a paper format, so we can look into the details, its presentation and slides. So these are the 3 elements that make me, you know, being more, you know, favorable towards these medications, but also we would like to see something better, as you said.
I often say to patients and families, my own enthusiasm for using the drugs is greater earlier because the data are gently suggesting that people with MCI do better. Dr. Kani, from your own point of view on, dare I say, Mount Olympus, what do you think about effect size and the decision to use these drugs?
Yes, I would like to say that as far as Alzheimer is concerned, there is a huge unmet medical need, both in Europe and also worldwide. Therefore, all the regulators would like to have a new medicine for Alzheimer's disease, which will be efficacious and safe. This will be reimbursed the next morning. But now we have these new drugs. The problem from a payer perspective is that their efficacy is a little bit uncertain by now. Therefore, we are a little bit reluctant to fund them in Europe. And for Greece, speaking with Greece, what frightens me is the size of the population that will be eligible. Not the one you mentioned in your presentation. You mentioned that we can go in a very strict population, and also we can apply strict criteria for infusion and the selection of patients, like in Johns Hopkins. But a country that probably doesn't have so much strict rules, like in USA or other European countries, probably it could have a very big impact on sustainability of the system. Therefore, I believe we have to have a very strict procedure about the patients that they will receive the product. And another thing, we have mentioned about the cost. Now, in Europe, with advanced therapies, in some other countries, there are some managed entry agreements that they are based on different aspects than traditional ones. In some hospitals in France now, they have a new rule that they pay after they see. They don't pay at first, and they see then. Therefore, this means that we can have agreements if we are certain about the efficacy that they can minimize or minimize the cost. We can't find a way to fund this kind of treatments, but we have to be sure that they will have an efficacy that will last.
Reimbursing retrospectively is a very creative but frightening approach.
Yes, because probably we will have to create some milestones, some clinical milestones, and probably we will have to pay a small amount, a guarantee amount of the drug at first, on the first year or on the first 6 months of infusion, and then we have to pay the rest if we see the results.
Nico? Paul?
Oh, thank you very much. Very good presentations and very important aspects of the treatment that we all want to know about. I want to make an observation, ask a question about efficacy that you were just talking about. As you said, the published data is slowing 25 to 35%, so very modest. On the other hand, there are subset analyses that are very interesting. We can't say too much conclusion-wise from them, of course, because they're subsets and not the total cohort. But if we look at the people with earlier cognitive stage, like MMSEs 27 and above, both drugs have about a 60% slowing of progression. So that's a pretty significant amount. And then if you say how many people don't advance to the next stage, it's about 39% more in the lecanemab, donanemab group than the other. And then if you say, do you ever see anybody improve? The answer is there are subsets that do actually come out better at 1.5 years than they did at baseline. And it was about 28% in lecanemab on control and 60% that were on the drug. So my question is, are you guys also seeing this in the real world? I have a lot of people on both drugs, and I'll never forget like one of my fellows coming to me and saying, hey, this guy's got a better CDR score this year than he did last year. Are you guys seeing that? And if so, should that be at least giving us the hope that the drugs are better than what we see in 25 to 35% slowing rate?
I'll take this.
Let me just comment real quick on the subgroup idea, because if we were to be strict about that, we should not be giving lecanemab to women, given that there's no demonstrated benefit in that analysis. So I'm always personally very cautious about giving much credence into unpublished data. But for my 5 patients, everybody's getting worse, maybe a little faster, and one patient thinks it's related to the administration. But Haroon, I don't know, what are you hearing?
So yes, I have seen the data that shows that patients who are in early stages, very early stages, but in those patients, they had quantified the amyloid level. The amyloid level was below 60, centiloids. So as of now, there is no way to quantify in majority of the PET scan centers first. So we can identify those types of patients. So some patients who have a cognitive score of above 30, like mini-mental of 28, 29, it's not necessary that they will have like low amyloid level, because high cognitive score, because patients may have good cognitive reserve. So that's why, that's number one. So all those patients are from lecanemab, and some of these patients did improve after 36 months slightly, but it wasn't that much. I think it was other patients who had low amyloid centiloid level, they also improved. So I would say that this drug has modest efficacy. It's not for everyone. You have to choose the correct patient, and once you have the right patient who are in very early stage and have pretty clean MRI, no other risk factors, you may see some benefit. I mean, the type of patients that have declined, even early stage, at the moment we cannot make a distinction in the first 12 months of treatment, because the plaques did not break until 12 months. So initially, even in the trial, the patients have declined. But again, there are some medical concerns as well that could cause decline.
Paul?
2 considerations here. One is in previous prevention trials, the A4 trial, happened to use a drug, solanezumab, that did not work. But it was a great place to study the effect of amyloid on decline. And within the group of patients who were amyloid positive, the ones with the least amyloid had the best outcome. So one of the things that we're not doing yet, we're basically using a visual read of the PET scan, plus minus, dichotomous. And it might be helpful to have a quantitative read. A lot of centers are working toward this, because we could probably say to people, you got a better chance if your centiloids are less than 24. For the folks not familiar with this, that's just the lowest, like the lowest tertile. The second part is beware of placebo effect. Our most important measures of outcome are function rather than cognitive scores. And it looks, when you do a clinical dementia rating scale, gosh, it looks objective. It's so validated. There's a lot of subjective. And in our own group, we've had a number of cases where patients get worse, actually quite a bit worse on the cognitive testing, and are better on the functional scale. Why? Placebo effect.
Which is family rated.
Which is family rated, and by definition has to be.
Yeah, thank you. Those are all really excellent points. I think I have about 100 people on lecanemab and maybe 40 on donanemab. It seems to me, I'm just one guy in one site, it seems as though people in general are progressing slower, but I don't know, I'm just one guy in one site, so I don't want to overinterpret that. Those are all really
But Paul, with those
good
numbers,
points.
you've got the capacity to find out quite a bit.
But you don't have placebo, so you don't really know.
That's true, exactly. Thank you.
A reminder is sort of because of our population research in the Cache County study, people with MCI and dementia, a third of them did not progress over 5 years. So there's a very substantial sense of stable patients. And those people are coming into our trials, and we're seeing them not progress as fast as we would think. For me, it's very hard to know that that's because of a drug. So it becomes very complicated. Dimitri?
Can you hear me? Yeah. So excellent presentation and a magnificent presentation of this complex topic. There isn't one right solution, but it befalls someone to play the devil's advocate, so it might as well be me. I am pretty skeptical about these drugs. One term that was used, it was uncertain efficacy. I would say that it is not uncertain efficacy that is the problem here. It's the fact that it is certain to be small to moderate. And so we have to base decisions to the fact that we have some drug that it's not going to do better than a certain margin. And so is this margin a meaningful improvement? Would also like to say that there are two parallel goals. One is to help individual patients, and the other is to solve the societal problem that is Alzheimer's. Because Alzheimer's, yes, causes a lot of suffering to individual patients, to their families and whatnot, and a huge socioeconomic burden. So no matter what we think about the first question, can we help individual patients, and is it personally meaningful for a family or for an individual to have their rate of decline slow down, and maybe we will feel one way or another about whether this is meaningful. Is it meaningful for a society to bankrupt itself or its health system in order to alleviate this tiny improvement? And I don't think that the current drugs are pretty good at removing amyloid. I mean, the next monoclonal antibody could be just tiny little bit better, but in my mind, it's pretty much a done conclusion that even if you remove the entire amyloid of the brain at that stage of the disease, you're not going to level off the disease. The decline will continue. So I think that we have to keep on looking for different targets. The monoclonal antibody question is great for now. That's all we have. That's what we have to discuss. But we really have to find other treatments that really level off, stop the rate of progression, and have strong efficacy, not just like this tiny bitty. Thank you.
Nico?
Dimitri, many people, share this skepticism. I just want to add, and I think we are all aware of this. I just want to add to what you say. Everybody's asking, every now and then, when is the next treatment for Alzheimer's disease, or when we will treat this disease, and everybody thinks of it in a digital way. Now we don't have treatment, and then tomorrow we'll have a treatment. But essentially, you know, it's important for people to appreciate that it's an incremental process, right? So what will happen, like, and there are many examples of that, is we will keep on getting better drugs, and drugs targeting different mechanisms and combinations of these drugs, and it will be a process where we'll have little by little steps of improvement, as you outline. And I agree with you that we cannot stop looking, because clearly we haven't resolved, this issue from a biological or even a societal or economical point of view. And clearly, there will be better drugs targeted for better patient subgroups. So I just want to raise this issue because everybody is expecting, and also, implicitly, many people are asking the question: is this the drug that resolves the problem? While it should be asked like, does it offer an additional help compared to what we have now, but always in the balance of how much do we pay for it?
Well, there is something we forget, right? Where it's the perfect as becoming the enemy of the good. Memory care that's available now is actually quite effective. And what worries me in Greece is that it's not widely available and implemented. In the US, it's actually a very effective approach. The US is now going to a system called GUIDE, where the the CMS, the Medicare, will pay for institutions to go out into the community, find people with dementia, put into place memory care activities that we know how to do now, with the anticipation that this will be very helpful. That's going to start up, actually has already started up in many places. So we can't forget that we actually have something right now that's pretty good, even though it's not curative. Dimitri, you have a follow-up?
Just to say that we're having this discussion. Just imagine if that was a pill that cost, and the cost was like 100 euros a month. Would we really have a discussion? It would be approved the next day, and we would be all celebrating. But the fact is that being as an invasive, expensive treatment, it requires us, although we're not policymaker, it kind of requires us to step in the shoes of the taxpayer and say, this modest effect, we could cure so many other diseases. We could do a lot more with this money. I mean, you have to take these considerations. And there is not one right answer for this, obviously.
Thank you. Great point. Yanni?
I think that works. Thanks, Kostas. I mean, as we have discussed many times to the assemblies of Hellenic Initiative Against Alzheimer's Disease, for the young, I see a lot of students and young people that please go to the website and check Hellenic Initiative Against Alzheimer's Disease. Actually, a lot of the members are here in the panel because there's a lot of seminars that do the stuff. Back to the question. If you, let's say in a magical way, tomorrow morning we wake up and there is a new perfect monoclonal drug, okay? Perfect. No side effect, it's improving. Are we in Greece or in Europe ready? We have all the infrastructure to use it. And why I'm saying that, it's not like, and we're very proud in Greece, we're setting up the system for COVID vaccination very fast, in a very digitalized way that even Germans would like to copy, and they did it later. However, that's not the case. And Kostas said in his opening talk that here we're talking about the next pandemic. Alzheimer's disease is increasing. So whatever today's solution we have, tomorrow they are going to be. And there is a lot of push on that direction. So at some point soon, we will have better drugs. Are we ready to apply through this process of monoclonal antibodies that they have a specific and very limited way of delivery? And how the Greek state is going to apply that is and this is something that I know at least from the Hellenic Initiative, Kostas can say, Panos also can tell about that. We are happy to help on preparing this. We are absolutely unprepared at that level for that stuff. And second, are we going to include the same ways that you're monitoring patients in states like PET? We have very few PETs scanning in Europe. What about that? So there is a technical issue and an MD issue I'm putting down. Thanks.
Anyone from the panel? Too bad the ministers of health and development left.
It is sobering to think about the contrast between COVID vaccines and this treatment. COVID vaccines proceeded pretty rapidly, the infrastructure proceeded rapidly, and of course you had millions of people. Look at the efforts we've made in one center to get 40 patients. I mean, the magnitude is just very different.
I hope I don't get this wrong, Amalia.
Yeah, Amalia. First of all, thank you so much for this wonderful talk. My question regards the presence of ARIAs, and specifically, if the presumed mechanism of action is to induce an immunologic response, so like inflammation, then could maybe ARIAs be seen as a possible marker for clinical efficacy? So like, could ARIAs predict maybe a better biological effect and thus a better clinical efficacy?
So ARIAs actually does mean that the drug is, affecting, maybe, it's breaking the amyloid, right? So usually most of these ARIAs happen, ARIA-H, for example, usually happens because, these amyloid antibodies, they attack the media of the blood vessels. And once they attack the media of the blood vessels, cause, the weakening of the blood vessel wall, and hence they have like fluid leak and stuff. Now, same thing, when these ARIAs happen, the one thing is for sure that some patients are like less responsive to anti-amyloid therapy, some patients are more responsive. So it happens in those, but there are also some other patient risk factors that we are not aware of what causes, or there is no crystal ball who will have ARIA, except for the ApoE3, ApoE4. Those are the risk factors for ARIA development. But other risk factors are, there is something, is coming up that maybe chronic kidney disease may have an effect. We don't know yet, but there are some, rules to that there may be a risk factor to these ARIA development as well.
Well,
I haven't seen long-term data on the association of ARIAs with long-term outcomes, because it could go either way. There's little doubt that ARIAs are occurring in areas where amyloid's being removed. I didn't show you the pretty pictures, but there's some nice examples from earlier studies where you could see, here's an area where the PET shows amyloid being removed, and hey, here's the same area for ARIA-E.
Nico?
So it's an important point, and actually there have been questions raised even regarding the blinding of the studies in relation to ARIAs, leading to some placebo effect in people who are receiving the drug and so forth. But there have been also some studies looking into that. If you look into some studies, more recent one by Larry Honig from Colombia, they even did some subgroup analysis in people who had ARIAs from the trials, and clearly there doesn't seem to be any improved benefit, which goes along with what makes sense. We see a damage in the brain, a lesion in the brain. It cannot be good, but even looking at the data, it doesn't seem to support it. But it's a reasonable question, and that's why it has been looked into.
Thank you.
All it supports is that it removes the amyloid. Those who have, but there's no clinical benefit.
Gentlemen, sorry, I don't know your name.
It's Cliff, and I have a question kind of more general. Are these ARIAs, I know they're in the name, but is it specific to anti-amyloid monoclonals, or will any monoclonal have this kind of issue? Will there be taurias for the anti-tau antibodies that are coming up?
First you got to find an anti-tau antibody that works. We'll let you know once we see. I mean, it's possible at the end of the month at CTAD we may finally see some positive results. There have been some hints, but I don't think anyone's observed ARIAs from the. There have been about 5 anti-tau antibody trials so far, mostly in progressive supranuclear palsy, and I'm not aware of any ARIAs or ARIA-E or ARIA-H. Do you folks
No,
have
so
any?
ARIA-E and ARIA-H, these two words were coined back in 2011, when these first generation anti-amyloid therapies started, like solanezumab and others, but these are only specific to the Alzheimer's disease anti-amyloid therapy, like monoclonal antibodies. It does not happen with any anti-tau, or at least it's not observed. There's no term like this. But as of now, that's the only thing that we are aware of.
And I just wanted to add something to that. I guess maybe not for the person who's asking, maybe for the audience, that, you know, similar phenomena happen spontaneously. There's amyloid-related angiitis, and they look very similar, both imaging-wise and to a certain degree clinically and even pathologically. But it's clearly provoked by this class of drugs. And also another add-on to that is that the hemorrhagic part usually goes along with the edema part. So people break down the hemorrhages into isolated area H hemorrhages that happen without edema and area H that happens with edema. So it seems that the most pertinent ones are the ones that happen with edema, because if one looks at the isolated hemorrhages that we see, the area H without edema, then the numbers are not very dissimilar to placebo. So we know that hemorrhages happen in the placebo arm. When they happen, but we didn't know how often they would happen because we wouldn't scan people so frequently when with MRIs, and we wouldn't rate them. So when hemorrhages happen, when they happen particularly together with edema, then it seems that they're more tightly related to these drugs that we're talking about.
Just a quick thought to add to that. I think that ARIAs overall reflect in an individual the relative distribution of where the amyloid is located. And so factors that influence a greater likelihood of localization in the intima of the blood vessels, that's where you're going to get, and we call that CAA in some settings, so that's where you're going to get the areas. So it would be eventually nice to be able to image that, and it's actually an achievable question on an MRI by looking at the size of blood vessels to say something about how much amyloid might be inside them as an indicator for future risk. So stay tuned.
Yes, hello. My name is Catherine. I'm a nutritionist. Thank you for being here. My question has to do with nutrition. We all know that nutrition plays a key role to all chronic diseases. I didn't hear anything about it today. So do you have any data about comparing groups who took care of nutrition and taking the drugs and groups who didn't take care of nutrition or specific nutrition protocols or general physical condition and just taking only the drugs? Do we have any data?
So you have the world's expert on that, Nikos Karameas. So Nico, you're the one.
Yeah, thanks, Kostas, for the compliment. So I don't want to diverge, but it's a separate issue. So there are two different elements, two different ways we can think of it: nutrition as prevention and nutrition in relation to prognosis. So you already have the symptoms, how does it affect? So nutrition in relation to prognosis, I don't think there's much data supporting that it may play a significant role. But there we have nutrition-related issues, the changes in weight, which is probably to a certain degree a result of the disease, but it becomes more complex because people change their setting. They may go to nursing homes, their diet changes there, they move less, they take drugs that reduce the weight, the cholinesterase inhibitors, they take drugs that increase weight, the neuroleptics. So it becomes more, so the nutritionist aspect is important, mostly in relation to weight management and making sure that these people don't become extremely thin and it may hurt their health after the disease has started during the prognosis part. In terms of prevention, there is data that maybe a healthy diet may be more close to the traditional, maybe Mediterranean values, maybe help decrease to a certain degree the risk of getting dementia. We don't know whether it's related to the amyloid biological pathway or whether it's inflammatory, oxidative, vascular, but there's a lot of literature on that.
Thank you.
Thank you. Sarah?
Let me just add to that. With lifestyle factors, the epidemiologic evidence tends to be pretty strong, as it is for diet. That a healthy diet, here we are in Greece, a Mediterranean diet, certainly associated with lower cardiac mortality and very possibly with lower dementia risk. The clinical trials have not been the clinical trials results have been disappointing so far. My personal feeling is it's because you can only do a trial for 1 or 2 or 3 years. It's likely the effect of nutrition is 2 or 3 decades. And so we're not starting early enough, and we don't have enough duration. So I think the same thing really applies to exercise, to socialization, and other lifestyle interventions.
Hello, my name is Stelios Pantelopoulos. I'm the head of the Research and Innovation Center of a technological company called Maggioli. And my question is about the effect of the AI. And I would like to have your opinion in what stage of the research you believe AI can support us in finding a new drug or finding a better drug, and how, when you believe this might happen.
Well, I can comment where AI is very active right now, and that is in brain image analysis, both in terms of digital analysis of MRI images in predicting pathophysiology, predicting prognosis, but there's evidence now that you can use MRI machine learning analysis to tell you something about the distribution of amyloid and tau. So the theoretical advantage there would be an MRI would tell everything, including the location, type, and distribution of amyloid and tau, which obviously would simplify a lot of what we're talking about. In terms of drug development, Nico, Paul?
Yeah, so I think there are AI experts here much better than we are, and I think in the remaining of the conference there will be some topics in relation to that. So I think there could be a lot of help from AI approaches in terms of going more towards precision personalized medicine. So we had been discussing before, for example, about maybe in earlier stages, or maybe people with lower baseline amyloid, or people who have certain profile may benefit better from these drugs. But this is only the tip of the iceberg. So I know that there's a lot of research, people trying to create, I don't know, some sort of metabolomics profile or other omics profile, and other information that the AI could capture and analyze that we cannot measure very well. So maybe AI could help us identify, using information from multiple fronts, subgroups that could be better responders to these treatments and maybe future treatments. Of course, it's not something that will happen tomorrow, but it's something that I think we will go towards, not long time from now.
Yes, I think the AI may predict ARIA in future years after, we have enough data or support. But I think the AI is doing a wonderful job.
Already, is that pharma is widely using AI to do the in silico high throughput screening. Do everything you can by computer to eliminate poor candidates. And I think AI has been very fruitful in helping industry do this. The second place, and it hasn't been, we don't have the results yet, but I think we're going to see that, is I think AI is particularly helpful in identifying subgroups that you wouldn't predict from your own head. AI is full of surprises. For instance, just a hypothetical. Suppose I found that tall Greek dementia experts who like to sail are at low risk, okay? You wouldn't predict that. You wouldn't predict that. Short Norwegian redheads, whatever. But my point is that AI will help you with those surprises. What AI won't help you with drug discovery is you can't test the drug. AI will not test your drug for you. And we're still looking for ways to make the process cheaper and faster for the the screening of early stage drugs.
Thank you.
Thank you. Sir?
Congratulations to all of you for the very good presentation. Thank you for being here. I am Dr. Mario Georgiadis, surgical urologist. Excuse me. I have two questions, a simple one, and the second is a little strange. My mother died 13 years ago from Alzheimer. A professor of neurology who had examined her, I was told from him that people suffering from Alzheimer's disease, finally, at the end, they die from cardiac failure. And I don't know what do you think about this. So the second question is a little strange. The elderly people who have followed a very good life, very good healthy food diet from the young life, their only young life, exercising for every kind of exercising, especially swimming during the winter, as we have here in Greece, 300 days very good weather, and it was written that the elderly people who follow a spiritual life, studying every day, newspaper, books, all this can prevent somehow the appearance of Alzheimer's disease. What do you think about this?
Yeah, yes. The question about lifestyle is not whether it helps prevent Alzheimer's.
Especially very good sexual life.
Less data on that, but just in general, there's plenty of epidemiologic evidence for exercise, healthy diet, a variety of leisure activities, socialization, social support, education, all being protective. The question is, as I said before, what's the effect size? The most prominent study that's reported out, FINGER, which was performed in Finland, a very aggressive lifestyle modification study for a year and a half. The great thing, it worked. Bad news, it only budged cognitive and functional outcomes by 0.1 standard deviation. The question is, can we jazz that up? I mean, if we could get that to 0.3, 0.4, if we could get a moderate effect size, we could get rid of all these drugs, I guess.
Well, we're coming to our end, and I see at least one other person. So let's, yeah, go ahead.
All right. Thank you very much for this wonderful discussion that we had today. Very enlightening. I'm here for two reasons. The first has already been accomplished. I wanted to encourage some of the students to stand up and ask a question. The second is that I wanted to address the field of personalized medicine and multi-omics and how we can use biomarkers, digital biomarkers or genetic biomarkers in, first of all, better recruiting and clinical trial design, and then optimizing the results via AI and feedbacking the design of the clinical trial so we get better, more direct outcomes and results and data that can help AI, because AI needs good quality data, and there is a huge manifestation of this umbrella of multiple thousands of different clinical phenotypes that you get with MCI and Alzheimer's. So do you see any future on, please?
Yeah, so let me just mention two initiatives, and I'll be quick and then see what others have to say. The first is that in the US, electronic medical records are basically used everywhere right now, and so it is possible to analyze what are called real-world data. At Hopkins, in our Precision Medicine Center, we have in our hands real-world data from close to 1 million people. And one of our goals is to use those for a preliminary look at individual subgroups that might be of interest. And we're not the only ones, but that's one example where hypotheses will be tested of various kinds. The other thing is an amazing development that involves the 38 funded U.S. Alzheimer's disease research centers, of which we are one. We are moving to an era where in the same person, we will have blood biomarkers, brain MRI, tau imaging, and amyloid imaging. And so once you accomplish that in the same person, at the volume that is going to happen in the US in the next 5-ish years, then you can ask a lot of questions. So I think those are getting biomarkers done, getting this one in 5 people and that one in 30 people doesn't help you. Getting them in the same people who are well characterized and followed, that's the essential piece that's already happening in the US, and Paul and I actually have a project that we're working on that'll build on that.
Fantastic.
So, yeah.
Because we shouldn't forget that lifestyle medicine and epigenetics of lifestyle medicine might be a biomarker, like a dynamic biomarker.
So, as Paul said, there's absence of proof, there's proof of absence. So, regarding lifestyle, there's no proof of absence of its efficacy. I would say that there's more absence of proof, so the clinical trials, mostly for practical reasons, have not been done. And now, with the help of modern technology and biomarkers, maybe we'll be able to do better tests, better trials in people who either are more at risk or in people who have certain biomarker profile, considering multiple biomarkers, as Costa said, or people who are more likely to decline, so we'll have more power. So it's something to be demonstrated, the presence of efficacy and also the effect size, as Paul mentioned. And AI can help there too.
Thank you very much.
Thank you. I think some of your students are now asking, so go ahead.
Hello, my name is Eleftheria, and I'm a student at the Agricultural University of Athens. Maybe my question is too hopeful, but I think the reason why brain cells do not divide is because they don't have an organelle named centrioles, which are contained by a protein named tubulin. So why can't we just insert tubulin to Alzheimer patients to help them divide their brain cells to replace the ones that die, and the string tissue, and also make it functional since there is no centrioles? Isn't that protein produced in other species, or isn't there a source we could use? And how thank you.
Well, those are great ideas. I'm not sure that we are the exact right number of experts, curious what others say, but brain cells do divide. There are stores of brain cells throughout the brain that are capable of division throughout the life. So something called neurogenesis that happens in our brains every day and speaks to plasticity. And many think the loss of neurogenetic capacity is behind many brain pathologies, depression, possibly some forms of Alzheimer's disease.
Yeah, but they mostly divide in early ages. And I mean, the problem with Alzheimer patients isn't that they lose the connections of the neurons they have. So,
Nico, you want to?
I can just say, there are two areas of the brain where there's still ongoing division, the subventricular zone and areas close to the hippocampus. But the key thing is the following. This is a testable hypothesis. So what I would do is, dig into the literature in detail, see whether this has been addressed or not on a basic science level, because I don't know a lot about this. I would have to read about this, and I'm not, as Costa said, we're not the experts on that. But one could see, has it been tested? Has it been tested adequately? Has it been done on a basic science level in the lab? Has it been taken clinically? Has it been taken to animals, to humans? And then it would be a great project for a PhD if this has not been done. So it's something to aspire for.
Thank you very much.
Last question.
All right, so I saw a movie some time ago that focused on a company that tried to make an injectable serum as a cure for Alzheimer's disease. That was based on a brain-affecting virus who was genetically modified to not be harmful to humans and to enhance brain activity. Now, I know that there are a lot of risks when it comes to viral therapy, such as mutations. However, are there any researches and studies being condoned about how a genetically modified virus could help someone with Alzheimer's?
So there have been a couple of direct injections of genetically modified virus in Parkinson's and also in Alzheimer's. I don't know, I'm seeing someone has some expertise over there. Maybe you could help answer that? You have a patent. Do you want to come up and tell us about it? Later today. Okay, so we'll catch the talk later today.
And also, would there be a possibility for the inserted genes of the virus to not cause any harmful mutations?
Why don't we defer that to the afternoon, where we have the right expert on the stage?
Thank you very much.
So it is 12:30, right on the dot. I want to thank my fellow speakers. I want to thank all of you. You stayed. This is wonderful. And I want to thank everybody in the back room who kept quiet. Thank you very much.
Νίκο, εσείς. Κάτσε να σε φωνάξω. The session is titled The Impact of Stress in the Brain. It's a very innovative topic, and we will hear some talks from the best. Please, little quiet. Thank you. So the first talk is addressed by Associate Professor Nikolaos Daskalakis. He serves at the Department of Psychiatry at the Harvard Medical School, and the title of his talk is Systems Biology Dissection of Trauma-Related Risk and Disease Processes Across Brain Regions, Omic Layers, Cell Types, and Blood. We're looking forward to hear from you, Nico. Please take the floor.
Thank you, Dr. Vlamos, for the introduction. Here we go. So I have a little bit of introduction on this session, starting by an overview of the, here's my disclosures, and I'm starting with an overview of the stress response. So all mammals, including us humans, we have a hardwired system to respond to stress. So when we get exposed to a life-threatening challenge like this tiger here, we have to, behaviorally speaking, from the outside, we have to have one of these three types of responses, the so-called fight, flight, or freeze response. This initial response is primarily mediated through an autonomic response and is quite fast. But then most often the challenge is gone. The initial phase has happened, and then when the challenge is gone, there is another hardwired system that helps us to return to homeostasis. And this involves the hypothalamic pituitary adrenal axis and the end product cortisol that will mediate all tissues to slowly get back to the original state. But there is some pathologic happening in stress-related disorders, and stress-related disorders are not only disorders of the brain, but here today we focus on the brain. In which individuals that have those disorders, even if the threat is gone, they keep this heightened level of activation. And very helpful to understand those disorders is to understand this individual variation, why some people respond differently to these experiences. The classic statistical approach to this is to study the genetic code, the DNA, the letters of the DNA, the 4 letters, the full sequence, and try to associate the presence of variations on those letters with the binary outcome, having or not having this stress-related disorder. Statistically, this is it has these problems that is asking a lot of questions because you have millions of letters of the DNA. And on the other hand, it has the simplicity that the phenotype is perceived as a binary outcome, being or not being in a group. So this needs a lot of power. And here in the middle of this graph, you see the required sample size, depending on what type of brain disorder you are studying, to start getting in the y-axis is the significant loci of association. All those disorders are polygenic, so the number of loci is very high, and to discover them, you need to have thousands and millions of cases. So you have the extreme case of schizophrenia, which is very heritable, and you have the other extreme case of depression that has a less heritable component. Post-traumatic stress disorder, that is the disorder that my lab primarily focuses on, is somewhere in the middle, which nowadays we have the first successful genome-wide association study that discovered approximately 100 loci in the genome related to this disease. In the meantime, and also more essentially to biologically understand these disorders, we need to move away from this simplistic way of analyzing individual variation and introduce the so-called system biology approach to understand all the intermediate steps from the DNA code all the way to the complex presentation of a psychiatric disorder. So biology is in our help here, right? Because our nature has evolved to have a very tight connection of how genotype relates to molecular phenotypes like gene expression or protein expression, and more complex things like gene networks, cell type communication, and these can help us understand intermediate phenotypes that we can measure in human beings in a multidimensional way, like when we use neuroimaging or when we use biomarkers in the blood or other tissue. And then hopefully bridge the gap from genotype to phenotype. My laboratory has been focusing on one iteration of these approaches, and it can serve as an example. Biologists have developed techniques to study, in this particular example, gene expression in great detail, and great detail in many ways, in the ways of sampling it from multiple tissues, sampling it within the brain for multiple brain regions that have distinct biology, but also considering the disease of interest, studying in the right context, either the right context in terms of development, the right context in terms of aging, the right context in terms of whether it should be basal gene expression or it should be gene expression studied after a challenge. In the end of the day, the good thing is that we have all these assembled reference gene expression panels, and we can use machine learning, artificial intelligence, to associate the genetic code with this complex tissue and cell type specific expression. Normally what happens is that we have the data set, let's say from a certain brain region, and we are able to associate the genotype, that is these 0, 1, 2 variables of the DNA, and we associate them with the explicit expression profiles. They could be mRNA, or it could be circular RNA, it could be microRNA, it could be cell-type specific RNA. It doesn't matter. In the end of the day, we will have some limitations of power, and we will use the machine learning to create a regression that could then we can replicate, but it will be sort of like an equation that we can use whenever we have genotype to predict something more complex like gene expression. So when we are ready, this means that the next time we see a patient and we take a, I cannot bring it up there. But when we have a genotype of a patient, we can measure it in the laboratory, getting the genotype from a blood sample. But we have this genotype information that doesn't mean anything, but using those models, we can impute something more complex, like the gene expression in the amygdala of the brain. And then we convert this, let's say, boring genotype information to something that we are more interested as to have more biological understanding of what is going on and associate it with the phenotypes we can measure in this patient that is in front of us. Another iteration of this that is in the right side here is that all these genome-wide association studies that other people have done in millions of people that we don't have access to are just as they are summarized statistical associations that we can now, using machine learning, convert them to something more meaningful. We can say, okay, there is the GWAS of depression, but we want to see this GWAS of depression through the angle of hippocampus gene expression, because hippocampus is a very critical brain region to know. But after we do those predictions, and somebody in the previous session mentioned it, is you do the predictions, but in the end of the day, you can still have to do the experiment, or you have to do the clinical trial, you have to test this. But you have something more explicit to test. You have a particular gene of interest, a particular tissue, and a particular prediction. So then you could potentially accelerate discovery. In the most recent iteration, in the Genome-Wide Association study for post-traumatic stress disorder, we have done this using this type of models, and we are now, from the upper panel that is just SNP associations, we are now in the lower panels where in particular regions of this Manhattan plot, it looks like a Manhattan plot because it has skyscrapers and some smaller buildings, so it has this, these ups and downs. But then the lower panels are the predicted genes, and these predicted genes are in particular tissues and brain regions and cell types. So we have done this extensively. Now we have power to test this hypothesis, and we assembled now biological data to actually test all this and see if risk biology is different than the downstream biology of disease. So in a recent publication we published this year in Science, we did exactly this. So it was a big collaboration across the US for multiple labs, and we selected three hypothesized tissues for post-traumatic stress disorder, one in the prefrontal cortex, the dentate gyrus in the hippocampus, and central amygdala, the central nucleus of the amygdala from the amygdala, where we actually measured not only gene expression, but we also measured methylomics, basically chemical modifications of the DNA that they code how experience influences the DNA code, explains a lot of cell type specific phenomena, and we also measure proteomics with mass spectrometry. The design for statistical reasons was a discovery replication design, and on a subset of these samples we also did the so-called single-cell genomics transcriptomic analysis, which is basically studying gene expression not only at the level of a bulk tissue, but at every single cell of the sample. And I will go into this. At the same time, because we want to have an early view if all these discoveries have relevance to the blood, we analyzed the UQ Biobank proteomic data from plasma. And at the same time, we were always integrating our results with the GWAS that I just described you, because we wanted to disentangle genes and pathways that relate to risk and or are downstream of a disease process. So in this schematic, I just wanted to emphasize is that when you have tissues from a living subject, or from, in this case, from people that actually died while having these diseases, is that a whole life has passed in these individuals, from birth to the early stressful experience that they might have had, to the onset of the disease, to additional stressors and or medications that they have had throughout their lives. So when you get a tissue, you have all these complex regulations compacted in one sample. So it's very difficult to deconvolve and disentangle all those things. now an overview of results. I will try not to go to the details, but when you do such a huge investigation, one thing is to evaluate your investment. The investment as in which tissue or which type of omics gave you most information for these two disorders we were studying. And I'm sorry I forgot to say one important thing. What disease we're studying here is PTSD, MDD, and controls. Why we have to study always PTSD and MDD together. Both are pretty much influenced from the same risk factors. And it is very unlikely to have a PTSD brain that doesn't have some aspects of depression throughout their life. So a very necessary psychiatric control group for PTSD brains is the depression brains that don't have PTSD as a phenotype. So that, remember this. So in the two disorders, we discovered that gene expression in the prefrontal cortex and exon-specific gene expression was the most informative. But then other layers of information we studied, either at junctions, exon-exon junctions, or transcripts, or CPG sites, or proteins, or peptides, had some unique extra information to bring in the table. With some specific things, for example, the dentate gyrus CPG sites, the methylation sites, were more informative for PTSD compared to depression. Somebody mentioned about neurogenesis in the previous session. DG is the region in which neurogenesis occurs, and it seems that in PTSD, the epigenetic regulation of that region is more informative for PTSD. Moving on, we had a various big level questions to answer. One is, are the different regions really different from each other, and at what degree? We saw that there were low to moderate correlations between the brain regions, so they are not overlapping. And if you would study omics like DNA methylation, you would see that the methylation signatures in the different regions were quite not overlapping. Other things we were interested in is, we know how gender and sex, biological sex, are important for the presentation of mood disorders. And also, we know from epidemiology there would be slightly different etiologic trajectories could be at play. So we were wondering if studying the disorder as a whole is different than studying it in a sex-specific way. And we saw that in PTSD, it seems that the correlation, the sex-specific correlations that were moderate to high were similarly related for both males and females with the primary diagnosis, versus in MDD, it seems that there was a greater degree of sex-specific things that we further want to evaluate. Another common risk factor of childhood trauma, we saw that the directions of effect that are childhood trauma specific seems to, in an overall sense, correlate with the primary disease effect. And these correlations are high, with the proteomic data having the lowest of those correlations. And similar observations we had about death by suicide. Suicide is frequent, both in PTSD and MDD, and it seems that, in general, having the disease and death by suicide generates similar effects. We were also interested in the correlation of the two disorders between each other, and saw that those correlations were actually lower, and they were not as high as perceived in genetic studies. In genetic studies, there is a notion of like a 0.9 correlation between the two disorders. Some people argue that it might be the same. Nevertheless, here we see that if you pay the price and study the biology of disease, you see that this correlation is moderate, and in some omic layers like proteomics, like DNA methylation and proteomics, these correlations are much lower. Then, I hope I'm not too slow. How, 5 minutes?
No problem, because
Okay.
We have a speaker that we will not attend.
Okay. So one other thing is that because we know the dogma in biology that we do in high school, right? So that DNA predicts RNA and RNA predicts protein. So we wanted to have this multi-omic correlation. But doing a multi-omic correlation is not straightforward, right? Because the features, the players at the RNA level and the protein level, they are not exactly matched, right? So there are a lot of combinations. So we chose to map all this data to common pathways and correlate them at the level of pathways. So you have the DNA pathways, the RNA pathways, and the protein pathways. So we see that after doing this, the correlations are quite low. Sometimes are actually not present, and if anything, they are low correlations against, let's say, the overall expectation. Of course, it could be that there is a better correlation if you study this relationship in a different time window. This is, by definition, cross-sectional because it's a dead person's tissue, so you don't have the possibility to create, time delay and stuff like that we can do in cell culture and in animal models. But, with this in mind, we saw that in the top pathways, you could potentially have common pathways involved with disease, like a lot of immune pathways. And you see that in both disorders, they can have the same immune pathway, but then RNA direction of effect being different than the protein direction of effect. You have also immune pathways that are more present in RNA and they are not present in proteins. And we see that synaptic and synaptic and neuronal type of pathways are endorsed by, for example, DNA methylation, some, and by proteins, others. So one other thing we wanted to do was to understand, because of this prevailing RNA-based immune pathways, we want to see what does this mean? Does it tell us that different type of cell types are involved? Is it neuronal? Is it non-neuronal? What is going on? So we did this so-called, there is a technique called spatial transcriptomics. So basically, you study, particularly you can do this very good in the cortex. So the cortex is structured in layers, and the different layers have, different cell types within layer. Having this data can be used to deconvolve the bulk data that we have, and we try to allocate where these disease signatures are occurring. So we see that in our data that for both PTSD and MDD, the RNA signal is in the top layer, the leptomeninges layer, that, if anything, has prevailingly non-neuronal cell types there. While the protein disease signal, that is in the bottom panel, that is more enriched with neurons, is the protein disease signature is more in deeper layers where more neurons are. So we see this kind of difference that I will go back to it in a little bit. At the gene network level, just because the RNA data are more powerful and they were more immune-related, we see all the gene networks important for disease tended to be immune or stress response related. And at the transcription factor level, you see transcription factors involved that are common immune and stress regulators. There is other things we did in this paper were that we try to factorize this multi-omic, multi-region data, try to see if we don't have any a priori hypothesis of how the data is divided. Can the data actually show us the underlying relationships? And we saw that indeed that we identified 30 factors, multi-omic factors, and we saw that there are factors that are endorsed only by DNA methylation, factors only about RNA, but we also found some very special factors that are multi-omic, multi-region factors. The most important of those, endorsed by all types of biology, was related to aging, and it's not surprising. but it's not the classic epigenetic clock, because it's very known in biology, epigenetic clocks tag aging. In our case, it is endorsed also from proteomic data and from gene expression data. And this particular multi-omic clock was having indications of age acceleration for both diseases. That is a classic finding reported in many brain diseases. And we found also some more unique factors related to disease. Now I'm going to very briefly to the cell type specific data. This is the type of maps you can do when you do single cell genomics, and you can read online about this amazing technique that instead of studying tissue as a smoothie, studies every single cell that is part of this sample, and you get this beautiful division of the data in major cell types. You can even go to the sub-cell types and the specific type of neurons you might be interested. But in the end of the day, we wanted to see if this data, and also aggregating data that other people is if it's telling us anything about specific things in particular cell types. In PTSD so far, we had most power in excitatory and inhibitory neurons and astrocytes, but in MDD, it seems with the N equals 50, right now we have power to identify a lot of neuronal signals, but also a lot of non-neuronal signals, and many of those are common suspects, like involving glucocorticoreceptor signaling and particular immune regulators. And we saw a prevailing signal on a particular genomic location from the genetic standpoint, the 17q2131, that is the location relevant to this conference, that is the location that has the top stress gene, the receptor for CRH receptor 1, and the same locus produces MAPT, which is the tau gene. So these volcano plots support this. We try to see if from the neuronal standpoint in cell culture, we could create a simplistic cell culture model that, I'm totally out of time. Yeah. So in that particular model, we were able to show that a fast regulation by glucocorticoreceptor in IPC-derived neurons is actually capturing opposing signals for the two diseases, with a positive correlation in PTSD and negative in MDD. And we were having an observation that the RNA data from the brain correlate with the blood proteomic data, which is, this is a very exciting hypothesis we can form, which is, if the blood proteomic data correlate with RNA data, and we know that they are in the leptomeninges, does this indicate that a peripheral signal interfaces with that superficial layer affecting RNA first, rather than the other way around? And we also saw that this locus that I told you is the most prevailing, strongly influencing neuroimaging among all neuroimaging variables in UKO Biobank. This was in 35,000 people, and this was in 50,000 people. That locus is the most strong locus. And I think the final thing is that now we can do causal analysis of going from genotype to expression to diagnosis. We can start studying in a more powerful way gene-environment interactions. And in the end of the day, we want to use all this data to understand various types of humans and employ them to create more biologically homogeneous subgroups of disease. And I will stop there. We have started doing this, but I'll leave it there, because in the end of the day, we want to help people that are in the upper part of this iceberg, but also in the bottom part, but in a more biological manner. So,
thank you, Nikos, for the passionate talk. And I think we will have at the end of the session questions for all the speakers. Let us introduce now Assistant Professor Paige Sigan from Department of Psychiatry and Behavioral Sciences, Johns Hopkins University. Paige is also the Director of Behavior Medicine Services for the Division of Pediatric Nephrology and Pediatric Dialysis Program. She will give us a talk entitled Digital Mental Health Applications for Anxiety and Depression, Current Evidence, Limitation, and Future Directions.
All right. Perfect, thank you. All right, so I'm going to be talking about digital mental health applications for anxiety and depression, what the current evidence looks like, current limitations, and future directions. So I'm sure we're all well aware of this, but anxiety and depressive disorders affect a significant portion of the population, leading to functional impairments and an increased risk for health complications. COVID-19 did not help this. It increased symptoms of anxiety and depression globally, exacerbating existing mental health issues, and this is really highlighting our current need for effective treatments that are accessible. So we're going to be talking about, briefly, just some evidence-based interventions because we have them currently to treat anxiety and depressive disorders. However, there are lots of barriers that impact access to these treatments. So some barriers include things like financial costs, stigma, and lack of qualified providers. Also, wait time to get into providers is very, very long. So for mood disorders, it can be up to 8 years to get treatment, evidence-based treatment, and for anxiety disorders, sometimes up to 9 years. So these long wait times contribute to worsening mental health conditions and highlight the urgent need for system changes and access to care in a timely manner. So this is where digital mental health applications come into play. So we know that at least roughly 15,000 digital mental health apps exist, which is a wildly high number, but not everybody uses them and we don't know how to access them. We also don't know if they work, so we're going to talk about that in a little bit too, but just to define what a digital mental health app is, it's an app on a mobile platform designed to deliver mental health care, provide self-guiding tools for tracking mood, managing stress, and implementing therapeutic strategies. So how many of you have downloaded the Calm app before? Is that as much? Okay, in the United States, a lot of people have downloaded the Calm app. Headspace is another popular one. So many people have downloaded at least one mental health app, but we don't use them and we don't use them consistently and we also don't know if they work. So that's what we're going to talk a little bit about today. So efficacy of digital mental health apps, do they do what we want them to do? We did a meta-analysis focused on standalone digital mental health apps. So this means it's just the app, there's no outside coaching, no therapist attached to the app, it's just the app itself delivering care. And we wanted to see if these types of apps could be integrated into a stepped care model. So we did a search from 2007 to 2022, and it came out with 36 different randomized control trials investigating standalone only DMHAs. And what we found was a modest but significant reduction in anxiety symptoms as well as depression symptom severity, so that's good. And then we looked at several different moderators influencing the potential therapeutic effects of DMHAs on anxiety and depressive symptoms. And one of those moderators was treatment duration. So the longer you use the app, the better the outcome, which makes sense. Participant inclusion criteria. So those participants that had higher levels of symptoms had increased, decrease, or had better reduction in symptoms. And then what's something notable is reduction in symptoms varied depending on the outcome measure used. So different outcome measures, one is the generalized anxiety questionnaire, and then another one, the depression and anxiety severity scale. Depending on which measure was used in the randomized control trial, you had different outcomes in terms of symptom reduction. So it's really important when we're measuring or examining the efficacy of apps, what measurement tools are we using, because that might indicate different changes in symptoms. So limitations of this study, the vast majority of commercially available DMHAs remain untested in randomized controlled trials, so we really don't know if those 15,000 apps out there actually do what they're saying they do. Limited characteristics across RCTs, so of the RCTs that exist, they don't really explain the apps in detail, so we don't know the different components and features and characteristic of apps to see what's happening, what might be really driving change in symptoms. The majority of studies also focus on participants identified as white individuals and women. This is important to consider when we think of what digital mental health apps can do. So if we're talking about increasing access to care specifically to different underrepresented populations, then we need to be taking into account, are the apps reaching the populations that we're intending them to reach in terms of access to care? And then about 50% of trials did not report on one or more demographic characteristics. So again, a really big limitation of the current literature that's out there is that we don't really know who they had in the studies. So we don't really know who these apps are reaching and who they're effective for. Many DMHAs are proprietary tools of specific companies, so we really need more transparent academic industry partnerships. And we'll talk about privacy a little bit later, but privacy policies really need to be improved, and the transparency of those need to be improved. So several critical questions remain about how can we optimally use these different tools, and at least in my field of interest, how can we integrate these tools into healthcare systems? So you can go download it. Anybody can go download digital mental health app, but how can we use them within care within our healthcare systems? So this leads to another paper that was recently published. We examined provider and patient perspectives on DMHA adoption within a healthcare system. So what do providers need to know and what do patients need to know to get these apps in the hands of patients and get them to use them? So we investigated barriers and facilitators to the adoption of digital mental health applications among patients and providers within a healthcare system. It was a targeted convenience sample of patients, 57, and providers, 100, were recruited from a large academic healthcare system. They completed surveys assessing their attitudes and opinions about digital mental health applications, as well as factors that would increase their adoption and use in routine clinical care. So first, we're going to talk about provider barriers. So main barriers here was providers don't know which ones work. They want to know which ones work in order to prescribe those to their patients. So they're unclear about best practices. They're worried about financial barriers, so not just the cost to the patient, but also reimbursement. So how can I bill when I'm talking about this app to a patient and prescribing this app? And then workflow concerns. So what if a patient doesn't understand how to download it, and I don't have time to spend, to spend with a patient to then download the app with them? How do we get around that? And then that kind of falls into the idea of tech support. So what if a patient needs help navigating the app? Me as their provider, I don't have that time beyond what I'm already doing for regular patient care to be able to sit down and be IT as well. And then also what could help providers be more inclined to prescribe them. So credibility, knowing that they work, knowing that they're going to benefit their patients. App features, so having things like guided activities, a way to capture data and then look at that data to inform different treatment care, and then ease of use, so for it to be easy for the provider and easy for the patient. Those would help a provider be more likely to prescribe an app to their patient. From a patient standpoint, biggest one was privacy. So the patients, at least that we surveyed, were pretty much in favor of using apps, but they were really, really worried about the privacy of their mental health information. And this is even more highlighted by recent lawsuits with BetterHelp, in which BetterHelp was sharing personal data to third parties like Facebook and Instagram. So their fear around privacy is not totally unfounded. And users often, again, fear that their personal data is going to be compromised. What would make them more inclined to use an app is usability. So if they can download it easily and use it, they're more likely to use it. Accessibility, so where they can use it, how often they can use it. different features. So they really wanted also, similarly to providers, guided activities. They wanted to be able to have a coach. And then about 74% actually would want a licensed provider within the app providing therapy. So that would be the things that drive, and of course, credibility. Does it work? Is it going to help me with my personal problems? These are things that would help increase use among a patient. So what do we do with all of this information? So one piece is really understanding the limitations of the current data that's out there, and that's that our samples are wildly, not diverse, and so we really need to look at, are the apps that we're researching and wanting to prescribe, at least in a healthcare setting, are they reaching the patient populations that are at highest risk for limited access to care? User retention is a big piece that we haven't looked at yet, but we know that there's lots of issues with people continuing to use apps. So maybe everybody in this room might download an app, but only a very small portion might actually use the app and continue to use it in a way that it's designed to be used for it to be effective. Clinical decision-making tools, so within a healthcare system, maybe we could come up with tools that help increase provider education and then also increase providers' decision-making around which apps to prescribe, because I might come in with with a presenting problem that's different than what you might come in with, what you might come in with, what you might come in with, and so how does a provider very quickly decide which app to prescribe? Making clinical decision tools would really ease that process and make it more efficient. Patients and providers want specific features included in their apps, so perhaps it would be promising to create some kind of panel built within a healthcare system of patients and providers to really hone in on which apps are going to be most useful for the patients that we work with, and have the features that our patients want. And then transparent privacy policies. So we talked about this earlier, but really I don't know if you've ever read a privacy policy on an app you've downloaded, but it is full of legal jargon. I get about a third way through and I'm like, okay, I think I trust this, and click accept. We shouldn't be doing that with our healthcare. So we really need more transparent privacy policies, and then really top-down methodological approaches. So we really need, everybody's building these apps, and then on that back end, we're thinking, does this app work for this patient? Are these apps effective? Are they doing what patients want? It really should be the other way around, where we're looking at how are these apps going to be, well, I think it's a mixture. We also need to be considering how are these apps going to be covered by insurance? How are these apps going to be integrated within a healthcare system? So working with healthcare leadership, working with insurance companies, at least in the US, and other stakeholders is going to be key for these tools to be effective and used. So just in conclusion, integrating these types of apps into clinical practice requires clear frameworks and strategies for use. Ongoing efforts to develop new apps are really of little value if we're not taking the opinions of key stakeholders into account, such as providers, patients, their institutions. So we still have a lot of work to be done in order to integrate these apps successfully into healthcare systems, but they do offer, it's their effectiveness in helping to increase access to care is promising. So yeah, more to hopefully come in the future for these apps. And here are just the references of the papers that I've discussed today, and I appreciate you all joining. Thank you.
Thank you very much for the beautiful talk. Our next speaker was Professor Sousa. Unfortunately, family health issue kept him away from Genedis. So we move on with our last speaker, Dr. Ioannis Sotiropoulos, group leader at the Institute of Biosciences Application, Demokritos, but a very esteemed colleague. He's a very active member of the Hellenic Initiative Against Alzheimer's Disease. He is responsible with Christina Dalla for all the joint satellite events we are doing with Genedis. He will give us the talk entitled Chronic Steers and Exosomes in Participation Diagnosis of Alzheimer's Disease.
Thank you. I know it's a bit difficult because it's after lunch and you are all tired. A lot of you had flight yesterday from States or around Europe. So I will try as much as fast and entertaining as possible. It is very difficult to compete Nikos Daskalakis and Paige because I really need to have this application if I can help me to prevent something heavy, you know, because working in research is kind of an anxious. So first of all, I would like to transfer the big apologies of Professor Nuno Sousa, who really could not do it due to urgent family issues. He really would like to be with us, but he didn't go. He's a great collaborator and a great mentor. So I'm going to speak to you about something you probably know in a daily basis, all of you, what is daily life stress. Everybody is on this stuff. So the work we have been developing since Max Planck and later in Portugal and now the last 3.5 years in Democritus Institute is basically in my lab called ExoBrain, which has 3 research lines. And indeed, this is the topics I'm going to give you some hints in the 20 minutes I have about the big triangle that we really know. That's yep. Okay. Has to do with how chronic stress and daily life stress in our life is a precipitating factor of depression and Alzheimer's disease, and whether there are common neurobiological mechanisms that can connect or support, you know, the appearance of these diseases. And indeed, this is the first stuff we are working on. Here is the identification of etipathological mechanisms that are activated by exposure to stressful conditions or prolonged stressful conditions. The second has to do with the exploration of biomarker potential of exosomes and how stress can affect that. And the third will be about the real novel therapeutic approaches we are following in the lab related to antisense oligonucleotides, which we're doing in collaboration with RNA Therapeutics Institute in Boston, as well as some cannabidiol work and psychedelics we're doing together in a nice network with Christina Dalla, Luisa Pinto, and Dimitris Kapogiannis will really join stuff soon. So basically, what we are doing in the lab has to do with how chronic stress can affect the main mechanisms related to amyloid beta overproduction and tau, and how this can affect from molecular synaptic neuronal malfunction and down to circuits and networks in the brain. Working also, as we told you, with different therapeutics and more platforms, trying to find something that has to do with this disease, which is, besides the amyloid beta and tau that you probably know, the 2 molecules that are abnormal and accumulated in the brain that comes together with a lot of inflammation. But there is also a big heterogeneity between the brain pathology in patients as well as the clinical manifestation. However, there are things that are staying really, you know, common in the AD brain that has to do with the progression of tau pathology that starts from very specific area, the entorhinal cortex in stage 1 and 2, for example, and through the hippocampus it spreads to other limbic and cortical areas in a very specific and always predicted anatomical way. This brings us actually to the hypothesis of the field that probably this very specific anatomical progression we have in tau pathology in the AD brain, it comes via exosomes. So what is exosomes? They are very small extracellular vesicles, very small vesicles that are secreted with membrane all around, secreted from the cells. And this is a hypothesis where, for example, you can see that we have a disease neuron which is full of tau, for example, and it secretes exosomes to the next synaptically connected neuron, which is absorbed directly or through microglia, and there is a lot of work developing in different labs, including mine, about the role of microglia. If they can pick exosomes from a diseased neurons, it can then process and transfer to the next neuron, transforming these to a disease condition. So these are these guys that how they're produced. I don't want to go to details because there is a lot of different audience in the background, but it is part through the endolysosomal pathway that it ends up in the lysosome degradation. It's a normal mechanism that our cells degrade and get rid of whatever is used and damaged in proteins in our stuff, or these proteins can be also secreted by exosomes outside the cells. So we have big discussions about whether exosomes are produced in order to get rid of waste of things or to send specific messages. I think both can be happening based on the literature. So we have two roles indeed that we know in the literature for exosomes. One is the propagation of the disease, as I tell you, from one disease neuron to the next one, directly or through glial. And then we can recognize extracellular vesicles or exosomes that are coming from different cell types, neuronal EVs. Based on the international guidelines of the International Association, we need really to focus on different cell types, neuronal, microglia, astrocyte EVs. And the second, let's say, role is that since they are very small, and it seems that they cross the blood-brain barrier, they go out of the brain, so we can really detect and isolate it in the peripheral blood. A lot of work is developed by Dimitris Kapogiannis. Tomorrow he's going to speak about that. And he's an expert on the field, and we're happy to collaborate with him doing some work for both, as you will see, for both preclinical and clinical work. The very, very important is that these exosomes could work like what we call brain liquid biopsy in the periphery. And that's very, very easy to collect blood in everywhere, even here, if we have some nurses, we could do that stuff. So the idea overall, if it is, okay, now it works better. So the overall idea is that, we have the brain pathology, and that secretes EVs that they contain proteins, microRNA, DNA, that are, let's say, mimicking or mirroring the health status of the brain. And these brain EVs we can collect in the peripheral blood and analyze and understand what happened in the brain. However, there is a lot of serious problems because most of the studies so far, they move directly from brain pathology to the blood. But for now, for the last years, we have a big problem to find accurate molecules that we need to isolate exosomes, because most of the studies doing this big gap. So they go to the blood and they try to correlate with the brain, because there is a problem, it's true, to isolate brain EVs from the brain. So without making a long story short, we have made a new method in collaboration with Bruno Costa Silva from the cancer field, Dimitris Kapogiannis and Clarissa Waits in my lab. It's a work developed by MD PhD previous student of mine, Patricia Gomez, that's now it's with Dimitris and in NIA, and Josephine there. And this, in contrast to the previous methods, the classical methods that they based on brain digestion protocol, so you separate the cells in order to take the EVs or the exosomes outside the cells, we allow the tissue to spontaneously release its own EVs. And without making, I will show you very few data, I don't have too much time, but it's working in both in human and mouse tissue. It's working for small brain areas, we have it published, and also it is, the most important, it gives less EVs, but more exosome enriched. I will show you few data supporting what I'm saying. Yes, well, always we have to do cryo-EM in order to see that this is EVs we have in our side, exosomes. Then we did nanoparticle analysis, and for example, you can see here, even more better in human tissue, that our method, which is the release method, is the red. It's much more, it's almost double the amount of small EVs it gives to us, and it's really reducing the big, because the exosomes are very small. It's between 50 and 150 nanometers. So we need to go in that range, because there's not absolute way to say that this is an exosome and it's not another vesicle that has similar size. So we use multiple approaches. Also, our proteomic analysis, for example, here shows that we have double the exosome-related proteins in our method. I don't go to too many details. And we, together with Dimitris Kapogiannis, NIH, we also used a very complex nanoflow cytometry, which, again, I don't want to go to many details, but we identify CD81 as a new marker, because that's very important to find new markers coming from brain, and we develop further this work in order to find cell type specific EVs for neurons, for different type of neurons, for microglia. This is where all the field is moving. And also we did a very easy seems that there is a problem. No. Very easy. As I told you, exosomes supposed to move from one brain area to another synaptically connected brain area, correct? So we did this. We label our exosomes and we inject in the molecular layer, that's exactly here, of the dentate gyrus. It's the entrance of the hippocampus. And then 4 weeks later, plenty of negative and positive controls. But 4 weeks later, we detect that they're moving to the molecular layer, to the granular cell layer, sorry. And this shows that we have intact and very well functional exosomes by our technique. And known and working on that for the last years that probably Alzheimer's disease depends a lot of the interplay between genetic and environmental factors. Our work has been, focusing for many years on the stress, nice work, and we have given different mechanisms where chronic stress can activate different pathomechanisms related to Alzheimer's disease, including the work with the great work with Professor Ben Volozin for Boston with RNA stress granules, which now my previous postdoc, now a young group leader, he continues in Portugal in collaboration with us in a very nice. So different mechanisms are affected by exposed to chronic stress. And this is preclinical data suggesting that, for example, we have accumulation of tau protein, pathological forms of tau protein by, for example, affected the endolysosomal pathway, the one I told you about that is responsible to exosome biogenesis, as well autophagy, all this, and also affecting mis-sorting and toxicity of tau to the synapses, very important for Alzheimer's disease, establishment of Alzheimer's disease pathology. And here, I just give you some examples of the work we have developed with mitochondria trafficking. Very important because mitochondria are actually the energy providers for our neurons, and as well as they clean synapses after overactivation by absorbing calcium. So very, very important damage done by stress in our brain and multi-level. But as I told you that this mechanism, the endothalasomal pathway, is also involved in exosomes, we have recently checked that chronic stress is also indeed release exosomes from our brain, and we can detect this both in brain and in blood in experimental animals. And that is accompanied by neuronal atrophy and all the other stuff that we know, neuronal atrophy, neuronal malfunction, hippocampal malfunction, as well as proteomic deficits in the brain. So, but we want to see what these EVs, are the extracellular vesicles, the exosomes produced by a stressed brain, how different they are they different from their cargo, what they transfer? And indeed, I don't want to go to too many details, you will see very clear difference between EVs coming from a control brain and EVs coming from a stressed brain. And through a complex proteomic analysis, I've just shown you a few things that, yes, based on the analysis of the proteomic analysis, another analysis of the EVs of a stressed brain, just by analyzing this information of stressed brain exosomes, we can really mirror what happens in the brain, in the tissue itself. Because we see that we have different, very similar footprints. For example, we have cytoskeletal disorganization and reduction of a lot of cytoskeletal proteins. We know that this is happening in multiscale analysis in our brain and in our hands too, in our labs. We have a degradation problems with the proteasome, for example, which I have published also this. And we have a lot of mRNA processing damages that you can see just in the exosomes of brain EVs, okay? So if this is the case, then we wonder, okay, can we, if these EVs from the stressed brain transfer all this information of what happens in the real tissue, so if we give them back, these stressed EVs, exosomes from a stressed brain, if we give them back to animals that are completely healthy, control, they are never stressed, they have no anxiety, no depression-like behavior, or no cognitive deficits, what will happen? And I think you guess well, yes, they could induce cognitive deficits, and they could really induce, I'm just giving you some of the, when we compare the effects of the EVs from stressed brain, we could see similar things like proteomic analysis showing, similar things in the proteomic changes that stress is inducing just by injecting back brain EVs from stressed animals. So these animals, they were never stressed. They just receive exosomes from stressed brain. So that means that these proteomic changes, I tell you, probably also mRNA, we are going now to do some microRNA-seq analysis in order to show what is the, let's say, infectability of these EVs coming from a stressed brain. But, and this is, for example, where we start analyzing, and that's again work from Patricia Gomez, when we start to analyze, that's new data. They are not really in a great format, but we're preparing now the paper. We see, for example, that as chronic stress is inducing inflammation, activation of microglia in the brain, just giving EVs from a stressed brain, but not from control brain, because we also give exosomes from control brain. We have the same structural, and this is many, many data coming also for multi-complex microglia structural analysis. So the EVs of stressed brain induced exactly the same effect as stress itself in the brain. And that was really amazing for us. So we go on with analysis and try to finish the paper. But we also want to see whether the same effects of stress we can also see in tau pathology, because our previous work at many levels and for many years have shown that if you expose animals and humans, actually, there's clinical work suggesting this, in chronic conditions, you have an aggravation, initiation and aggravation of tau pathology or amyloid beta pathology in the brain. So I would like to see what happened with exosomes by using transgenic models like tau ones with brain exosomes. And we see that even in that, we have an increase of exosomes by NTA, this nanoparticle tracking analysis. We could use ExoView, and we see that inside these EVs, they include tau, and indeed pathological tau, and inside the EVs, and even oligomeric tau, we could see by capillary analysis, just in the brain EVs produced by stress. So it seems that stress is loading pathological stuff to this, but we also see, release of tau even without exosomes. So probably stress is doing more things than releasing pathological forms in. And then we try to see whether we could see these effects that brain EVs had, how similar they are to the brain damage, the tau pathology. And again, we find different proteins. I don't want to stay. We just would like to see that we also here see that brain EVs in tau pathology mirror the effect of aggravation of tau pathology induced by stress. Again, suggesting that probably EVs, brain EVs, could mirror the health status of the brain tissue itself. And the last experiment, and I'm finishing, we also use a drug. It's not the best way to do it, but it is the one way so far that we have in our hands, that we try to block the exosome release from the brain by using a drug that it is published in previous studies that is good enough to block or inhibit, attenuate the release of exosomes. And we managed to, we managed to block, as you see here, the effect of stress, the increased effect. So stress here is increasing the release of exosomes from the brain, but this is not happening, or it's happening, but because there is a reduction of controls, this is the case. But very, very important, we see again this effect of stress in the free medium, that it was blocked when we used the drug under stress conditions. And now we also see, yeah, you will see, it's frozen. Can I have some help with? The Qualisound people are very, very good. They are supporting all our seminars. Please go to Hellenic Initiative Against Alzheimer Disease website to see all the previous seminars where different speakers, some you will listen today, but also others where it's pre-recorded. It is the Genedis satellite events we're organizing together with Hellenic Initiative. So to see a lot of talks related to different topics from molecular, clinical, issues and problems in our website. So we are back. Brain pathology. We could also reduce the stress drive, the stress-induced aggravation of tau pathology by using this. That's immunofluorescence. There are more data that we have for that paper. And entering into the last part of the sessions, the therapeutic, it's one slide, just one slide, to show you that we try different compounds that they are really pure, like cannabidiol or psychedelics. And we see, for example, very fast, a very nice recovery when we give cannabidiol to these tau transgenic mice. We have a very nice recovery after exposure to stress. So in other words, and this is memory or neuronal atrophy recovery. So in other words, exposure to cannabidiol in specific doses can revert it or block the effect of chronic stress on tau aggravation pathology. And we have also reduced pathology, as you can see here, and a very, very clear, sharply change of proteomic of hippocampus in, for example, in the animals where you can receive CBD under stress conditions. But be careful. You see that CBD alone can be damaging your brain, because it seems like we have beneficial effects of CBD only when we have a pathology, when we have stress-related exposure, or say pathology-related, not in healthy brains. And this, I'm just concluding what I show you today, that we have produced a novel method for spontaneous release of small EVs in human and a mouse brain. And this offers a novel platform for the study of in vivo genesis as well as modulation ex vivo. It can also be used in other tissues. This is a practice people are using now more often even in cancer for collecting exosomes and try to find biomarkers. We also saw that chronic stress indeed release brain small exosomes, alter their proteome, and this can mirror what happened in the brain tissue. And that it is itself transfer pathogenic stuff related to the effect of stress on the brain, and also that this transmission and release of exosomes under chronic stress conditions could contribute to the aggravation of tau pathology in the brain. And hopefully we will have more to say about cannabidiol, because there are also clinical trials here starting in Greece, not with Alzheimer patients, but with other patients, and probably will go to that direction too. Thank you very much. So if something I would like...
Thanks. Thank you, Yannis, for the nice talk.
Thank you.
Are there any questions to all of our speakers during the session? Yes? I think it's the microphones in the middle.
Nikos Hatzakis, Copenhagen University and Center for Delivery of Oligonucleotide Pharmaceutics. In relation to the last talk of Yannis, I'm wondering whether the stress release affects primarily the protein content and the oligonucleotide content of your exosomes, and whether this could contribute to, for example, epigenetic noise or any related diseases.
Okay, I can use. Thank you, Mano. We have TAC individual microRNAs, but now we are doing the microRNA-seq, and because it's an expensive technique, you're welcome to collaborate with us and do it together for more samples. But we don't know. We don't know.
Yeah, let's talk afterwards.
Thank you. Thank you very much.
Yes, Kostas.
Great talk. Great series. So as you were all talking, the topic being stress, I was reflecting on the people I've interacted with in the last 2 or 3 weeks and trying to think if there was anybody I've seen in the last 3 weeks who are not chronically stressed. So it's, for me, raising an important issue about the definition. So the population studies are pretty much giving up at this point, especially if they're dealing with younger people, about the ability to differentiate someone with a lot of stress or less stress. Everybody has a whole lot more stress, certainly in our environment. So I'm raising the question because ultimately the definition of chronic stress is essential. And my read of the literature recently is that there is not uniformity and agreement. So perhaps you could enlighten us on what's the right definition of chronic stress and how do you measure it at the human level?
I will do the easy work, then they will go with more difficult work. It's true that stress itself does not kill us, okay? It is the way we cope with it. So I have Nikos as a terrible boss in the lab, and I'm his PhD, also Panos. Panos has no gray hairs. I have a lot of gray hairs because of the stress that Nikos is giving us in the lab. We are under the same pressure to produce and do stuff. Panos really doesn't care, and I cannot sleep. I wake up at 4 and say, bloody Daskalakis, he's killing me, I will have no job after that. So this means how I cope with that. Second, biological thresholds, there are no biological thresholds. There are some, actually, speaking with Nikos Stefanis, your friend and the director of the psychiatry clinic here in the Genedis Hospital, there's no depression biomarker. That's why we look exosomes and other stuff, try to understand if there are. But I don't think there is threshold specific that we can say, I cross this threshold and this appears. So it will be much more difficult to say what's the amount of stress that kills Yanis and not Panos, or Panos and not Yanis.
Okay, Nikos, he
Yeah,
personalizes.
yeah. I want to add, like, in the first 20 years of biological psychiatry, they would, try to simplify a solution like measure cortisol, right? And it didn't work out. Many unsuccessful cases of confusing findings, slightly effects, and stuff like that. And I think it's because the question, the test has to be who responds in a pathologic level to stress. And with a single measure, you will never find it. And I think you need a more integrative way, potentially a challenge test, something that is a little bit more nuanced, more multidimensional. And then I think we would be having more, potentially integrating with other type of data, biological and digital. I think we could have more reliable ways of parsing this individual variation. I think because what is universal is stress exposure, but the pathologic stress is it's a unique. It should have some genetic components, some epigenetic components, something more nuanced that could be more reliable, I think. So I'm hopeful for the future, but I think going back to expecting that, in Alzheimer's disease now we have the amyloid beta and tau, right? But they are very critical in the core of the disease. Cortisol is important for when you have a stress response. Everybody will have a cortisol increase, but this is not what you want to find the stress-related pathology. Cortisol increases also when you do exercise, so it's not the right marker. So I think we need, surprisingly, after studying for 80 years biology of stress, that we didn't come up with that yet, but I think it would require more integrative approaches.
Well, just a quick point. I mean, should we be talking about stress response as opposed to stress exposure? Because that's where the variability exists.
Yeah,
I think that's what you're
individual
saying.
variation in stress response, yeah. And the timing of the stress response, a lot of elements of the stress response.
Paige?
I mean, I defer to the from a biological model, both of you, but clinically, I mean, we look at impairment to functioning from a stress response standpoint of how people are doing in terms of their daily life activities. From a biologic standpoint, I defer to both of you, though.
But do you see, by using the application, your application, do you see individual thresholds of something is wrong here in each individual patient? So coming back to the idea of precision medicine, can you, by using different data, biomarkers, clinical tests, can you find kind of threshold or differences between individuals, something that we can, let's say, categorize and say, I belong to the high responders to stress, so please don't, I'm telling to my people in the lab, don't stress me. Okay, so I belong to the really low responders of stress, and you can do whatever, I will respond nothing, I will be fine.
I don't think there's one specific way, going back to what you were saying, we don't have one, completely agreed upon threshold for individuals, but I think individually within different research studies, people often do refer back to impairment in functioning to then, put people into different categories in terms of severity. But I don't think there's one agreed upon operational definition and threshold set, which is an issue, but.
Setting the question a bit differently. Can you have the ability to make the corresponding queries to the system, or to have an extra app for getting results concerning these subgroups of the people you enter the app?
So if I'm understanding correctly, is there a system to
You get log files, you get data from your application. So can you work on them with specific queries?
So we'll use different measures that then will categorize people into different.
You do it, or?
I do, yes. So I will do it in clinical intakes to understand kind of where people are at, definitely. So we'll use different objective tools to get people into different categories for diagnostic purposes too. And it really does then really depend on impairment in functioning. That's really, I think, what helps push us into
This will get a deterministic result on what you're doing. Okay.
I want to add something that a classic thing in medicine is that there are some markers that themselves are not accurate diagnostic on anything, but after you know someone, like you have some individual baseline of someone, they could be informative of how they are on later time point, let's say after stress. So I think if we have markers we could serially measure, we can have this individual baseline, and that individual baseline will be very informative for this particular subject and possibly more meaningful.
In your study, did you see any, or you didn't try to see if there are subcategories in MDD, major depression, or PTSD in response to HP axis dysregulation, I would say, as a better approach, which is not always, because women has higher cortisol levels, but they are working much better than us.
Yeah, there are.
It's true.
In the initial studies, we do the big group comparisons, but I think when we go deeper to the data, we can see in very particular pathways, you can have a subgroup that has more intense participation of a pathway. More intense, and HP axis is one of them that potentially could be more intensely implicated when the survivors had childhood trauma experiences. And you can think of other examples too.
Another question, please.
Hello. Thank you, first of all, to all the speakers. My name is Konstantinos Anargyros, and I'm a resident of psychiatry in Psychiatric Hospital of Attica and a student in the postgraduate program of bioinformatics. My question is for Dr. Daskalakis. Regarding your study, did you have any issues or before any approaches about the methodology of the sample due to the fact that in psychiatry, many patients don't have a simple diagnosis or might show something like depression but with anxiety or some personality disorder alongside the main one? Was this taken into account in the subject? And second of all, were the subgroups based on the type of trauma?
This comes to, in general, in psychiatry and also specifically in PTSD, there is a big amount of comorbidity. So on those brains we're studying, if you actually go to the actual clinical record, you would see that they would endorse many times substance use, depression, and also when you go to trauma, they will, by definition, they will have a trauma A that is part of the diagnosis to form the diagnosis that they had, but then they would have additional experiences, and there will be all possible subgroups that we discussed. First of all, there is no best study. There are approaches of going after it. This is the so-called sensitivity analysis, sub-analysis that we do. I mentioned a couple of examples where we would do analysis focusing on this potential confound and try to see if the analysis that doesn't take into account that confound, is it finding different things? We created a whole new group of subjects, the depression group, at least to, for example, the fact that pretty much all our PTSD cases had some level of depression. Other approach for the trauma issue is we could create the continuous scales of trauma exposure and try to see, things that are focusing on that dosage effect. Do they identify different or similar genes with the original analysis? So I think it's like the beginning of it, and we have provided a couple of those subjectivity analysis, but now we're kind of like following up on this and try to dissect it much more, adding more samples, because power is very much against you when you add too many degrees of freedom in the analysis. So, it to be continued. Yeah.
Thank you.
Professor Volozin, you had a question? Ben was for one of the first keynote speakers we had at the first Genedis in 2014 in Corfu. Ioannis also was there.
I saw you were already kind of going over, so I stepped away. I had a question, probably because we're going over, Nikos had a question. Justin Uchida took these kind of system biology experiments and drilled down to identify a particular hub protein that would regulate multiple things at once and propose that as a treatment in the case of neurodegenerative disease. That's the PIC5 enzyme. And I'm curious, with all of your systems network analyses, if they identify hub proteins or targets, RNA, whatever, that would be that would allow for intervention, novel forms of intervention for PTSD.
Yeah, we propose a couple of ways of how to prioritize those key proteins. We had this idea of one proposition we made was, is convergence in the biological signatures a good characteristic to seek for that particular special protein? We saw that if you impose any type of convergence at the tissue level, omic layer, or multi-trait involvement, we saw that requirement tends to bring in the game a lot of other interesting properties. So that is one thing that worked. And we have done this also previously in animal models of PTSD. And by doing that, common proteins that you would hypothesize emerge, like glucocorticoid receptor, estrogen receptor 1, TNF, STAT3. And we have, in terms of interventions, have worked primarily on the glucocorticoid receptor. The cool part is that you can have those master regulators that operate it that way, but you have to find, develop drugs that can go in a tissue and affect them in a cell type specific way.
Without
that would be the challenge.
Side effects. Right.
Yeah, to avoid, let's say, glucocorticoids affecting all the cell types while you want to affect only the neurons and the astrocytes, and then, which is a big challenge. But I know that there is this biphasic things that you can, have a protein together with something else, try to help it target something specific. But I haven't seen that in the clinic, but my hope would be next generation of glucocorticoid drugs to have some element of that.
So we have to close this interesting. Sorry for, please, we can address the questions afterwards, okay? So we have to close this interesting session. Thank you all. Thank you for the nice presentation and a very interesting discussion.
was refreshing for everybody after a nice but intensive morning. We start a bit late because our first speaker, Dr. Josephine Egan, she didn't manage to come due to some last-minute problems. So we start now on time at 3:30 with Professor Ben Volozin, great mentor, great scientist. He's in the field for a few years, because he's young. However, he has a big contribution on amyloid beta and tau field. With the recent work he's developing, both in human and experimental work, focuses on stress granules. Today, he's going to speak us about the cellular phase of Alzheimer's disease, intersection of the RNA metabolic stress response with tau in neurodegeneration. Thank you, Ben.
Great. Well, it's great to be here. In fact, I do remember the first Genedis meeting in Corfu when I met John. So it's great to be back. Let's see if you can put up the slides. And for the record,
Ben, if you want, you can use the microphone. It's easier.
Yeah.
Because this microphone.
Okay, great. Let's see while we wait. While I'm waiting for the slide, I just want to point out that my name is actually Ben. It's not Bez, but if you want to call me Bez, that's okay. It's a nice color. So once we get these slides up, I will be telling you. I'll just ad-lib it now. There we go. Okay. So first of all, I always need to point out that I have a conflict of interest. I'm also a co-founder and chief scientific officer of Aquina Pharmaceuticals, and we're developing small molecules to treat neurodegenerative diseases like Alzheimer's and ALS. But I'm not going to discuss those in this talk. So just so everyone's on the same page, the basic, this is like the nutshell biology, simplistic biology of Alzheimer's. And the idea is that you have A beta, which is produced here, and it rapidly oligomerizes extracellularly. It then fibrillizes, and those fibrils stimulate inflammation. Inflammation, as, for those of you who may not know, is also oddly equivalent to aging in some ways. It's defined aging phenotype. So those two factors then feed back on the cell and cause tissue damage. Now, they don't cause every type of damage like an explosion. It's a very selective damage that goes through tau protein. And that is the biology of Alzheimer's disease in a very simplistic way. The question is, why tau? Why specifically tau? And the hypothesis, which John talked about earlier, is that tau functions as part of a stress response. And so much of my work has gone to investigate the interactions of this. And what we've shown over the course of multiple years is that tau interacts with the translational stress response. What does that mean? That means that tau controls how the body manages RNA and protein synthesis. And in a very simplistic level, what it does is it matches protein synthesis to meet the available energy. The evidence that tau interacts with the kind of RNA translational system was we first showed in about 2012 when we looked at these proteins called RNA binding proteins, which I'll show you in a moment, migrate out of the nucleus and form these things called stress granules. Stress granules were implicated in diseases like ALS as early as 2006 with TDP-43. And so we showed that phosphorylated tau, shown in green, co-localizes with some stress granules, in particular TO1, but not with others, like a very common stress granule that people use when studying peripheral cells, G3BP. So that led us to investigate why this would be and what's happening. Now, there are many different types of RNA granules. What happens is RNA binding proteins basically act by combing together to form liquid droplets. And those liquid droplets are called membraneless granules. And they control every aspect of your body's functioning. For those of you who've looked in a cell and seen a nucleolus, have you ever wondered how you get that round thing in the nucleus without a membrane around it? It's because it's a liquid drop. And so every structure in the nucleus is controlled by membraneless granules. Every time you think, you have protein synthesis out at the synapse. That's RNA granules doing translation. But when you have stress, RNA binding proteins migrate out of the nucleus into the cytoplasm where they form these stress granules that act to dampen protein synthesis. It turns out a lot of those proteins that make stress granules have mutations that cause ALS or frontotemporal dementia. And so there's something special about those. Now, you can see this we showed this, I think, elegantly, where we took some tau, we attached this Cry2 protein to it that allows it to oligomerize in response to very little light, just like from an LED from a pen light can make it aggregate. And so you shine light on it and it oligomerizes, and as it oligomerizes, you can see that the TO1 that's normally in the nucleus migrates out into the cytoplasm where it forms these RNA granules, and then this whole system begins to form aggregates and actually tau fibrils, and the neurons begin to die, all with a little light shined on that. Now, skipping over a lot of work, we use this system to identify in an unbiased way the proteins that interact with tau as it oligomerizes and fibrillizes. And what we saw was that tau forms a complex that includes multiple different RNA binding proteins, but in particular HNRMP-A2B1 as the most abundant. And that identifies methylated RNA. So we're soon about to send out, it'll be on BioRx, a paper where we've done the methyl RNA transcriptome for AD and control, and that's a whole different story. I won't tell you about that, but what I will tell you about is this question on what is our original protein that we were studying, TO1, doing. Now, we showed that if you go and get rid of TO1, you can actually prevent progression in tauopathy or reduce the progression. So the mice live longer. When you take a tau mouse, knock down TO1, this RNA binding protein, you inhibit stress granule formation. And if you look at multiple different measures, like if you look at the number of neurons in the hippocampus, you can see that in a wild type animal, you will have this many, and then it goes down in the P301S mouse, as shown here. And then if you reduce TO1, you can recover the neurons, so they're protected at least for a while. But we were wondering, that's a global TO1 knockout, and TO1 interacts with many different cell types. It's in neurons, it's in microglia. And in fact, in peripheral inflammatory cells, when you get rid of TO1, it actually stimulates inflammation. So we're wondering what's really happening in each cell type. So we created 2 different mouse models. One, which was we made a conditional knockout where we used the CAMK2 Cre promoter and knocked TIA1 out of neurons, and then crossed it to this P301S mouse that develops tauopathy, and looked at what we saw. And what we saw was what one might expect from what I just told you. If you take a P301S and look at tau pathology, here this is shown with MC1 here, which is a misfolded tau, you get lots of tau pathology. But when you reduce TIA1 selectively in the neurons, you reduce the amount of tau pathology. No great surprises there. And if you look at it biochemically, you can see the reduction of oligomeric tau. I won't go into the details for that, but it's about what you thought might occur, and so only moderately interesting. But when we went and looked at the effects of reducing reducing TIA1 in microglia, we then uncovered a whole biology that was really fascinating. And what I'm going to tell you is a biology that highlights the differences between central inflammatory cells and peripheral inflammatory cells that actually yield opposite responses, which has implications for thinking about inhibiting inflammation in Alzheimer's disease. So previously, Paul Anderson had shown that if you do a total knockout of TIA1 and you then stimulate their joints with LPS, you get a model of rheumatoid arthritis. So knocking out TIA1 is bad, right? Except that if you think about it, that's weird, because I told you knocking out TIA1 for the brain was good. So what's going on? So we created, so when we originally did this, we thought that if we knocked out TIA1, we would enhance the immune response, the inflammatory response in the brain, just like you see peripherally. So we created these mice. We used the CX3CR1 Cre to knock out TIA1, crossed it to a P301S mouse. We then went and isolated the microglia ex vivo and looked at the expression of TIA1. And so we used the Siglec-H to say, oh yeah, we actually have the microglia. And you can see when we look at TIA1, we kind of it was eliminated from the microglia. So the knockout works. When we looked at the pathology, we saw a surprise, because just like with the CAMK2 knockout, if we looked at the P301S here, and that's the PS19 P301S, or the one with the microglial knockout, you can see there was a reduction of phospho-tau, of misfolded tau in general. Reducing TIA1 in the microglia was good, which confused us. And here you can see the quantification of that. And here you can see biochemical profiles demonstrating the reduction biochemically, so we're not kidding. It reduces the TIA1. And we worked with John and Joanna Silva at University of Minho. And if you look at the microglia, it's very obvious that reducing TIA1 is helpful. So here you can see that here's a normal microglia, and then with a P301S mouse, it gets amoeboid, showing that it's inflamed and activated, but you don't see that in a P301S TIA1 knockout cross. And if you look at markers like IBA1, you can see that with the P301S, you get the elevated IBA1 signature. I think it's very hard to see, but you also get an elevated CD68 and reduced in the P301S TIA1 cross. So how is that happening? Well, we looked at the transcriptomes, and what you could see is that this DAM signature, disease-associated microglial signature, was reduced when we in the P301S. So there's an entire transcriptional effect of TIA1. So TIA1's an RNA binding protein. It has two actions. It acts transcriptionally to stimulate genes. It also acts, as I told you, in RNA granules to control proteins in the cytoplasm. So here you can see the transcriptional reductions of all these markers that are associated with disease: CLEC7A, TREM2, CD68, ITGAX, C1q. And when we looked at the used ENCODE and looked at the genes that TIA1 was known to interact with directly, and looked at the genes that were dysregulated in the TIA1 knockout, 50% directly mapped to what was in the ENCODE database. And since the ENCODE database was done on HEK cells and misses all the things done in the brain, 50% is a really high ratio. So almost all of these are likely to be transcripts that directly interact with TIA1. When we looked at, meanwhile, I was worried. We're seeing this reduction in the inflammation, but it's been published already that there is an increase in inflammation peripherally. So we wanted to see whether these same mice exhibited a hyperinflammatory response peripherally. And so we took mice, we injected them with LPS, and then we looked at the peripheral response. And what you could see here, here's wild type and here's a TIA1 knockout. You can see that LPS increases the response in a wild type mouse, and that's accentuated in the TIA1 conditional knockout, just like had been published previously. We saw that with IL-1 beta, we saw that with TNF1. And then, so we knew the peripheral macrophages are responding like had been shown previously. And the next question we were wondering was, what happens to those? Are those macrophages that are hyperactivated, are they still able to get to the brain? Maybe the brain doesn't attract them or something. But so we injected the animals with fluorescent microspheres and looked at how many got into the brain. And you can see that, in fact, there were more macrophages in the brain in the TIA1 conditional knockout. So that says that in every respect, what we're seeing is a dichotomy between the peripheral and the central responses to TIA1. And just to show you that looking in these same cells, we looked in a different experiment, but looked in the brain, and what you can see again is kind of what I showed you before. This one didn't work quite as well, but in response to LPS, you can see there's no like big increase in the TIA1 knockout of these markers in the brain. So periphery and central, different responses. The question was, what's going on? So this is not one of the prettier graphs I've ever produced in my life. Apologies. But what you look for is, we wanted to find the transcripts that were selectively responsive in the blood and not responsive in the brain. And you can see this axis of DDX58, RTP4, and IRL7, all which mediate the interferon inflammatory response. And so that is hyperactive peripherally and not hyperactive centrally. So one aspect of this is clearly that there's a differential transcriptional response, but I told you that TIA1 also interacts a lot with proteins. Well, recently, Beth Stevens' lab produced this paper showing that C1q, which is what mediates synaptic pruning, interacts with ribonuclear protein complexes, i.e. RNA binding proteins and RNA. And so we wanted to see whether this might be what was going on here. So we went and pulled down TIA1 from brain and asked what proteins were binding to TIA1 in the brain. And what you can see is that the top binding protein for TIA1 overwhelmingly is C1qC. We also saw C1qa and C1qb. And when we went and did the co-localization in the hippocampus, we saw exactly what Beth Stevens had seen, which is she used a different RNA binding protein, but we could see C1q co-localizing with TIA1 in microglia in the hippocampus. We also see a small amount of TIA1 co-localizing with C1q in neurons, but that's harder to show. But when you look at the proteome, you can see it. There's TIA1 interacting with all these synaptic vesicle proteins at the synapse, as well as cytoskeletal proteins of the synapse, including BIN1, an Alzheimer's disease risk factor. So this leads to a model. Why is TIA1 kind of protective? The reason is because TIA1 appears to act as a hub. So the idea is, and just to catch you, remember I knocked down TIA1, so when I talk about explanation, if you knock it down and you're seeing a reduced response, that means that normally it's stimulating. So everything's going to flip and be opposite, but here we go. So normally in the brain, TIA1 activates the inflammatory response, and it binds C1q to promote synaptic pruning. That's a hypothesis that we have to prove. It also stimulates production of pro-inflammatory cytokines. Hence, when we knock down C1q in the brain, we block this response, we block that response, and it's protective. While in the periphery, TIA normally inhibits the macrophage inflammatory response, inhibits movement into the brain. And so when we knock it down, we get a hyperactive response. So what this highlights is that microglia, even though microglia are derived from macrophages and are of that lineage, they actually have pathways that are diametrically opposite to what happens peripherally. And in fact, in a number of the GWAS studies that they're looking at multi-omically, comparing the effects seen transcriptionally in peripheral blood cells versus brain microglia, for a number of these GWAS risk factors, they have opposite effects depending on when you look in the brain and peripherally. So as we move forward, thinking about inflammation, this is a wrinkle in the story that the peripheral and the central immune systems appear to have react, in some cases, opposite to modulation. Just acknowledging people who did all this work, Chelsea Weber and Anna Cruz kind of generated the animals and did much of, Anna grew them. Chelsea did much of the work on this with help from Jack Haw, Sophie van der Speck, Alex Taylor, and Joanna Silva did those beautiful microglial tracings with help of John over here, and Andrew Mealy helped with the proteomics. So thanks.
Hello. Shall we have any questions for Ben? I think it's better since we have, another speaker also lost her flight. She will talk tomorrow. So we have this 20 minutes extra time. So is there any questions for Ben? If not, I can ask one because...
Or I can give a talk on an inhibitor of ALS, of TDP-43 pathology. It takes 20 minutes.
So you want to ask something? Okay. So you consider in Alzheimer's disease is it possible that there are things that are happening related with TIA could also from the periphery could contribute? So there is kind of a stimulus coming from tau pathology to macrophages in the periphery, then come back? Or how you imagine or hypothesize, not imagine, hypothesize?
This isn't me, but like David Holtzman, a number of people have shown this recently in Alzheimer's disease, but actually in Parkinson's disease, have shown this as far back as 2013, which is a lesson. If you want to publish in Science, just go and look at what they did in Parkinson's in 2013 and do the same experiment for Alzheimer's and submit it to Science, and you'll get in. Anyway, so what they've shown is that in these neurodegenerative diseases, the peripheral, it's not just that you have an inflammatory response. The peripheral cells, macrophages and T cells, migrate into the brain. You get multiple different cell types, and in fact, there are multiple different inflammatory cell types throughout the brain. There are perivascular immune cells, and so they go, and no one really understands what each cell type is doing. And I would submit to you that actually, in some cases, they might be acting in contradictory roles with each other, or responding to different stimuli. But there is zero question that there is a peripheral component that migrates into the brain. In Parkinson's disease, that becomes even more extreme, where they're proposing, actually in the case of aggregates, that 70% of cases of Parkinson's disease begin in your gut before migrating to the brain. So, yeah.
Nikos has
Fascinating talk. I had a question about TIA1 in more normal states. I wonder if you would comment on the effects like Joe Ryman in Columbia has described on TIA1 in the hippocampus circuit, part of fear conditioning, involving fear conditioning, glucocorticoid receptor.
In Eric Kendall's lab.
Yeah.
Right.
And kind of like a different territory, like unrelated to this, or it's part of a continuum?
I think it's part of the same thing. So we don't have the data. In their work, they've mainly done it behaviorally. And so one of the things that we're doing is we have the proteomic evidence showing that TIA1 interacts with synaptic vesicles. When we look at it through immunofluorescence, the TIA1 is in neuronal soma, you can see lots of it, and you can see lots of it in microglia. We only see a small amount of it in synapses, so we're doing those experiments, but it requires super resolution imaging to really show it. So we're not there yet to prove it. But I think what they're doing is correct, but in more ways than one. So they're saying, oh, TIA1's regulating synaptic function. I suspect it's regulating synaptic function in part directly through interacting with synapses from within neurons, but also through C1q regulating synaptic pruning, which isn't just for pathology, but is also for memory. So that's my intuition. And
the interesting thing they had was also in relation to some colocalization with glucocorticoid receptor, I think, or in some kind of cortisol aspect that I find it.
I wouldn't be surprised, but I don't know that explicitly.
So let's say my question more general would be if the stress is this stress vesicles
Yeah.
also part of more like a intracellular stress response also in the classic sense?
Yeah, so if we take what John, I mean, I like what John's saying because it takes all this tau pathology and removes it from the pathological context and says, what is it normally doing? Something that most of you probably don't know, and this speaks to how old I am, which is that infants actually have abundant tau, misfolded tau in them. Just lots, just like in an Alzheimer brain, except that it's not fibrillar. Their lysosomal systems are still active and can get rid of it. So I was once in the study section, someone said, hey, you know, someone's doing this experiment where they found that tau is expressed in infants. This is a great area to study. And it's like, it is great, you know, and I published that before you were born. But it has a normal function that's not just about disease. It's about, and so John has shown that when you have stress, you get these same phosphorylation responses that you get in Alzheimer's. What's the difference? The difference is that in Alzheimer's, most of the people with Alzheimer's are elderly and their lysosomes are crap. And so they can't get rid of the tau as it aggregates. Whereas if you take a baby, you know, or some of you young, youthful graduate students, and stress you get rid of the tau fine. So yeah, tau is part of a glucocorticoid response, and we actually have some proteomics that we've done that John did, where we actually stimulated DEX into brain and looked at in a tau knockout and a wild type mice, right?
True.
And the tau knockout removed the dexamethasone response or dampened it.
Yep.
So it's all part of that kind of response. In disease, the easiest way to understand that is that it is modulating energy to match protein synthesis, because ribosomes are the most abundant proteins in your body, and they take that's the most energy intensive thing, so just dampen, keep the protein synthesis matching energy. In stress in a young person, it must be doing something differently.
This is how I met him in Corfu. I love to listen to him discussing about different topics. He has an MD background with a lot of biological and kind of system biology approaches from there to there. So, but I need to stop you, Ben.
Okay.
Despite I love you, but we have to go on with a lovable presentation from Vasiliki Maheraki, a great assistant professor scientist. I say great because I know the work. I'm sorry in advance. And she was going to talk us about iPSC-based disease modeling and drug discovery in Alzheimer's disease. Thank you, Vasu.
So first of all, I would like to thank the organizers for inviting me to present the work that we are doing in our lab at Johns Hopkins. So here. So as the title of my presentation says, I'm going to talk about induced pluripotent stem cell-based disease modeling and drug discovery in Alzheimer's disease. So I'm pretty sure that most of you know what stem cells are, but I just wanted to remind you what are the basic characteristics of induced pluripotent stem cells. So what they are is our ability to generate iPS, take a little bit of blood from a single individual, isolate the peripheral blood monocytes, and reprogram these cells so that they will become like stem cells. So they will become like the human embryonic stem cells. There are two characteristics of these cells. First of all is the self-renewal, and most importantly, their ability, their multiple potential, that's why they're called pluripotent, to generate all different types of cells in the human body. So they can generate neurons, muscles, cardiomyocytes, etc. What is the advantage of using this type of cells, the human-induced pluripotent stem cells? First of all, and I will focus on this, is since they are, you can isolate, you can reprogram them from each individual, you can isolate them and you can generate a patient-specific cells. So we have the ability, and I will explain more, to talk about precision medicine using these cells. Also, we can model the human disease in vitro, and in the future, and actually in the near future, we can use the cells of the same individual for cell replacement. I'm not going to give you a big background about Alzheimer's disease. You heard already a lot of background about the disease. I just want to mention only a few things relevant to this presentation. We know that there are no treatments for this disease. Only the ones that we have, and you heard this morning session, they can only modestly slow the progression of the disease. Since 2003, 98% of the drugs have failed. And most importantly, we can see that the patients of this disease, they have an heterogeneity in the disease onset, in the disease progression. Also, the symptoms are different in each patient, and also the response to treatments. So the idea here is that Alzheimer's disease is not a single disease entity, it is an heterogeneous disease. And you can see that it depends on different patients, they develop different symptoms in different time frames. And they respond in different drugs. So we really need to talk about precision medicine. So in the lab, we are using human-induced pluripotent stem cells as a precision medicine approach for Alzheimer's disease. So what we are doing is we take blood for patients, from hundreds of patients, that they are participants in the Alzheimer's Disease Research Center at Johns Hopkins, that the clinicians have access to their clinical data, like MRIs. Then we use this methodology, which is called reprogramming, to generate the iPS cells from each of these individuals. And then we can differentiate to different brain cells, since we are talking about a disease of the brain. So we can generate neurons in our in vitro system. We can generate different types of neurons, like serotonergic or cortical neurons. We can generate astrocytes or microglia, the immune system, and also brain organoids that I'm going to focus in my presentation today. So the idea is that generating these different cell types from each individual, we have the ability to model the disease for each individual in our Petri dish, and also test different drugs and see how each individual responds to these drugs. So what we are doing is we recruit the healthy individuals and patients, and we generate their iPS cells. This is a schematic representation of the whole process. Oops. It doesn't move. Back and forth. Okay, here. And then, since we generate these iPS cells, we make a stem cell bank. We have the stem cell for each individual in the lab. But in order to make sure that these are true pluripotent stem cells, they need to pass a quality control, yes? So we start with the morphology, since iPS cells, they have a specific morphology. We do a karyotyping for each of these cell lines, and we test if they are true pluripotent cells with different markers for pluripotency genes, and with different methodologies. And we also use what we call spontaneous differentiation. This is a test to prove that these cells can have the ability to differentiate to 3 different lineages: ectoderm, mesoderm, and endoderm. And this is the ultimate test to generate good iPS cells. As I mentioned before, I'm going to focus on the organoids. In the lab, we have the ability to generate pure cultures of these different cell types, the astrocytes by itself, pure cultures of neurons, pure cultures of microglia. Why we are doing organoids? They call it also mini brains, okay? We call them cortical organoids because we want to have a better representation of the human brain morphology, because these are 3D spheroids, okay? So, and this is actually very important for Alzheimer's disease modeling. So on top, it's a schematic representation of, and without many details, of what we are doing in order to start from human iPS cells to finally generate organoids. And here, there are actual images starting from human stem cells and all the way to these 3D spheroids. So starting from human iPS cells, we can make what we call embryoid bodies, that they are spheres that they can mimic the blastocysts during the embryo development. And by adding different factors in our culture, we can generate these 3D spheres. And as you can see, they grow in these, what we call bioreactors. They are steering bioreactors so that they will have a better oxygen diffusion and nutrient absorption. So they can grow for many, many months, even more than a year in our culture. And this is, I just wanted to show you how they look in our incubators, and I hope you will be able to see how these teeny tiny spheroids, and it's really fascinating to come every day in the lab and see them growing, okay? So what is the great thing about these 3D spheres? First of all, they mimic the brain structure. So the cells are not just randomly, it's not just a ball of cells with neural precursors or neurons. They have a structure. So they are mimicking, to some extent, the structure that, and the organization that neurons have in the human brain, generating different layers, as you can see, of neurons, and different types of neurons. But also, you can see that they have also astrocytes stained with different markers, and also oligodendrocytes stained again with specific markers for astrocytes. So you have a better representation of the structure and of the cell types that you can have in a mini brain. But what about the pathology? And why I said that these are models that are better for Alzheimer's disease? Because since they are growing in these 3D cultures and they have all this, and they can develop all these cell types inside the brain, so we can grow them for many months, allowing the disease pathology to develop. So if we stain with specific markers for AD pathology, for example, AG8 is a specific marker, a specific antibody, which is a very broad antibody that they have been using for years to detect plaques in the human brain or in the mouse brain. We can see that we have aggregates after about more than 3 months of culturing of these cells. But also, they can also develop hyperphosphorylated out if we use another antibody, PFH1, another known marker for this pathology. So now we have very nice models for this to study the disease in vitro. So I'm going to give you one example how we can use these organoids, this in vitro model, as drug screening platforms. We can do many things. We are doing transcriptomics, we are doing extracellular vesicles, disease secretion, and how we can use them as biomarkers. But in this case, I'm going to explain to you how we are using them as drug screening for drug screening assays. So many of the Alzheimer's disease patients, they develop what we call neuropsychiatric symptoms, like agitation, depression, psychosis, in different stages of the disease. And we believe that a dysfunction in the serotonin system, either the misregulation or of serotonin in release or uptake, can cause these different types of neuropsychiatric symptoms. And this is a serotonin system, which means that serotonergic neurons are responsible for this. Again, there is a heterogeneity in the Alzheimer's disease patients regarding this NPS syndrome. As for clinical variability in the time and also the type of the symptoms, but most importantly, there are no many drugs that can be used. Only the ones that we are using now are the SSRIs, and these drugs are only effective for a subgroup of people. So how we are approaching, what is our precision medicine approach to address these issues? So we are generating iPS cells from healthy individuals, also from individuals that have Alzheimer's disease but without the symptoms, and Alzheimer's disease patients with these symptoms. So we can generate many iPS lines that we store in the lab, and then, as I already showed you, they pass the QC control, and then we make organoids from each of these individuals. We are talking about hundreds of organoids in the lab so that we will be able to use them for different types of experiment. So this is a schematic representation again, without many details by adding different factors. And here is how we can bright field microscopy from iPS cells and how the organoids, they grow. These organoids, since I told you before, we are trying to study the NPS, and we said that this is a serotonergic default system. These organoids are a specific type of organoids. We call them hindbrain organoids, that they are enriched in serotonergic neurons because these are the neurons that we want to study. So after we generated these organoids, we call them hindbrain organoids, we characterize them, which means we want to see if what we produce in the lab are true organoids with serotonergic neurons. So we use different methodologies. I'm going to show you only two of them, like RNA RT-PCR, to see if they express markers for serotonergic neurons, and you can see upregulation. And we can use also immunostaining for specific markers against. This is a large images of this area, where they can secrete, where you can see serotonin staining. So after we are confirming, we confirm that they have these neurons, serotonergic neurons. Are these neurons are dysfunctional? So do they secrete serotonin as they do in the human brain? And we saw that even 27 days after we have these organoids in the cell culture, we can measure this ELISA secretion in the supernatant. So now we have a very nice platform that we can see that we have organoids, we have the serotonergic neurons, and they are functional. They secrete serotonin. Also, after doing proteomic analysis of Alzheimer's disease versus healthy organoids, we detected about 7,600 proteins. Out of them, about 7,090% are common in both the organoids, but about 10%, which is very interesting, is differentially expressed in Alzheimer's disease and in healthy organoids. And as you can see here, it's very distinct, the separation in the volcano blot, but also in the heat maps. These are the latest data, and we also saw the interesting thing that these differentially significant expressed proteins, they are also involved in different metabolic pathways that they are related to Alzheimer's disease, but also in the serotonin system. So now we have a very, very nice system that can generate serotonergic neurons. So how we can use them as a drug screening? So one of the drugs that is an FDA-approved drugs are SSRI drugs. It means serotonin reuptake inhibitors, or selective serotonin reuptake inhibitors. They are FDA-approved drugs, and what their function is just to have a high affinity on the serotonin transporter. So they inhibit the reuptake of the serotonin, so we have increase in the extracellular space of the neurons. So what we see is After we add 1 hour after we treat the organoids with these SSRI drugs with different concentrations, we have an increase, which is a dose dependent in the serotonin in the extracellular space. More importantly, what we saw is variability. So testing these different drugs in different individuals in the organoids, in their organoids, we can see some of them, they can respond differently of some others. Some of them, like for example, healthy, here individual and this one, they don't respond at all. But others, you can see a 2 to 3-fold increase in the serotonin secretion. And this is, as I said, it's a sense of variability because the cell lines are few cell lines to be able to subgroup the patients and say, oh, this is a group and this group responds different because it's a small number. So the ideal thing is to generate many more, hundreds of these, so we will be able to see and make these groups that they respond differently. And actually, that's what we are doing currently, like have more than 30 IPS lines with Alzheimer's disease patients that have NPS and not NPS, before and after giving the drug. This is something that we are doing currently, and we can see that there is still different people, they respond differently. And, I just want to thank all the people that they work in my lab, some of my collaborators. These are the people that they work in this specific project. And this is the funding that we have in the lab. Thank you.
Thank you, Vaso. I think you take the microphone for the questions. Plenty of questions. Shall we allow if they're not, you're welcome to start. So you can, you have a microphone. It's up, if you do it.
Thank you very much for a great presentation, excellent work. I wonder, do you have in your cohort of patients, of hundreds of patients, some patients that have presenilin gene mutations, and if they have different pathology or something different from the rest of the group? This is my question.
Hello? Yes. So this one, this is the last study that I showed you. It's only sporadic AD. It's not familiar. They don't have any mutation. So that we didn't want, this is actually from a clinical study that they use these SSRI drugs. And we only choose only sporadic. We have in the lab many other presenilin 1 and other mutations familiar that we are going to work more on this. What we saw is in other study in terms of pathology is the ones that they have, they are familiar, they develop faster the pathology than the sporadic ones. And in the sporadic ones, some of them they develop the pathology and some not, or different types of pathology.
Thank you.
Nikos Hadzakis, Copenhagen University. I have two questions interrelated. The first one is, what is the heterogeneity in your spheroids, in your organoids, and how many of them do you need to have a readout so as to have a statistically robust analysis? And the second, which is downstream of this, is how scalable is your assay? Can you actually apply it to 1,000 humans or 1 million?
Yes, so it's a very good question because when people that they are working with organoids or spheroids, there is always this question about heterogeneity in terms of the size. We have published actually this data, and we have shown in the paper, and we have an algorithm that shows how homogeneous these organoids are. So we have optimized the protocol. What we see is at the beginning, the first month of growth, the organoids, they start growing in a different, even though we start with a specific number of cells, we can control the number of cells that we put in the organoid, but then they reach a plateau and they become all homogeneous. Otherwise, it would be very difficult if they are heterogeneous to have this any conclusion. And
Scalability.
Scalable, yes, of course. So having this bioreactor is actually spinning flasks. Okay, you can have about 50 organoids in each of these flasks, and if you have bigger ones, you can have hundreds. So you can definitely scale up. Depends on the funding that you have, of course. Yes, you can definitely scale up. And that's the beauty of this, because you can, as I said, you can use hundreds of organoids to be able to have some statistical data.
Thanks, Yorgos. Paul?
Paul Rosen from Johns Hopkins. I know your work pretty well since we work together.
Yes.
But it doesn't mean I understand all of it since I'm a clinical researcher. What's the scientific added value in these experiments of using organoids instead of just cells in culture?
Yes, this is something that I didn't mention at the beginning. These are, as you know, samples from a clinical study that, of course, we don't have access to patients. We don't have access, us as researchers, to the clinical data. This study, as you know, it just finished. That the patients, they had NPS and they had this, some of them they had SSRI drugs, some of them not. It was blind. So now, generating all these organoids from these patients, now we can go back and ask from you, the clinicians, what are the clinical data and see if we can correlate our data, meaning how these organoids respond to different drugs, and have the clinical data if your patients respond in the same way, what we see in the lab and what you have. So what I mean is that we can see how these cells can respond and how we can, how each individual can respond to each drug. And we can subgroup these patients and test this drug for each person, and know that this patient can respond with this way.
Can you do electrophysiology on these?
Yes. I didn't show the data because I told me you have only 15 minutes to talk. We have done electrophysiology and using MEA, multi-electrode plates, where you grow the organoids on top of electrodes, and we showed, yes, and we saw differences in Alzheimer's disease organoids and in the healthy ones.
Thank you.
Yeah, this is a major functional test that we are using.
Nikos?
I had a small question and comment. I imagine that it's an elegant study, and also I appreciate how painful it is to get high numbers, right?
Yes.
So I wonder if one of the thoughts you guys have in the continuation of the project is to, because presumably the biggest part of the disease signal comes from genetics in an iPSC-based system. So I wonder if, and we know that there is some evidence for a causal, partially mediated path from polygenic genetics of depression to Alzheimer's disease. I wonder if you could select based on MDD-PRS, MDD-GWAS-PRS, lines of AD patients that have high depression genetics, and presumably show that those guys are the ones that mostly show the serotonin-based phenotypes in your culture. And
Yeah,
I imagine you guys are thinking of strategies.
I think that's a great idea.
Yeah.
I think that's a great idea, and the thing is that my lab is part of the Precision Medicine Center in Alzheimer's disease at Johns Hopkins. So we are working with many clinicians. Some of them are here. So we can work together to select, as you send these patients, so we can generate these organoids. And yeah.
Actually, two questions. First, do you see signs of neurodegeneration?
Yes.
You see neuronal death, good. And the other question is whether you have, do you have fibroblasts from these patients also?
So it depends not from these ones, but we have fibroblasts from a different cohort that actually we are going dural fibroblasts, actually, we have. That we are planning to start working with them now and generate, so we have autopsy brains, we have dural fibroblasts, and we are planning to generate iPS cells from these fibroblasts, and then compare, differentiate to organoids and compare with transcriptomics, proteomics, and compare what we see with the autopsy brains. But it's not very easy to find this type of cohorts because you have the autopsy brains, which is, limited numbers that we have, and dural fibroblasts to make.
Any more questions? Okay. If not, we should move to the next speaker, but I'm not sure if Arno is here. Yes, sorry. Because the lights I could not see. So, Professor Arno Wiesringer, he is the director of the Department of Neurology in Max Planck Institute of Human Cognitive and Brain Science in Leipzig. And his title is Why Cardiovascular Diseases Are Neurological and Vice Versa. Very interesting title. Thanks again.
Thank you, the organizers, for putting together a wonderful conference. Thank you very much. I'm very happy to be here. Could I have the slides, please? Yes, this is actually, in a way, the real title of my talk. But for you guys, serious scientists, I gave it another title, a more sober title, Why Cardiovascular Diseases Are Neurological and Vice Versa. 3 women, a cardiologist, a neurologist, and an engineer, are sitting together in the evening drinking wine. And they are discussing about the origins and what produces emotions. The cardiologist is very clear. She says, come on, we know since millennia, since the old Greek philosophers, it's the heart. The neurologist is angry. She says, come on, haven't you listened to the last 100 years of neuroscientific research? Every thinking, every mental activity, of course, is in the brain. The engineer says, I do not really know much about where the emotions come from, but please give me signals. If you give me signals from the heart, if you give me signals from the brain, then we look at emotions, and then I will tell you. This experiment has actually been done. So people have been classified, of course, fancy AI, machine learning, based on either cardiovascular signals or either neural signals, EEG. The task of the classifiers was to classify emotions, happy, angry versus sad. And as I said, a cardiovascular measure was ECG or plethysmogram, and neural measures were brainwaves, EEG. Now, look at the classification accuracy. Based on ECG, PPG, cardiovascular measures, it's 76.8. If we look at neural measures, it's 76.9. Is that surprising? So the engineer says, maybe both are important for emotions. And maybe, she says, maybe even more, maybe for other mental functions. Maybe they also involve the heart and the brain to happen. And that's actually a kind of research stream that we and others have been trying to follow. What is the role of the heart in mental function? And of course, let's start again with emotions. And just to give you many examples, so the underlying reason why the classifier works for both is that each emotion, whatever emotion you have, it's briefly associated with an increase or decrease in heart rate. Also, if, for example, you have a threatening stimulus versus a non-threatening stimulus, you can differentiate them based on a decrease in heart rate. Or in this study, if you just look at faces, whether you know them, whether these are loved ones, and also if you look at names already, your heart rate will increase, and it will increase differentially, whether the faces you observe are loved ones, your spouse, or whether they are neutral ones. Even for names, that's the case. And already several studies, and I think this is a very pioneering and almost definitive study, shows that also in animals, emotions, and especially fear has been studied very, very often, are always integrated, what Devoto here calls neurobehavioral cardiovascular microstates. So for this freezing associated with fear and anxiety, you have a sharp increase in heart rate together with the freezing. And he also differentiates different macrostates. Some animals, maybe diseased animals, or with other genetic disposition, have not an increase in heart rate, but a decrease in heart rate. And he speculates that this could, in the human arena, may be associated also with diseases. I come back to that later. So back to the emotions. So emotions are typically classified according to arousal and valence. So for example, happy has high valence and high arousal, whereas sad has low valence and low arousal. And now you can also classify them together with the changes in the cardiovascular system into happy, having high valence, high arousal, heart rate increases, sad, it's almost the opposite, and angry is a differentially defined cardiovascular neurobehavioral state, which has a different dimensions, so different cardiovascular and neurobehavioral dimensions. So, but each of them you can classify as a cardiovascular neurobehavioral microstate. And for the psychologists among you, this is not a completely new idea. So the James Lange theory has been around for more than 100 years, which actually states maybe the origin of emotions may be in the body, that physiological arousal instigates the experience of emotion. It has been controversially discussed until today, and actually one of the best studies actually has been published in Nature last year of the Diserot group, because so far it was always very difficult to separate heart activity from brain activity, to only stimulate one of them. And in this study, using optogenetics, they only stimulated heart rate increase in mice. So they have an isolated heart rate increase with optogenetic stimulation. And they wanted to see whether this tachycardia elicits anxiety-like behavior. And it does, but only if the animals are in a certain, for them, threatening environment. And they also show that this anxiety-like behavior goes along with activity in the posterior insula, which is a well-known area for interoception. And if you inhibit that, then it prevents anxiety-like behavior. So the conclusion is that the posterior insula is a potential mediator of bottom-up cardio-interceptive processing. Inhibition of this attenuates the anxiety-like behavior, but most importantly, you need both for understanding and defining that anxiety behavior. So for emotions, yes, we can say that we need the heart and the brain in order to constitute that what we perceive as a whole as an emotion. Now, is there a function for the heart also for other mental functions other than simple emotions? For example, for perception, for learning. Now, if you look at simple perceptual tasks, in this case, for example, you give a small tactile stimulus and you just check whether people perceive or not perceive that stimulus, then you see that there is in both instances a heart rate deceleration. However, from the heart rate deceleration, you can identify whether the stimulus has been perceived or not perceived. In a follow-up study, we were able to show that actually this heart deceleration not so much reflects conscious perception, but it reflects the feeling of certainty. If I'm uncertain, then I have a strong heart rate deceleration. If I'm very certain, the heart rate deceleration is less, or even the heart rate goes up. In other words, also these functions basically are intrinsically linked to heart rate changes. And there are many, many other examples. External touch versus self-touch is a very old study which I stole for historical reasons. Also, the type of touch, whether the touch is from a person or from a computer, from a known or unknown person, also reflects differentially in heart rate changes. Or in this study, we were able to show that during a simple game where you get rewarded with simple smileys, this, the feedback and also the prediction error is actually best encoded in changes, decreases in this case, in heart rate. So actually at all mental functions which we looked and where we measured heart rate and cardiovascular parameters such as blood pressure and heart rate, there was always a change, orienting response, perception, learning, like prediction error, reward, punishment, decision making. It seems that all mental activity is always associated with a cardiovascular change. And it also seems, if you now look, what does the cardiovascular change reflect? It typically reflects what we could call feeling, like the intuition, the gut feeling, my heart flutter if I'm nervous. And these kind of things seem to be related in the cardiovascular aspect, in the cardiovascular dimension of what I call cardiovascular neurobehavioral microstates. And so here just an example for different types of perception, whether you feel them confident and unconfident, you have different perception, confidence, and you have different cardiac responses. So again, these different, pretty serious perceptual tasks also reflect different cardiovascular neurobehavioral microstates. Now, these were examples where basically you could think there is some activity in the brain and it impacts on the heart. Does it also go the other way around? Are there also indicators of bottom-up effects? So if the heart beats faster or slower, or maybe during systole versus diastole, are there differences in mental function? This is what we studied systematically, and actually it was a coincidence that we looked again at perception of very weak near-threshold somatosensory stimuli. And what we did in that study, we recorded an ECG, and then we just post-hoc checked whether stimuli in systole or in diastole are more often consciously perceived. And so these are the stimuli, electrical stimuli, and what you see in the lower right is, yes, the hits, when we perceived it, were much more often in diastole, and the misses, which were not perceived stimuli, were much more often in systole. So it seems that in systole, perception is worse than in diastole. And Israel confirmed this finding by also showing, again, diastole, we perceive stimuli better. We also showed that there was a stronger, not heart-evoked, somatosensory-evoked potential in diastole, reflecting the higher perceptual impact a stimuli has in diastole. Now we said, okay, so maybe the heart is modulating brain activity, so the brain is more active in diastole. If you look at motor behavior, it's the other way around. Movements are preferentially started in systole, as Stella Kunzendorf showed in this study. And then we asked ourselves, maybe there is a difference between the change during the heart to each cardiac cycle between perception and motor. Let's see, what about the excitability of the motor cortex in systole versus diastole? Is it really increased in systole? And yes, this was the case that we showed in this study. In systole, the TMS, magnetic stimulation evoked potential in the brain and in the muscle was stronger than in diastole. So there seems to be a differential impact of each cardiac cycle on what happens with brain activity. Other examples from other groups, emotions are stronger in systole, and a quite worrying study which shows that if you measure some measure of racial prejudice, you find in this study by Garfinkel-Cruz that racial prejudices are stronger in systole and are absent in diastole. Controversial study, but it shows that that there seems to be even an impact on higher moral decision making depending on what the heart does. So, but what we can conclude is with each heartbeat, there is a structured modulation of brain function, and people use this also. For example, this is a study in which people who do shooting, sports shooting behavior, and actually if you look at professional people, they only shoot in diastole, and the people who just start shooting, they only shoot, or they just shoot randomly between the two, and shooting in diastole is associated with a better performance than shooting in systole. So we unconsciously know this, and also we behave accordingly. So literally, from heartbeat to heartbeat, there are structured top-down and bottom-up effects of mutual influence between the heart and the brain, consistent with the idea of cardiovascular neurobehavioral states. Now, what about possible long-term states? Now, I come back to our 3 women. On another evening, they have now looked at all this evidence. They are now convinced that the brain and the heart are continuously interacting during each function. So they ask, now, what about diseases? So could it be that all brain diseases involve the heart and all heart diseases involve the brain mutually? Now have a look, which would be logical from the findings on these microstates. Now let's have a look. What about possible long-term cardiovascular neurobehavioral states? And now if you look in the literature, cardiological diseases versus neurological disorders, of course, there is a big literature, but it refers to very extreme cases. Now, we and others here, our study, where for some time ago, we showed that if your heart stands still, so if you have a heart failure, acute one, yes, you will have long-term changes that you see, especially here in the midline. And even if you have no standstill of the heart, but if you have chronic heart failure, Carsten Müller was able to show that also that leads actually, despite any absence of stroke, to severe atrophies in midline structures of the brain. So, there are many other examples. For example, if you have atrial fibrillation, you have little emboli, and this also affects cognition and the brain. But these are in a way extreme examples. And also on the other side, does the brain impact the heart? There are also some extreme examples. Maybe you know Takotsubo cardiomyopathy, better known under broken heart syndrome. In strong emotional situations, some people, mostly women, develop cardiomyopathy, so a failure of the heart, which obviously is produced by a strong stimulation of the heart by the brain, so a strong top-up, exaggerated top-up. And another example, which has recently gained a lot of attention, is that with a stroke, which is primarily a brain disease, if the stroke actually happens in the anterior insula, the region which I told you is responsible for interoception, if that happens, then these people are very likely to have also a myocardial ischemia. And actually, most of them have at least a mild cardiac damage as indicated by elevation of enzymes like troponin. So in the extreme cases, it's very clear that there are strong relationships between heart disease and brain disease. But can this mutual impact during the extreme cases be generalized? And now I want to give you an example of a much, much minor cardiovascular.
It will be a long, sorry, it will be a long example or short? Because we're running out of time.
Okay, so...
No, you can go. I'll just try to make it
so
short.
5 minutes?
Example.
5 minutes?
No. 3?
3, okay, I will try to rush through.
2, we get, there will be a lot of discussions, I'm sure.
Okay.
So the less time you use from now on, the more discussions you're going to have it.
Okay.
Thank you.
Okay. So then I rush through the hypertension example. Basically, what we show in a study by Lina Schare is that chronic hypertension goes always along with a reduced mental state, and actually high blood pressure, on the other hand, goes along with a better well-being. And the reason, most likely, and we confirm this in a study based on the UK Biobank, the reason most likely being a differential relationship between what happens in the heart and is mediated via bioreceptors to the brain, and how this is perceived in the brain. And if you look at so increasing blood pressure leads to higher well-being. The diagnosis of hypertension is lower well-being, and actually corrected for blood pressure, people with future hypertension already have lower well-being. So there is a strong relationship between blood pressure, hypertension, and well-being. And having said that, illustrated also here, so basically blood pressure leads to a continuous change in valence, well-being, and arousal. And also, I haven't shown that, but I tell you now, also it changes how I perceive emotions. With higher blood pressure, I perceive emotions differently than with lower blood pressure. And so from that, I conclude that hypertension is a long-term neurobehavioral cardiovascular macrostate, which influences all other microstates. And I can tell you the same for all these so-called cardiovascular diseases and diseases of the brain. Hypertension is a risk factor for all of them. It carries over its consistent behavior, but independently of that, each of them involves both the cardiovascular and the neural system. In summary, if three women have interesting talks, let's listen to them. And I thank all these people who've done this work.
Thank you. After drinking my wine, I have to take my hypertension pill. And one question, please, no more. I have three in mind, but anyhow, Dimitri, you want to?
This was a fantastic talk. I was wondering whether you looked at all at the effects of something like caffeine that affects the heart.
Yes. I mean, I can tell you if I drink, the personal experience is that caffeine immediately or very rapidly improves my mood. And I'm pretty sure that a huge portion of this is related to a blood pressure. I think, so I'm often asked, where is the relationship between blood pressure, which immediately leads to higher well-being, and where is it clinically relevant? And everybody of you who has ever treated patients knows if you give them antihypertensive, they are immediately much worse. We tell them it gets better. Yes, it gets better, but the effect is mainly driven by acute decrease in blood pressure. And if we take that into account, I think, for example, for the compliance of patients, it would be extremely important.
No more?
If it's possible, please, because we are running out of time. Thanks.
I'm around. I can talk to anybody.
Thanks a lot. Thank you.
Thank you.
So let's move to the next. The next speaker, which is Professor Clifford Kendros, or Kleanthis, his Greek nickname. He's from Kavli Institute of Systems Neuroscience in Norway, and has a very, very also interesting talk, which is cell-type specific digestion of neuronal circuit of memory. Very keen of listening to you. Thank you.
Yes, so this will be a very different kind of, it's the wrong talk, I'm afraid. The one that starts with the picture of the, not that one. That's Christos. I think that's the next one, yeah. So, in the meantime, I'll vamp. Yeah, I am. There we go. Exactly. Right. So, so my father is Greek, was Greek. My mother is Swedish, was Swedish. And so I'm an American who's now in Norway, and it kind of makes sense because the old joke is that my father asked my mother to marry him, and she said, "Nej, nej, nej," which means no in Swedish, but yes in Greek. So that's kind of, that's the one, exactly. Okay, so this is,
I am a basic scientist, okay? We do systems neuroscience at the COVLE, which is basically trying to figure out, explain the behavior of the animal in terms of the behavior of its neurons, right? So we are interested in memory, right? But I would say that basically our understanding of the brain is kind of at the hunk of brain level. But to understand how it actually works, we need to dig down into not the hunk of brain, because every hunk of brain's got all this incredibly complex circuitry in it that's made up by all these thousands upon thousands of different neuronal cell types. So when I talk about cell types, I mean, I kind of dig deep in there. And still, though, why am I here, right? Because our lab actually, doing our basic science kind of stuff, realized that the same thing is true of neurological disorders, right? As actually Nikos and many others here are showing, the cell types themselves may actually be the most important things. These diseases are not necessarily diseases of the whole brain, they're diseases of particular cell types in the brain. So, yes, that works. So we're interested in using these things basically to try to take the brain apart like as if it were a radio. Express things that can change activity, right, in particular neuronal cell types and see how it affects the firing of other neurons, right? And the particular area we're interested in, does this thing have a pokey thing, or no, it does not, or yes, it does? Okay, no. I'll just point at stuff. Oh. Okay. Hold it down for a little bit? Okay. No. Around, is the top one? Yeah. Yeah, okay, I'll just keep it down. You know, I'll just use my hands. So basically what you can remember everything, because everything basically dumps into the entorhinal cortices. That's what we're very interested in. And then they talked, the deep guys talk to the peripheral guys. The peripheral guys then talk to this thing called the hippocampus. Hippocampus is this whole loop in the center of the brain is basically crucial to memory, right? And that's what we're interested in, basically what changes in your brain when you learn something. So if you record from neurons, right, in the hippocampus, for instance, the loudest thing you see is what we call the place cell effect, which is that they fire, as you can see over here, in a particular part of a particular environment, okay? And my colleagues upstairs at the Kavli Institute then found in the entorhinal cortex, you get a different kind of spatial cell, which fires in these regularly repeating kinds of firing fields, the so-called grid cells, right? They shared the Nobel Prize, O'Keefe and the Mosers, in 2014 for these discoveries. But it's basically like, if you think about it, it's like particular places here in the hippocampus, right? And space in general, like Kantian space almost, in the entorhinal cortex. So we're very interested in how these things do. Place cells are basically like if you go to a mall, you need to find something, you got to look at one of those maps, you need to find where you want to go, and you need that big red arrow that says you are here. So the first time I came in here, my hippocampus reorganized and then basically shows this environment. So this reorganization is called remapping, okay? And what you can see is basically, this is the old way of showing the cells. The same neuron, there's 4 rows, each one's a neuron, the hippocampal neuron, in the same environment, fires in the same place, but when you put the animal in another environment, fires in totally different places, unpredictable places. So makes sense, you can do this, because how many places can you learn? A lot, right? So we started to mess around with the different cell types. How much do these grid cells in the entorhinal cortex affect these place cells? We used a chemogenetic manipulation of just these cells, right? And we found that we could actually make the animals remap in a totally familiar environment just by manipulating the activity of these entorhinal cells. Old stuff, right? And then we realized that having these cell type specific tools were really good for systems neuroscience, so we started looking around at real molecular biologists, learned the techniques they use, something, in this case, something called CHIP, did microdissections of different brain regions, and then tried to see, well, basically, this is Stefan's work here. It turns out there are ways to identify these things called enhancers, right, which are kind of what tell promoters where and when to express genes. And there's only like 24,000 genes. I think there's actually more neuronal cell types than that. But there are arguably millions of these enhancer sequences in the brain. And indeed, a lot of times when you do like a GWAS study, that's what comes up, is this non-coding DNA, which we used to call junk DNA. And the interesting thing is, if you take very closely related medial versus lateral entorhinal cortex, very closely related brain regions, and look at them at the enhancer level, they're about as different at the enhancer level as the brain, as the liver is from the kidney. Huge numbers of enhancers specifically in the brain. And even nicer than that, you can take these enhancers, these peaks that you only find in one of them, right? Stick them into another vector with a heterologous promoter, right? And what you get from this, from these non-specific genes, right? Oops, yeah. So here's what the gene looks like. It's all over the place. You can make a transgenic animal that just expresses in one cell type in the area you're interested in. It can do it again and again, different enhancers, different cell types. But again, you're targeting, in this case, the entorhinal cortex, right? And then later, Rajiv actually in the lab showed that you can not just do this with transgenics, but you can actually do this with viruses. So there was, I don't know if the guy who asked that question is still here, but this is the idea, right? You can make viruses, basically, that recapitulate. Here's the transgenic animal, same enhancer. Rajiv finally figured out how to make things be quiet and recapitulated the specificity of the expression in an AAV virus. So the kind of stuff we do is basically circuit breaking, right? So there's a strange thing about the circuit of the hippocampus. The pyramidal neurons get both stuff from the regular trisynaptic circuit, right? But they also get unprocessed information directly from the entorhinal cortex, the same cells, either at the proximal or distal dendrites. So what we wanted to do, what Oscar wanted to do, use one of these transgenic crosses that's just expressing an EC layer 3, okay? And EC layer 3 projects up to EC layer 2, right? And goes through the whole loop. But it also has a direct projection here to CA1 neurons, okay? So by using optogenetics, you can see the expression is here just in CA1 and subiculum, right, which is what EC3 goes to. Using optogenetics, you can just silence these presynaptic terminals and not affect the whole loop. When you do something that specific, okay, you don't get a lot of differences, okay? There's stuff, some things do happen, but the firing rate doesn't change, the spatial firing doesn't change, all kinds of things do not change. And that's in a familiar environment. So here's this to this. And this is a showing of this remapping. How correlated are the two spatial rate maps, basically. However, what you do see is if you do this stopping of this unprocessed direct intrarenal input while the animal is making a representation of a novel environment, you stop the generation of a new representation. So very, very highly specific change here. So this is the kind of stuff that my lab does for a living, right? This is my day job. However, we realized again that this is a very interesting result, we think, because it's like the direct input. How do you know if something's novel or not? Well, you have to compare it to what's not novel. So we think this direct input is basically like a novelty signal. All right, that's the systems neuroscience stuff. This is why I'm here, okay? So we started making all these different tools that can do these different cell types in the entorhinal cortex. And as I believe it was Yannis that said, it turns out there are these two things, right? There's the tau and there's amyloid, right? Basically, to sum up so much research, tau correlates well with the cognitive decline, whereas amyloid, the genetics just scream APP, right? So the Brocs, these pathologists, did this thing called Brock staging that Yannis brought up. And the way it works is, way before symptoms, you start seeing these either NFTs or this AT8 tau positivity, okay, phospho-tau,
in particular neurons of the entorhinal cortex, transentorhinal cortex, lateral entorhinal cortex in rats. And it spreads through there, through Brock stage 2, to other neurons in the entorhinal cortex. And then from there, stage 3, it goes to the hippocampus and subiculum, okay? But it doesn't go, strangely enough, to where these neurons project, because these neurons actually project to the dentate gyrus and CA3, which actually are very late in Braak stages. Instead, it goes to CA1 and subiculum, okay? Continues, seems to spread, and this basically gives rise to the idea, some call it a prion hypothesis, that the tauopathy in AD spreads, okay, over time to synaptically connected areas. But again, why then doesn't it go to the dentate and CA3? So, this is the basic idea that I was talking about. I briefly spoke about a patent. The idea is basically starts here in the entorhinal cortex, goes to hippocampus, other connected regions, keeps going, and they're a mess by the time you get to the high stages of Braak. So, again, these cells are these layer 2 entorhinal renin positive projection neurons. Interesting because a recent study showed that there is a very protective, something called the Kolbos mutation in the renin gene, and these are some of the very few excitatory neurons in the adult that express renin. And it also is one of our viruses is very highly specific to these neurons as well. So you can see where I'm going with this, basically. Would it be possible in these early Braak stages to stop the spread of tau before it gets bad? That's basically the idea. We do have a virus that does this, and now we see this is a virus in a wild-type rat hitting those same neurons. Got a patent for it. It was actually the first time I said this was actually at a Genedis conference. So we got a patent, fine. Now you have a patent, how do you test? So basically, you put it in an animal model, but the problem is no animal model actually recapitulates the anatomy of the tauopathy, right? So, and it's funny because the non-human primates even, they get amyloid, they get plaques, but they don't get the neurofibrillary tangles that are associated with tau, okay? And that's true of most of the animal models as well, at least if you don't put a FTD gene in there. So, simple experiment. We just said, okay, let's just take a stupid virus that just likes neurons, synapsin promoter, right? Inject a bunch of it into the back of the brain so it infects lots of different cell types and overexpresses wild-type human tau in lots of different cell types, right? And then we just follow them, right? What happens? It's basically a tau challenge, right? And we do immunohistochemistry to kind of see what's going on. And then at the end, if I get to it, I'll show you we're doing some single-nucleus RNA-seq. So basically, we do a tau challenge in young animals. I mean, this is overexpression, so you can do young animals. It has downsides, too. It's not an aging thing. But you can see we use 3 different antibodies. The AT8, which is a very commonly used one, hits this site, and then the serine 396 that hits the PH1 site. Is that correct? PHF1? And then this MC1 antibody, which is thought to be one of the more pathological antibodies because it actually looks at a paired helical filament conformation rather than just a phosphorylation site. This is what the data kind of looks like. So pink here, this is Nguyen. So here's lots of neurons, right? Here's one of these injections. I don't know how well y'all can see this, but we got tons of human tau being expressed in these neurons, which are the pre-alpha cell things. These are these fan cells of the lateral cortex, but lots of other neurons as well, right? And you can see here that correlates exactly with the 4-hour tau from humans that we're expressing. And here you can see it's linear, right? More GFP, the more tau. I mean, duh, right? What happens when you start looking at these phosphoantibodies? Well, Here you can see the GFP, or maybe not, you can't. Those are really bright lights. But I'll show other graphs then. So you can see, yeah, we're getting it totally here in these fan cells, but also tons of these cells here in the perirhinal cortex and cells here in the deeper layers of the entorhinal cortex. Okay? And it looks basically linear, but, I should say, a little anatomy lesson here. We're looking at the different layers here, layer 2, entorhinal cortex, layer 3, deep layers. Perirhinal actually probably starts around here, ectorhinal. So basically, what you can see in the red in the blue are these layer 2 cells, right, in the entorhinal cortex, right? The black are the cells not of the entorhinal cortex. The red are the cells of layer 3, right, which we didn't get that many of, but still, we got them. And you can see that, okay, the blue guys get definitely above threshold, right? That's the pre-alpha cells, the fan cells. But there's a population of neurons in layer 3 that are almost stronger, right? Even though they get the same, relative to the GFP, so relative to the amount of tau we are overexpressing, okay? That's just showing it in a histogram, right? Lots of positive in LEC2, LEC3 also, and then pretty much nothing elsewhere, and nothing, at this time point at least, in the rest of the cortex. Here's another one, P-serine 396. Remember, this is a different site, right? And here we see something kind of different. We see it's kind of light, a little, in the layer 2 neurons, the fan cells, right, the pre-alpha cells. But it's quite strong here in these layer 3 guys. What's up with that? Again, there's the color for you on the right. And here you can see with the histograms, just tons and tons of this 396 and immunogenicity here in layer 3 of the LEC relative to layer 2, even though they're not the fan cells. And then finally, when you look at this MC1 antibody, this most pathological antibody, though again, I'm a tourist in this field, so please keep me honest here. But this paired helical filament antibody, you see it again, mostly here in these layer 3 cells. Why? Okay, so I'm going to just zip through these summary slides, right? And we can go back to them if we have time. That was a little too zippy. Okay, so basically, both at 2 months and 5 months post-injection, okay, you see, okay, the AT8 antibody likes layer 2, which are the pre-alpha cells, but layer 3 cells like the other 2 antibodies, including the most pathological one. All right, and that's true also basically.
Is this the last slide or the one before last?
I don't know, they're going by fast. So which would the basic, just look at the histograms if you can't see it. Though it is really nice to see, look at these processes going with the MC1. But basically, layer 3 is overrepresented, okay? Why does this matter? Remember how I was telling you about in our physiology experiments? Where does layer 3 entorhinal cells go? CA1 and subiculum. They go where the next stage in Brock staging is. So we think we've identified a cell type, basically, that's actually quite important, or is an important player in the progression, prodromal progression of the tauopathy that is part of the story of AD. Okay, and molecularly, how much have I got? Ooh, I'm done. Mandel cows basically showed that if you get one of these sites phosphorylated, okay, what you end up getting is an opening of this paper clip, right? But if you get both here and here, the PHF1, yeah, epitope, you get this compacted paper clip configuration of the tau, which is similar, is like the paired helical filament configuration, the pathological, most pathological configuration. And you can even see it when you look at the labeling, right? Here you can see, this is the EC layer 2 cells,
I mean, they're there, right? But the EC layer 3 inputs here to CA1, they look totally different. They both have label with this antibody, but they're in these little inclusions, these little aggregates in the layer 3 inputs. So that's basically it. I know we're done, right? So basic idea here is, well, we're doing what is known as a really great, powerful method for taking research money and turning into clusters of little dots, which is RNA-seq. And we have found lots of different differentially expressed genes based upon whether or not the same cell type has the tau there or not, right? And we are trying to use this information. You can see actually, here's the tau positive neurons are not in the entirety of the cell types cluster. They move the expression pattern over. And we're trying to figure out what is it about these neurons that actually makes them such good reaction vessels for the pathological interactions that create pathological tau. And with that, we're going to keep doing stuff. And finally, I want to say this work was done almost entirely by Isaac Martinson in the lab. Funding up there. And thank you for your patience.
Thank you, Cliff. Great story, deserves many questions, but one, can we have one? Do I block people? Okay, we have.
I guess the question would be, I mean, it's fascinating and the story of trying to translate from humans. When you figure out what kind of injection you have to do to recreate that trajectory, did you do behavior in these rats?
We've done no behavior. And in fact, you know, look how few cells we got that are actually being infected in the first place. I would doubt that we would see behavior going on here. But if we're considering making a transgenic where you'd get a lot, you won't get the injection, but you get this in the background. And that would basically allow us to do the behavior. But we'd need to get funded before that. So.
Great story anyhow. Thanks. We have a lot of questions, I know. Thanks again. And the last speaker for today's session, at least this session, is Professor Christos Yapizakis, which is associate professor in the first department of pediatrics here in the Medical School of University of Athens and in the Hagia Sophia Children's Hospital. So the title of his talk is Genetics and Epigenetics of Oral Cancer.
Thank you very much, Dr. Sotiropoulos. I would like to thank the organizers and especially Professor Vlamos for the invitation to talk to you about the genetics and epigenetics of oral cancer. I'm a medical geneticist, a dentist and biologist, professor of genetics at the Medical School of the University of Athens, and head of the unit of orofacial genetics. I have no conflict to declare. You probably have heard that oral cancer is a very common cancer. It's the 6th most common worldwide. It has a global incidence up to 22 cases per 100,000 people, and about 500,000 novel cases per year. It's a multifactorial disorder: smoking and heavy alcohol consumption, genetic mutations, even some HPV types, human papilloma virus types, are involved. And about 95% of total cases involve oral squamous cell carcinoma. The topology of oral cancer is all over the mouth, the surface of the tongue, inside the cheeks, palate, lips, gums, salivary glands, etc. And always it starts with asymptomatic precancerous lesions. But still we have 500,000 novel cases per year. In the EU, about 100,000 novel cases, and in the United States, about 60,000 novel cases. Every hour, 2 people die in the European Union, and about 1 person dies in the United States of oral cancer. The global mortality rates is over 60%, and the recurrence rate is very high, 45%, with only 8% of people to survive in 5 years. So, but it starts with asymptomatic precancerous lesions. But the problem is that it's cannot show anyway. So the problem is that it has a very late, untimely diagnosis. About 40% of the patients have already presented with lymphatic infiltration, and about 10% with distant metastasis when they are diagnosed. So the clinical assessment and biopsy has to be done prior to surgical removal, which is the therapy of choice. But the patient comes to the specialist, who is usually a dentist or a orofacial or oral maxillofacial surgeon, when the lesion is clearly visible and shows symptoms like pain, like burning sensation in the mouth. So it's very late. And the cancerous mass is already grown, adapted to the microenvironment, and probably already metastasized to the lymph nodes. So the late diagnosis is responsible for the high mortality rates, which are the same over 60%, up to 65% for many decades now. So we need the development of targeted non-traumatic screening techniques, maybe a liquid biopsy with taking biological samples, blood or saliva, but the diagnostic methods so far, such as protein biomarkers that are tested and or circulating tumor DNA, so far are ineffective for early detection. So we need to develop protocols with diagnostic value and reproducibility after full understanding of pathogenic mechanisms. So even the genetic testing of patients is not a diagnostic tool. The oral cancer, of course, it's a disease with a strong genetic background, and we know the main genes involved, like P33, P53, CDKN2A, which produces P16 and P14 proteins, but and other genes. But the genetic testing, either DNA sequencing or whole exome sequencing, is usually financially inaccessible for many patients. It's indicated for assessing the individual's risk, but the predisposition risk does not always lead to a disease. And mainly the genetic testing is useful for research purposes and has no diagnostic utility. So what do we know about the genetics of oral cancer? First of all, we know that in normal mucosa there is an altered first event, an altered cell. We know from genetic association studies that were done mainly by our group 15 years ago that an inflammatory stimulus may be the ground for these alterations to happen. Then there is the precancerous state, and finally the invasive cancer. And we have genetic events that include point mutations, translocations, deletions, copy number variations, gene amplifications, but also epigenetic events like DNA methylation, histone modification, and microRNAs. I will talk about this later on. And of course, risk factors, as I mentioned before, lifestyle factors like smoking, like heavy alcohol consumption, HPV, and even pollution. And according to experimental animal models, the genes involved are responsible for regulating cell proliferation, oncogenes or tumor suppressor genes, and these are over or underexpressed based on if there are oncogenes or tumor suppressors, depending on the stage of cellular damage that ultimately leads to oral carcinogenesis. But each person has a unique genetic profile, as it happens with other cancers. And basically, we know for animal studies, and the best animal study was the one developed by our group 15 years ago that got a Basic Science Award in an oral cancer conference in Amsterdam. That is a sequential carcinogenesis model. We knowing all the oncogenes and tumor suppressor genes in different stages, in 7 different stages of oral cancerogenesis. And we know from several studies of our group and others, the basic genes that are most commonly involved, like P53, CDK, N2A, FAT1, caspase 8, Notch1, etc., that are involved in oral carcinogenesis. So the 10 key cellular landmarks in oral cancer are are caused by mutations in specific genes. They infer maintenance of proliferative signaling, avoidance of growth suppressors, avoidance of immune destruction, activation of infiltration and metastasis, tumor-promoting inflammation, hyperproliferation and cellular immortality, induction of angiogenesis, genome instability and mutations, resistance to cell death, and dysregulation of cell energy, like in other tumors. Now, let's move on to epigenetics. We know that epigenetics is used to describe changes that do not modify the base sequence of DNA, but change its function. Epigenetics is a bridge between genetics and between genotype and phenotype. And the main epigenetic mechanisms, as you know, include DNA methylation, histone modification, and regulating non-coding RNAs. According to the doctrine of molecular biology, DNA makes messenger RNA, makes protein. But 40 years ago, in the 80s, the scientific community considered a large part of the genome as useless genetic material. It was called junk DNA. But in this junk DNA, there were transcribed RNAs that selectively bind to complementarity to messenger RNAs of functional genes and regulate their translation. So among these RNAs are the microRNAs, which are small single-stranded non-coding RNAs of about 20-22 nucleotides. They regulate gene expression through post-transcriptionally through mRNA silencing with translational repression and even degradation of mRNA. And they complement target regions in 3' or 5' untranslated regions of mRNAs through the RNA-induced silencing complex. And one microRNA can regulate the expression of multiple genes in target genes, and different expression patterns have been noted in health and disease in different microRNAs. And there are characteristic patterns in several cancer types, including oral cancer. So there are microRNAs that silence oncogenes, and these are called tumor-suppressing mirs. And there are microRNAs that silence tumor-suppressing genes, and they are called oncomirs. So extracellular microRNAs circulating in biofluids like blood, saliva, urine, etc., or in tissue, in intracellular microRNAs, have a great potential as biomarkers.
We have like 3 minutes.
Sorry?
We have 3 more minutes and some discussion.
Okay.
Thank you.
So I'll briefly talk to you about what we've done to find out to identify which are the most important microRNAs for oral cancer out of hundreds known that are affected, dysregulated in oral cancer. We made a bioinformatic in silico methodology using first we created an oncogene panel of 15 most important oncogenes in oral cancer and another panel with tumor suppression genes. And we made a microRNA target prediction analysis for the identification of about 800 genes of panel, microRNAs of panel 1 and 440 in panel 2. And then we filtrated, we selected the microRNAs that target and possibly regulate about more than 60% of the genes in each panel. And we were able to identify only 4 microRNAs that were very important. One that was targeted all different tumor suppressor genes, MIR155, and 3 that targeted the most of the oncogenes. And 155 targeted all tumor suppressor genes, and 34, MIR34 targeted all oncogenes, all 15 oncogenes. And we did that also using the model, the animal model of sequential oral oncogenesis to see which microRNAs were important in hyperplasia, dysplasia, and early invasion stages, so in malignant transformation. And we were able, using the same methodology, and we were able to see 3 microRNAs that were important in hyperplasia, the same 3 plus 1 were important in dysplasia, and the same 5 plus 2 were important in early invasion. So these are really good biomarkers to use for early prediction of initial stages of oral cancer. And this is in silico methodology, but we're doing these experiments in our lab to see if these theoretical findings are correct in several, in about 50 cases of oral cancer and 10 controls. And this methodology got the Basic Science Award in the Pan-Hellenic Conference of Medicine this year, and 2 Best Presentation Prizes in conferences of human genetics and medical genetics. And I would finish mentioning, this is the last slide.
Thank you very much.
But I would like to say, I would like to mention the group. I'm the leader. I would like to mention Professor Vasiliou, who is the professor of oral maxillofacial surgery, Professor Krousos, who is an emeritus professor and director of University Research Institute of Maternal and Child Health and Precision Medicine, Professor Theocharis, professor of pathology, but most of all, the PhD candidate, Iphigenia Gintoni, who did most of this bioinformatic and laboratory work. And this is her PhD, the study of microRNAs in saliva, blood, and tissue of patients with oral cancer. Thank you very much for your attention.
Thank you. We have time for 2 questions. Sorry to stress it, but we really... Eleni is going to the microphone.
Thank you for your talk. That's very, very encouraging that you have identified these mirrors. I was wondering if you are thinking, in addition to biomarkers, using them as targets and targeting them with agomirrs eventually to stop cancer progression. Is that something that you are planning to do?
We're thinking about that, but we're basically focused now on finding out if these 3, 4, 5 microRNAs can be used for early detection. This is our primary focus, to make a liquid biopsy that would be used by any dentist, for example, with a little saliva, and save a lot of lives. Maybe we can go on with this research, trying to stop the expression of some genes in the future. But our main focus is to create a liquid biopsy right now. Thank you.
Thanks. Any more questions? If not, we would like to thank the last speaker and everybody for the nice long session. Sorry. Thank you.
Nanotechnology, and we are very pleased to have with us Professor Kostas Demetsos. He's professor of the Pharmaceutical Nanotechnology, Director of Laboratory of Pharmaceutical Technology, Department of Pharmacy, University of Athens, and mainly is a dear friend and a great researcher. Please, you have the floor. He will talk to us with the title, Complexity at Nanoscale, New Challenges in Therapeutics.
You are ready? Okay. Hello, everyone. I would like to thank you for the kind introduction, Professor Vlamos. I would like to thank the organizers and Professor Vlamos for inviting me to give a lecture on complexity at nanoscale. I will focus on new challenges in nanotherapeutics via complex lipidic grafts. And I want to say that I will go through two main important scientific fields, complexity and lipidic grafts. In my point of view, both are very important in order to design and to evaluate novel nanomedicine, especially those that are produced based on nanotechnological issues. So I will start and I will share with you the slides regarding nanotechnology and lipid grafts. In 2021, 3 scientists received the Nobel Prize in Physics for groundbreaking contributions to understanding complex physical systems. And Stephen Hawking has called this century the century of complexity. All we know that nature is a complex system and complexity leads beauty and art at the natural processes. This slide nicely presents polymer and diblock polymer and their conformation and changes due to an external stimuli. By changing the external stimuli, for example, pH or temperature or ionic strength, we can change the conformational properties and consequently the functionality of the system. These polymers are able to change their conformational properties and consequently their entropic state. It is obvious that in nature there are such changes that take place through biopolymers such as proteins and peptides, and these biomolecules are stimuli responsive to external stimulus. What are lipid rafts? Which is the second part of my talk. Lipid rafts are cholesterol-rich plasma membrane microdomains that regulate a diverse range of cellular functions. Lipid rafts are rich in cholesterol and sphingolipids and are important for neuronal cell adhesion, action guidance, and synaptic transmission. Many diseases, like neurodiseases such as Alzheimer or Parkinson's diseases, as well as AIDS, can be correlated with lipid rafts. In 1972, Singer and Nicholson viewed cell membranes as two-dimensional solutions of oriented globular proteins and lipids. Singer and Nicholson published an important paper in Nature in Science Journal in which discussed the organization of cell membranes or lipid bilayers composed of phospholipids and cholesterol and of proteins and lipids, and promote the fluid mosaic model in order to describe the functionality of our cell membranes. In 1988, Simons and Van Meer suggested existence of microdomains or raft in plasma membrane of epithelial cells. And at the 2006 keynote symposium of lipid rafts and cell function, lipid rafts were defined as small, heterogeneous, highly dynamic, sterile, sphingolipid-enriched domains. All these issues are included in my new book entitled Nanotechnology in Therapeutics. Lipid rafts are metastable phases. What is a metastable phase? A metastable phase is a thermodynamically driven microdomain which act on our cell membranes and on artificial cell membranes and participate in all cell functions. So our cells, our living cells, and on their surface are fully of microdomains that are characterized as lipid rafts. And here in this slide, we can see a well-organized lipid bilayer composed of phospholipids and a raft in between lipid bilayers. So this is characterized as a lipid raft, which is a microdomain, thermodynamically driven, and play a crucial role in all cell functions. Looking a little bit down, we can see fluorescent microscopy images show crystalline in red and liquid in blue metastable phases of an artificial cell membrane. What is an artificial cell membrane? An artificial cell membrane is a structure, a nanostructure, which is able to accommodate bioactive molecules and to transport them to the target tissue. So we can use the knowledge obtained from our cell membranes in order to develop and to evaluate artificial cell membranes. These red and blue spots on this image are metastable phases that coexist in non-equilibrium thermodynamic state. So this is important because we have the tools how to identify such important items on our cell membranes and on artificial cell membranes. Lipid rafts exist as polymorphic metastable phases on the surface of artificial nanodevices like liposomes and lipid nanoparticles. We know that artificial cell membranes are mainly liposomes and lipid nanoparticles that are able to encapsulate bioactive molecules or genes and to transport these compounds to the target tissue. Here you can see different morphologies. By dissolving lipid molecules into aqueous medium, we can receive different morphologies such as A, B, C, D, E. These morphologies play a crucial role in the pharmacokinetics and pharmacodynamic properties of the encapsulated molecule, and also affect the stability of the final medicine. The transition from the one morphology to another morphology is thermodynamically driven and depends on the microenvironmental condition. As I mentioned, the microenvironmental conditions, for example, pH, temperature, whatever, can change the morphological characteristics, and however they can affect the functionality of the final medicine. Such morphologies can be characterized using capital letters. For example, L is used to characterize lamellar phases, P to characterize ripple phases, Q cubic phases, and so on. There is a continuous increase in publications about lipid rafts being responsible for diseases and neurological problems. You can see that there are more than 8,000 publications in PubMed concerning lipid rafts and the descriptions and the functionality and the usefulness to study such microdomains on our cell membranes. I'm happy to share with you this nice slide with experimental results that have been obtained from my lab in the past, what we can learn so far using these figures, we can see small peaks that each one corresponds to a metastable phases, to a microdomain, to a lipid raft. These metastable phases could be considered as information hubs. So these information hubs can be correlated with serious diseases like neurodiseases. And this is another a nice figure using the differential scanning calorimetry, which presents complex metastable phases of artificial cell membranes. And what we can learn so far, we can see the red curve, which is with a nice shape, composed of D-oleic phosphatidylcholine. We used simple phospholipids in order to produce nanostructures that are mimic the cell functions. By adding a guest molecule, for example, a polymer, which is a dendrimer, PAMAM, in different concentration, 3, 10, 20%, we can see different peaks that have been raised. Each one corresponds to a different lipid rafts, to a different metastable phase. In 2024, in the Journal of Biomolecules, a paper has been published entitled Lipid Rafts, the Maestros of Normal Brain Development. And the lipid rafts, as I mentioned, are complex cell membranes microdomains in neurocells that could act as information hubs and can be correlated with serious dysfunction of our cells. The balance between order and disorder drives the level of complexity and consequently the level of cell functionality, the cell dysfunctions. So the question that arises is how we can study the complexity of artificial cell membranes, of liposomes or lipid nanoparticles. All these structures can transport, as I mentioned, bioactive molecules to the target tissues. In my point of view, the most important thing is to study the internal complexity of such structures. For example, here we have 3 structures A, B, C. All have the cubic long-range order, meaning that the external complexity is the same. But what happens in the internal complexity, looking carefully inside to these 3 cubes, we can see difference regarding the channels, the morphological properties of the channels. So we have the same long-range order but different short-range order. So it is important to have advanced tools in order to study this issue. And the paper which was published discussed liquid crystalline lipid carriers as complex systems, and what we can learn from this paper, we can see that by using X-ray and high-resolution freeze fraction electron microscopy, we can study the morphology and the dynamic topological transitions of these structures. So by using SACs and electron microscopy, patterns of lipid cubic lattices with large A or normal big water channels for protein entrapment, we can see in this figure. What we can see in these 2 figures A, B, we can see peaks. Each one corresponds to a different morphological characteristics with a different metastable pattern. So such techniques like XRD and freeze fractional electron microscopy allow us to detect metastable, intermediate, and coexisting structures. Recently, I published a paper entitled Nanosimilars, a scientific or regulatory debate, and I promote new tools and new approaches in order to study the complexity, the internal complexity of such systems. In my point of view, information theory and entropy principles are important for precise and accurate characterization of such complex self-assembled nanostructures. And nanothermodynamics open a promising avenue for a more systematic study of physicochemical, thermodynamic, morphological characteristics of such non-linear structures. Recently, we have published a paper entitled Artificial Cell Membranes as Bioinformation Hubs, and what we said in this paper, we discussed on therapeutic networks. We have to know the network between the structures of such domains in order to identify serious diseases like Alzheimer's disease, like Parkinson, and so on. Moving on, I would like to propose that artificial intelligence is an advanced tool in order to study the internal morphological characteristics of such structures, not only of artificial cell nanostructures that can deliver bioactive molecules to the target tissues, but also we can study the internal complexity and the surface properties of our cells' membranes. And this is an amazing approach that we have to keep into consideration. And coming to the end of my talk, this year, chemistry laureates Demis Hassabis and John Chambers have developed an AI model, AlphaFold 2, in order to solve a problem years ago, predicting proteins' complex structures. So we know that the complexity is an amazing item that should be studied in depth. In my view, it is obvious that the complexity is an emerging issue, a complex dynamic phenomena on cells, like lipid rafts behavior, are correlated with serious diseases and should be discovered under the lens of complexity and AI. I would like to thank you very much for your kind attention.
Thank you very much, Professor Demetrios. I think that you will present us also your new book as a book launch right now.
Yes, I think that the next session
before okay.
is for the presentation of my book. In my book, I can say that there are many issues and items that are included also in my book, like complexity, artificial intelligence, non-linear dynamics, and many colleagues helped me to incorporate all these items into my new book, and I invite you to be present in the next session, which is the presentation, the launch of my book.
Okay, we should notice that in 2016 we had a book launch by you in Genedis, and afterwards it was awarded by the Academy of Greece.
Okay.
Okay, so
Thank you.
We believe the same. Any questions? Okay. Before moving to the next session, let us invite the Vice Rector of the Kapodistrian University, Professor Stathopoulos, for a short salutation for the Genedis.
It is a great pleasure for me and great honor to be here to the presentation of the new book of my friend Kostas Demetrios on nanotechnology and nanomedicine. with Kostas, we're working for many years now in the field of nanomedicine, and we have designed together and implemented an MSc course in nanomedicine in the National and Kapodistrian University of Athens, which is, to my opinion, a very promising and very successful course. And in this course, we every year we use books of Kostas Demedjos. We give Kostas Demedjos books to our students. Kostas, except very high quality scientist, is a very great character. It's a pleasure for all of us to work with Kostas, and this is, I think, this is the most important characteristic of Kostas Demedjos, and this is the reason I am a friend of him, and we have so much close relationship all these years. Costa, we thank you very much for all your work and all your collaboration and all your contribution to science, to nanotechnology, to nanomedicine, and to pharmaceutical nanotechnology, and to our students. We are very happy to work with you. We thank you.
Many thanks to the Vice Rector of the University of Athens. And the next session is dedicated to the book launch of Professor Demedjos. The book is entitled Nanotechnology in Therapeutics, Basics and Trends, published by Wiley. And the first talk is given by Dennis Dourdoumis, a professor at the Pharmaceutical Technology and Process Engineering, Director of Center for Research and Innovation, Faculty of Engineering and Sciences, University of Greenwich, UK. The title is Recent Advancements in Nanomedicine Challenges and Opportunities. Thank you for being here.
Give me a moment. Okay. Thank you very much for the invitation. I would like to present some recent advancements in nanomedicine, some challenges and opportunities that we can see over the next few years. Before I start, I would like to tell you a few things about my role. Since 2012, I'm editor-in-chief for a series of Wiley. This is a book series called Advances in Pharmaceutical Technology. Myself and a few other eminent academics, such as Professor Jürgen Schimmmann, Vladimir Torchilin, Martin Snowden, and Professor Alfred Farr, who recently passed away, are responsible to identify pioneers in different areas of pharmaceutical technology, and then we ask them to contribute a book based on their expertise. And the whole series is based on a lot of different topics. We start from the lead compounds where we are discovered and can be used later on for treatment of various diseases. We move to pre-formulation, analytical characterization using advanced techniques, and we cover also areas of pharmaceutical processing and manufacturing until the end product. So as you can see here, we have a range of books. Some of them are on this slide. over the years, and a lot of them are bestsellers. So the last runner of this series is the book that Professor De Medjas edited, and it's called Nanotechnology, Therapeutics, Basics, and Trends. So having read some of his books, published in Greek publishers, I was privileged to invite him and contribute his book in our series, because I thought that this was something missing, and it was also timely to discuss and present advances in nanotechnology. So the term of nanotechnology is well known, and nanomedicine, of course. We heard a lot about that for the last 7 years, but in academia is well known for more than 50 years. So eventually, the term was, let's say, invented from Eric Drexler, who published a book in 1985 called Engines of Creation, The Coming Era of Nanotechnology. So this book, actually, it was not a scientific book, but it was based on a presentation that was given by a Nobel laureate in 1959, Richard Feynman, and the title was There's Plenty of Space at the Bottom. And this is how these terms became very popular to academia and, of course, industry. So in this slide, you can see some of these nanoparticles, and there's a number of different materials. In the nano range, you can see how they compare, for example, with the tennis ball. So the nanotechnology has found applications not just in medicine and healthcare applications, but also in different sectors, like, for example, water treatment, waste water treatment, textile industry, and high-performance batteries. So it's well known, but in medical applications, we've seen a lot of advances over the last 20 years, with several products being in the market, and that covers a whole range of areas, like for cancer treatment, diagnostic, nanoparticles for diagnostic tools, tissue engineering, and also, of course, in drug delivery and gene systems. So a recent example, we all know about these COVID-19 vaccines that include novel drug delivery systems, comprised of novel drug delivery systems, but also genetic material. I'll come later to this particular example to give you some more information. So we can see here, this is the timeline for the development of nanomedicines, and it goes back 50 years. In 1965, when Professor Banham discovered liposomes, which are these are nanoparticles that can be used for transfer drug substances to our body. And from 1965, it took about 30 years to see the first product in the market. That was Doxil, which is a blockbuster for the treatment of Kaposi sarcoma. So you can see that it's not very easy. Kostas mentioned, discussed a lot about complexity of these nanostructures, and we can see how that works. Of course, over the years, we see an exponential increase of the products which are marketed in the form of nanomedicines. And that includes a wide range of materials, where we have nanocrystals, liposomes, what we call pegylated nanoparticles. We have also protein-based nanoparticles or drug conjugates, or even metal nanoparticles that can be used for different applications. So here is another schematic diagram where you can see a different classification, which is based on the actual material properties. So we have what we call organic materials, inorganic, and carbon-based. A lot of them, all of them have been tested for healthcare applications. Some of them have seen the way to the market, and some of them they'll never see, but we still, based on scientific curiosity, we test them. So I'll move now to challenges that we encounter when we deal with nanoparticles or nanomedicine applications. There are several challenges. So the very first one is that the translation of basic science to clinical application and subsequently to market is very difficult. There's only 10% of these molecules or the drug delivery systems that will be tested, and eventually we see them as an end product. And this is what we call the valley of death, because there's a very high attrition of these products or these molecules that are tested. And there are several reasons about that. The very first one is that always the in vitro behavior is quite different to the in vivo performance. For example, we might have very good and excellent data through biological assays, for example, cell culture or even animal trials, but when it comes to humans, we don't see them working as we expected. So another challenge is that specifically for tumor targeted nanoformulation, the complexity of these tumors. We also know, I'm sure some of you have relative experience, that the tumors we develop in animal models are not the same compared to humans. The animal models, the tumor in animal models are not as solid as in humans, so that makes it very difficult to penetrate or uptake the drug substance or the nanoparticle into the tumor. And that's why we always see very exciting results in animals, but not in humans. Also, some of these nanoparticles that have been developed to reach the market are multifunctional, they have a multifunctional character, which means they have different entities incorporated in the particle, and some of them are related to, are used as a drug delivery system, so they will release the cargo into the cells or in the tumor, but some of them will be used as a diagnostic tool. So the problem here is that you have, the pharma companies have to go through very expensive trials because they have to prove that they have the drug delivery is efficient and it has a clinical effect. But the other problem is that those materials, they have to prove that they're biocompatible, non-cytotoxic, and they don't cause any harm to patients. So this is an issue. The other issue is related to the manufacturing of these nanoformulations, is what we call in industry batch-to-batch variation and scalability. So it's not good enough to have those manufactured in a lab scale, but you have to move that into mass production. And the current techniques, or the techniques that we used to have, are not very efficient for large amounts. And we have seen that when we had this shortage of COVID-19 vaccines. And another issue is the ethical problems that might arise for delivering or developing these products. So one of them has to do with the company's target or aspiration. There are several diseases which are, for example, rare diseases, and the company has to think about what we call the cost-benefit evaluation, which relates to the profit of the company. If the company doesn't see that the product is going to be a blockbuster, they're going to make enough money, they don't really care about that. So this is an ethical issue we have to take into account. The other issue is that a lot of clinical trials are carried out in patients which they have advanced disease. They are in advanced disease stage. And in this case, that the patient, although they sign the consent form, and are aware about this is a trial, they raise many hopes. So this is an issue because they get a false impression that eventually this will give them a better treatment and eventually they will be healthy. The safety profile and the potential toxic effects of those materials, I mentioned that already, is a very important issue because we have seen products going to the market, but eventually a few years later are withdrawn. So this is where the regulatory authorities come to play a critical role, where they have to evaluate what we call risk to benefits ratio. So talking about regulatory authorities, this is another problem because for two different reasons. All regulatory authorities, they pose restrictions about nanomedicine, and those result in very expensive trials. So the companies have to spend millions to investigate a drug product, and those restrictions usually relate to ethnic or even national restrictions. So, for example, FDA will ask you to run different trials at different continents, which means a lot of money, and the company has to reconsider their approach. Another issue, again, is that all these regulatory authorities, they are not harmonized. They have different regulations. For example, FDA is completely different to EMEA or even MHRA in UK. And then this is an additional burden that companies have to take into account when they develop product, which means, again, more trials and more money because the trials has to be very specific to meet the regulatory restrictions. So I'm moving now to this example because we all know about the pandemic in 2019 and COVID pandemic, and this is a very important paradigm. The reason is that we know that because of the pandemic, there's a lot of effort to develop mRNA vaccines and use these lipid nanoparticles as a drug carrier. We know that from literature or those are related to these areas, there were some products like Onpryto or Synrix that have been already in the market. So those products, for example, they use complex oligonucleotides or RNA material. The difference is that these products went through the regular process and it took years of studies and investigation to reach the market. However, the COVID-19 vaccine was the two vaccines that incorporate genetic material were developed in a very short time. And to make this one happen, there was a collaboration of regulatory authorities around the world, but also industry. So we can see now if there's a mutual understanding and also flexibility from the regulatory authorities, because this is an issue. Over the years, the restrictions are more and more complex. So that can lead to a product that is good that will benefit public health. So, and in this particular case, the innovation was not only on the actual drug delivery system, so they developed some really exciting nanoparticles and incorporated the genetic material that was supposed to be, was meant to be stable, and it was stable at the end of the day, but also they address another issue that I mentioned before about the scale-up and the manufacturability of those nanoparticles. So as you can see at the bottom image, this is a device, is a commercial device where you can manufacture those vaccines, and they use what we call microfluidic arrays or microfluidic technology. So we see here that there was a lot of novelty behind these developed vaccines in a very short time. So there are a few opportunities in trade that we can see now coming in the market, and the global nanomedicine market is anticipated to be about 381 billion in 2025, so next year. So the basic concept here is to develop cost-effective and patient-friendly diagnostic tools, and then those will be used for the treatment in a very short time and try to be less invasive as possible. The reason is that healthcare systems, they have to spend billions for the treatments, which are usually expensive. So a combination of diagnostic tools with appropriate drug delivery systems will reduce the cost, but also will benefit the patients. So another trend that we have seen these years, I think Kostas mentioned already, is what we call personalized medicine. So again, recent advancements in genomics and different sections, they rise this unmet need to develop products that can be used specifically for individual patients. So in this case, knowing the genetic profile or the exact cause of the disease of the patient, will be able to design a specific product that it's not just it uses the same drug amount or a different drug amount, but also to design the formulation for a specific patient. And the reason is that we have seen, I mean, if any of you are doctors, I suppose you are, we have seen that people suffering from the same disease at the same stage, they react differently in the treatment. So this is the basic idea of personalized medicine, is to treat each of them individually. There's a lot of interest, again, on targeted drug delivery and nanodiagnostics, which I already mentioned, specifically in cancer and vaccines. And the reason that these two areas are a hot topic for industry is that over the last 20 years, we've seen an increase in the morbidity and mortality of cancer patients. But also, now the COVID vaccines, they pave the way to develop modern vaccines which contain genetic material. Also, lastly, there is a lot of interest on machine learning approaches and artificial intelligence. And in this case, the combination of those two covers the whole spectrum. So we start from people try to identify, or even companies, they try to identify new lead compounds that they will be very beneficial, then move to the actual formulation. You have to identify which is the best formulation for the particular drug substance, and eventually goes all the way to the end product by optimizing the manufacturing process. So, in conclusions, we know that nanomedicine offers transforming opportunities in healthcare by covering a wide range from target delivery and advanced diagnostics to personalized medicines and tissue regeneration. So the future medicine will involve AI or machine learning approaches and combine them with genomics, and ideally will offer optimized treatment for patients. So thank you very much for your time. I'm happy to answer any questions you might have.
We will have all the questions at the end of the session. Thank you. So, next speaker is Associate Professor Themis Exarchos from our lab, Department of Informatics. He will give a talk concerning artificial intelligence, bioinformatics, and nanopharmaceuticals.
Thank you for the introduction. Thank you, Professor Damezos, for inviting me to this session to present the book. So the title of my presentation is Artificial Intelligence, Bioinformatics, and Nanoinformatics. I will start with just some introductions and concepts, very trivial, and I will try to intersect them at the second slide. So AI is the ability of a computer or a computer-controlled robot to perform tasks normally associated with intelligent beings. And it's a term often used in the process of developing systems endowed with the mental processes characteristic of humans, such as the ability to think, discover meaning, generalize, and learn from experience. Now, the second term is bioinformatics, which is the science of linking biological data with techniques for information storage, distribution, and analysis to support multiple areas of scientific research, including biomedicine. And then it's also fed by high-throughput data-generating experiments. Then we have nanoinformatics, which is included in the new technologies of health sciences and is defined as the science and practice of determining information related to nanoscale. Also, nanoinformatics includes the development and application of effective mechanisms for the collection, validation, storage, sharing, analysis, modeling, and application of information. Now, within the new book, Nanotechnology and Therapeutics, Basic Trends, there are chapters that the author tries to intersect these concepts. The intersection of AI, nanoinformatics, and bioinformatics has notably influenced the evolution of medical diagnosis, enhancing the quality of diagnostic devices through the advanced material constructions and heightened the functional sophistication. This collaboration has positively impacted medical diagnostics, enabling devices to detect and diagnose conditions with great precision and depth. And then the incorporation of the nanoscale materials has contributed to this heightened device sensitivity, while the AI-driven functionalities, as the previous presenter showed, have elevated diagnostic capabilities, marking a significant stride in advancing healthcare technologies. So the book intersects these three concepts and application to therapeutics. And now I have some figures here, some slides from the book. So in this slide you can see the different applications of AI in healthcare. I go directly to the last part where we have the disease diagnostics, the drug efficacy, the ADMET prediction. ADMET is absorption, distribution, metabolism, excretion, and toxicity prediction. We also have disease and subtype discovery, disease target discovery, de novo drug design, and experimental design. Then another figure from the book, which shows the general process of artificial intelligence and machine learning in material science, which is the core of the book also. So having the original data in step 1 and then having the samples in step 2, we create the models and evaluate them in step 3 with several different applications like property prediction, like materials discovery, and other purposes like process optimization, finding of density functionals, and battery monitoring. Another interesting term mentioned in the book, and we try here to connect it with AI and ML, is to predict the liposome formulations by integrated machine learning. So liposomes is a bilayer vesicle-like particle composed by various lipids with a diameter ranging from dozens of nanometers to micrometers. Liposome formulation prediction models can be built using machine learning and artificial intelligence approaches. And the important parameters of liposomes, including size, polydispersity index, zeta potential, and encapsulation, can be predicted using optimal ML algorithms. And these are concepts described in the book. Finally, if we go to AI and the drug development process, this is also a nice figure. If you can see the upper part, we use AI for benchmark compounds set design to predict the target's role in the disease. We also have design of in silico compound libraries, identification of novel therapies, prediction of drugability of therapies, prediction of signaling systems, and then going also further, we have the drug repurposing, a new term. We have the selection of specific patient population. All these can be performed with the application of artificial intelligence, bioinformatics, and nanoinformatics. So there are several benefits with this collaboration for the pharmaceutical industry in embracing such technological approaches, like the discovery of new molecular entities and novel research directions, mining data from databases in a more precise manner, identification of the most relevant biomaterials that are either conventional or advanced excipients for producing effective final formulations, and the acceleration of processes by using and mining data from databases rapidly and accurately. Also, AI can partner existing conventional techniques for the accurate identification of morphology towards characterization of the internal morphology of the nanosystem using ML, machine learning, and deep learning approaches. And this by improving the design and development process of the novel and reproducible nanodrug delivery systems. Also, such approaches can be part of should be part of the dossier to be submitted to the regulatory agencies, such as a new drug application, NDA, when this is concerned. Additional benefits, the pharmaceutical industry will partner with AI startup companies and should embrace these new innovative directions regarding more precise development of nanomedicine, towards the development of new biomarkers utilizing deep neural networks, design of new pharmacologically active molecules, repurposing of existing drugs, characterization of new protein interactions, and discovery of new interactions that are emerging ways to introduce AI in pharmaceutical research. And in this slide, we can see existing collaborations between AI and pharmaceutical companies, in mainly drug development. So you can see several very well-known pharma companies like Biogen, like Roche, Pfizer, AstraZeneca, and then you see the different companies on the left and on the right side. And you can also see, although it's a little bit small, the reason for their collaboration. So you can see that there is for drug repurposing, the first one, or the second is to track real-time data via smartphones and other wearable technologies in a Bayer clinical trial. Also find new drug candidates for glaucoma, accelerate clinical development of new therapies for breast cancer. Concluding, there are already several applications of AI in pharma companies, and of course there are much more to take place in the future. I think this is my last slide. Thank you very much. I would like to invite the next speaker, Dr. Naziris. And the title of his presentation is New Health Technologies in Industry and Clinical Practice.
Thank you, Professor, for the introduction. And I would like to thank everyone on behalf of my professor and teacher, I think, as well, for being here for the launching of this book, this academic work, which above all is of educational character. I think he would agree. And up till, 5 seconds ago, I think I was wondering what would be the best way to share with you the experience I've had with Professor De Medjos these past 10 years, I think almost, that I've been with him from my undergraduate studies till my postdoctoral research now. And I think that this manuscript, apart from scientific and apart from its research value, the information, the classification of, let's say, technologies that it offers, I think that it's also a part of him, and in a very, in a sense, it's an inspiration for anyone who wants to know him and the work he has done all these years. A lot of effort into the field of nanotechnology and the translation into nanomedicinal products, with emphasis in the phenomena that take place in the nanocosmos, right? So this is the challenge, I think, right now, and what kind of analytical tools and what data science can offer to better understand the phenomena and understand the complexity, as he said, analyze them and regulate them. Of course, this starts from the bench when we try to develop them and control their properties, but it ends up in the hands of the regulatory agencies, as the dear professors also commented before. So, from our part and the team of pharmaceutical nanotechnology, who are all here, and we will be here tomorrow as well to discuss with you, we can offer some insight in the field of nanotechnology, from the part of technology, analysis of these systems, new advancements, but also propose maybe how we can better scale them up for industrial applications, and maybe try to fill this gap for clinical translation, right? So I think some very important keywords mentioned in the book and mentioned in this session as well. We have all these health technologies and the updated version of them, and we'll see what that means. We primarily deal with nanomedicine, nanotechnology, but I think that nowadays all the different technologies, for example, cell therapy, as we will see later, or gene therapy, they are all intertwined, right? And we need to find a way how to incorporate them more harmonically and apply the principles from all these different fields in a manner that will have the best possible outcome. Self-assembly, analysis, and the regulation are very important words in this process. The World Health Organization defines health technology as the application of organized knowledge and skills, which is very important, in the form of devices, medicines, vaccines, as we've seen, and systems in general that may solve a health problem or improve the quality of life. So the new health technologies term applies to this definition, and of course medicinal products are not new, but combined with other technologies, we have now new drug molecules that may be more well-suited for targeting of specific receptors or specific biochemical paths. Of course, we know biotechnological products and biosimilars as well. Then we have nanomedicinal products that came afterwards, and nowadays they're very popular. We have advanced therapy medicinal products, including several technologies, and I'd like to see medical devices as a technology that can treat, but it's also a technology that can give us answers on the behavior of other types of technologies. So all these algorithms that I'm not very familiar with, but I would be happy to know more from you maybe, I think will give us answers to the behavior, on the behavior of these systems. So this is a recent example from the literature that shows how researchers developed some, I think we would define it as a cell therapy. Of course, it's in development stage still, but they're called anthrobots, and they occur from the self-assembly of individual cells. We can say that we have the infusion of functional properties in cells that ultimately can give even healing properties for neurons. So this technology starts from, let's say, the concept of biology. It goes through the concept of self-assembly. We have specific phenomena that we need to understand. We have final properties like the fractal morphology of these aggregates and how they function on neurons. So a lot of properties to regard. An earlier publication from the same group showed how we can build cells in silico from individual molecules, which to me is fascinating and I mean a great opportunity, but I'm not really sure how to approach this technology with our tools, with the tools of nanotechnology. So we have living organisms from scratch, from zero, and they become cells with specific morphologies, like Professor De Medjos commented before. And we need to, of course, understand these morphologies and how they're going to interact with other biological systems. ATMPs are more well known. We have gene therapies, cell therapies, and tissue engineering products. But, of course, after all these efforts these last few years, we can say that new approaches will emerge in technological, analytical, and regulatory perspectives. Of course, one of the main themes in the book Nanotechnology in Therapeutics is nanotechnology and nanocarriers, which has started a long, long time ago. And we have first products that, I mean, here you can see the different classes, which is very important to keep in mind and to understand. And we have new classes emerging every day from polymers, from proteins, complexes, inorganic nanoparticles, of course, for diagnostic or therapeutic purposes, or the combinatorial concept of theranostics. But one of the first and, let's say, most well-studied classes is liposomes. And these are the small, the tiny sphere-like vesicles that look like cells. They are similar to our membranes, right? So they are also, they have been given the terms biocompatible and biodegradable and all these promising properties. The first product being approved in 1995, so 30 years since then, since the first liposomal and one of the first nanotechnological products, liposomal doxorubicin. Since then, we have advanced the field very much by incorporating other types of materials in these systems. We combine them with polymers, with proteins, with inorganic particles, as I mentioned earlier, and these are called a new class of innovative excipients for pharmaceutics. But as you understand, we are not talking only about pharmacy. We are talking about medicinal products. And it's very important to understand that regulatory-wise, these fields might be different at this right now, at the moment, but we have to harmonize them, right? The book also mentions different processes for the production of nanoparticles, and I'm very happy to read inside the process for the production of lipidic vesicles that we developed a few years back when I was in my PhD studies. A very simple process, but not only that, a lot of other processes for the production of lipidic nanoparticles and other types of nanoparticles. And it's very promising to see such processes and technologies that were developed inside the laboratory, nowadays being applied in industrial scale, and even having products in the market by using these technologies. So it's not just theory, of course. We want to apply all these technologies. We want to have the translation and the benefit for our society. For liposomes, it's very important to understand the structure, their properties. As it was mentioned earlier, we have the drug encapsulation, we have the size, the polydispersity, and all these properties can be probably, we've seen it mentioned theoretically in the literature. They can be studied by data science tools. There are not a lot of practical examples for me to give you. I don't think that it is a field that has flourished still. But I think that if we come closer as groups and truly apply this interdisciplinarity that we are all talking about all these years, we can probably see what you have to offer so that we can understand better these tiny little things that we make in the laboratory. And of course, the clinical outcome is the final what we finally want to achieve. But if we do not understand the intermediate steps, then this is a random process, right? It's not fully random, but if we understand the complexity of these systems, as Professor De Majors mentioned, and lately we have seen that the internal complexity, the external complexity, and the interface area are very important. These different levels maybe earlier were thought, as one unilamellar thing, one homogeneous thing, one and the same property, but they are now different levels of the same particle that they might affect the different properties of the particle, such as the drug release from the nanoparticles. Some very nice cases that are shown inside the book, and the cryo-TEM images, or TEM images in general, that give us insight to the morphology of such systems. And finally, I would like to conclude with the concept of chaos theory and non-linear dynamics. With my friend and colleague, Professor Stavrinidis, here at the front. We are going to present tomorrow a brief, let's say, we call it workshop, but it's really a presentation and a stimuli for discussion with you, because we try to apply nonlinear dynamics tools to liposomal systems, and we have our first publication some years ago. Here you can see some results from the manuscript. We specifically try to apply nonlinear dynamics on the stability of the size and the polydispersity index of these systems, and I think that the results were fascinating, and the indexes that we calculated Of course, it was never done before. They're considered, let's say, a new analytical tool for these systems and the way to delineate their complex behavior. So maybe we can later predict their stability beforehand if we have the necessary information. The regulatory framework, of course, is the final step. The cycle of innovation includes all these elements that you can see here, from the initial idea to the clinical stage, authorization, post-market, and back to the initial idea. And the 4 pillars for these new health technologies are the risks, ethics, rights, and markets, and these are discussed inside the book. I think that it's time to discuss more on what the regulatory approval, monitoring, etc. tools will be in the future for such products, because they are evolving very fast, and each field has its own achievements. But when we're talking about interdisciplinarity, I think that finally we will have to come up with some common rules, common ground to analyze and better understand these systems so that we may be able to make the most of it, right? And we always care about having a high benefit and a low cost for these treatments. So I think that with this slide, I would like to thank you all for being here today and take your questions if you'd like.
Thank you, Dr. Naziris. Maybe the questions at the end. I would like to invite Dr. Maria Houdulesi from Unipharma, and the title of her talk is Nanotechnological Platforms Intended for the Delivery of Biomolecules.
Good afternoon to everybody. Before starting, I would like to thank Professor Kostas Dermedros for inviting me to participate in this session and to wish him good luck to the launch of this new book, Nanotechnology in Therapeutics. In this presentation, we will present 2 basic chapters of this book dealing with nanotechnology in vaccines and some regulatory aspects. Starting from the development of novel vaccines, describing some of the basic categories and clinical applications. And regarding the second subject, the book focuses on the regulatory framework of the advanced therapy medicinal products, of the nanobiotechnological products, as well as some nanosimilarity and biosimilarity issues. Let us now start from the first subject regarding the nanotechnology in vaccines, with a mini introductions. Vaccines are biological products intended to activate the human immune system to produce antibodies against specific antigens by using subunits of recombinant or purified pathogen-specific proteins or antigens, as well as some adjuvants in order to improve the antigen uptake by the antigen-presenting cells. We should have in mind that each year the vaccines prevent for more than 3 million deaths. In the next slide, you may see the historical pathway of both mRNA and lipid nanoparticles evolutions in parallel. These 2 pathways have been met since 1978, from the development of the first liposomal mRNA formulations till today, wherein many different clinical trials of nanovaccines are being organized for different pathologies, including cancer immunotherapies and virus infections. And of course, the market approval of nanovaccines like Onpattro or COVID mRNA vaccines. Apart from mRNA, vaccines have already used nanotechnology also to carry protein antigens against the influenza virus with the technology of artificial non-viral nanovectors called as virosomes. We should take into account that the development of such products requires, it is an interdisciplinary subject that requires the collaboration of many different scientists from different fields, including nanotechnology, biotechnology, and genetic engineering. As it is depicted in the book, the formulation process of a vaccine is a multifactorial process. Of course, the selection of the nanocarrier and its biomaterial and the selection of the adjuvant type are two main key parameters. The nanocarrier could be either polymer or lipid or of other biomaterials such as peptide or metallic nanoparticles. And of course, their physicochemical and morphological characteristics affects the final behavior of the vaccine and its biological performance. Of course, also the adjuvant type affect the final formulation. Adjuvants could be either synthetic or genetic engineered or even a natural product. Some issues that we should also have in mind regarding nanovaccines is that we should achieve stability, safety, and efficacy, and also the reproducibility of its production process. Let us now describe some of the main nanocarriers being used for nanovaccines, starting from the liposomal nanocarriers. These products have already been on the market as lipid nanocarriers, non-viral vectors called as virosomes. They are anti-influenza vaccines like Inflexal and Epaxal. And the addition of non-ionic surfactants or bile salts seems to be able to increase the immunogenicity of the product, increasing its permeability through cell membranes and the stability of the final product. Contrary to liposomes that are characterized by a lipid bilayer, the lipid nanoparticles include different internal morphologies, as you may also see in the cryo-TM images obtained by the literature, where you may find multivesicular particles and many different spherical nanostructures with different dense cores. The lipid nanoparticles are mainly composed of cationic ionizable phospholipids together with cholesterol or other phospholipids or polymers such as polyethylene glycol. They have been used to effectively protect genetic material and deliver it to the cells, because they can protect the nucleic acids from degradation by nucleases, uptake by phagocytes, and their association with serum proteins. They have played an important role in development of COVID vaccines. Lipid nanoparticles usually use ionizable lipids with a positive charge that are less toxic than the non-ionizable ones, because they are positively charged only inside the cells, and due to pH change, they become uncharged into the bloodstream. In the same chapter, some subcategories of lipid nanoparticles are also presented, such as the solid and the nanostructured ones, along with other types of nanoparticles for vaccines, such as polymeric, inorganic, metallic, and emulsions. Polymeric nanoparticles may include nanocapsules or micelles or dendrimers. The inorganic ones are non-biodegradable, but they exhibit well-controlled preparation process and better reproducibility, while the gold nanoparticles are being investigated also as immunoadjuvants. Moreover, a special reference in the book there is about the formulation of COVID vaccines. A comparison of the two mRNA lipid formulation is presented in this table taken from the book, highlighting also their differentiation in the storage conditions. Moreover, another nanovaccine has also been developed that includes not mRNA but the spike protein and the adjuvant, and as its adjuvant, a natural product saponin. Moreover, many different case studies regarding the lipid nanoparticles nanovaccines in the clinical applications are also described in the same chapter of the book. And furthermore, another critical issue that it is highlighted is the role of biophysics. For example, the creation of different metastable or lipid rafts phases within the lipid bilayer of the nanocarriers may affect the final stability of the nanovaccine and therefore its final functionality. Of course, the application of thermodynamics and with methods such as differential scanning calorimetry could help us to disclose such a metastable phase and prevent such instability issues. And now let us move on to the second part of the presentation, to the part of the book regarding the regulatory framework. In this chapter, you may find some basic information regarding both FDA and EMEA organizations and their main committees. Of course, the chapter focuses on the advanced therapy medicinal products and its regulatory framework. These products can be classified in gene therapy medicines, somatic cell therapy medicines, tissue-engineered medicines, and also its combined category. We should mention that such products exhibit great challenges, such as the procedures for establishing good manufacturing standards, its clinical trials, their heterogeneous national regulatory processes, and some reimbursement issues. The chapter highlights the need of establishing appropriate regulatory and controlling standards, as well as robust methodologies and evaluations process that should be continuously monitored, evaluated, and improved. Not only the advanced medicinal products exhibit critical issues, but this is also in the nanobiotechnological products and their regulatory framework. Such issues may be summarized to the following questions. Which are the best analytical techniques and physicochemical characterization methods in order to have the better assessment of the nanoparticle behavior? How could we assess the pharmacokinetics or the drug release profile? How we could achieve a reproducible scale-up method in order to move on to larger productions? Are there any standards regarding the biomaterials that are being selected for the nanocarriers? And eventually, which are the critical parameters of the nanoparticle that we should also have in mind? And finally, last but not least, the chapter states some significant queries regarding the subject of the nanosimilarity. How we could produce functional, effective, safe, easy to scale up and repeatable nanomedicines? Is there a reproducible framework in order to define the term of the nanosimilarity? What are the scientific and the law-based directions that should be applied? How could we measure the reproducibility during the scale-up and manufacturing process of nanomedicines and nanosimilars? And eventually, which are the limits regarding the nanoparticulate carrier? In all these queries, the chapter is trying to answer to with stating some basic terms like the critical quality attributes of the nanoparticles, including physicochemical and morphological characteristics, the need of quality by design, the need of robust regulatory framework and robust methodologies in order to assess all these characteristics, the fact that the nanocarrier is actually an advanced excipient, that it is very much different than the classical one excipients, and eventually how all these matters could lead us to our final scope, which is to have nano products and nanosimilars of high safety and efficacy. Thank you very much for your kind attention.
Thank you, Dr. Khoudoullessi. I think Professor Demetriou would like to thank some people that contributed to the book.
May I have the presentation? So I would like to thank some people, but I would like to dedicate this ceremony to my professor and mentor, Professor Dimitris Papachagopoulos, when I was as a postdoc in his lab in 1995. Okay. So, dear colleagues, thank you very much for being with us in this ceremony, and I would like to dedicate this ceremony to my mentor in nanotechnology, Professor Dimitris Papachagopoulos. Dimitris Papachagopoulos was a pioneer in the field of pharmaceutical nanotechnology and in applications of nanotechnology in therapeutics. Professor Dimitris Papachagopoulos was one of the visionaries in liposomal nanotechnology, and in 1995, when I was at his lab, completed my postdoc period producing new lipidic nanotechnological platforms encapsulating Vika alkaloids. Dimitris Papachagopoulos, with his team, developed the first anti-cancer liposomal medicine named Doxil in Europe Calyx as co-founder of the company Secus Pharmaceuticals, which has been approved by FDA to cure cancer. This was the first liposomal nanomedicine which is still available as an original product on a global scale helping cancer patients. As written by his student, Professor Peter Goulis, who has made a significant contribution to the development of nanotechnology vaccines against COVID-19 in the article dedicated to the memory of Professor Papachagopoulos, Professor Goulis said, Dimitris Papachagopoulos has played a leading role in developing the science and technology of liposomal systems. As a result, he has influenced the careers of most scientists in the field of pharmaceutical nanotechnology and nanomedicine. Numerous articles have been written in scientific journals such as Nature and Journal of Liposome Research in memory of Professor Papachagopoulos, which mention his significant and influential role in pharmaceutical nanotechnology. So I would like, and I did, dedicate it with respect and love this book to the memory of my beloved mentor, Professor Dimitris Papachagopoulos, who introduced me to the nano world during my postdoc period at the University of California at San Francisco in 1995. I would also like to thank Wiley for the excellent job and the collaboration during the management period in shaping and correcting the chapters of the book and the excellent results. Of course, I would like to thank Unipharma pharmaceutical industry for the continued support of my scientific efforts, especially the CEO, Dr. Iulia Ceti. And of course, there are many people that I would like to thank. And first, Professor Vlamos for hosting the session of my book launch in the Congress Genedis and for his friendship for many years. The Vice Rector of National Kapodistrian University of Athens, Stathis Efstathopoulos, for his friendship and for the excellent collaboration for many years in the field of nanomedicine. I would also like to thank Professor Themis Exarchos and Dr. Maria Koudoulesu convey to the audience the main significant ideas about therapeutical nanotechnology based on the content of the book. And of course, I would like to thank Dr. Konstantina Skolariki, who supports and manages in an excellent way all issues related to the presentation of the book. I thank Professor Dr. Douroumis, who encouraged me to write this book and write an extensive foreword. Of course, I would like to thank my friend, chemist and mathematician Aris Georgopoulos, who stood by me for more than 20 years and helped and supported my scientific efforts. I thank Dr. Nikos Naziris, who supported me in all my scientific efforts and has stood by me for over 10 years. I thank Professors Stavros Stavrinidis and Michalis Chanias for providing information on chaos, nonlinear dynamics, and for fruitful discussions. Very grateful to Dr. Barry Steele for proofreading the language of the manuscript and his suggestion for making it more readable. And of course, I would like to thank my close colleagues, Maria Tsakiri and Yannis Tsichlis, PhD candidates, for the fruitful discussions in new directions of innovative drug delivery nano platforms. Finally, thanks to the evolution in science technology in recent years, I had the opportunity to discover scientific issues in a more precise manner. And of course, I would like to thank you for being here in this ceremony. Thank you very much.
Okay, thank you, Professor Demezos. I think we have time for a couple of questions, if you would like, in the book to any of the presenters from the audience. Or if the presenters would like to make questions to some of the other. To the microphone, yes.
Thank you very, very much for the excellent talks. I'm trying to ask about something about design and design-specific nanomaterials or lipid nanomaterials. I can understand, for example, about cancer, we should actually design and focus on pH or specific thermosensitive nanomaterials. Talking about Alzheimer or neurodegenerative diseases, how efficient is someone to design nanomaterial or lipid particles in order to penetrate the blood barrier? I mean, it's very easy for us to design such as molecules or systems. Thank you.
Okay. If I may, thank you. And thank you for the question. Stimuli responsive systems were part of my PhD research and still one of my passions. But regarding BBB permeability and BBTB permeability, when we have tumor, for example, or any special pathophysiological conditions when we have neurodegenerative diseases because we have inflammation, right? I mean, and it's something that recent strategies focus around, and we try to find new approaches. Regarding nanomaterials, there's a lot of this concept called active targeting and targeting specific receptors on the BBB barrier so that we can transport the particles through. It's not the only one, though. Stimuli responsive systems are not the ones to take the, let's say, the active ingredients or the therapeutic molecules across, but I think they're mostly intended for releasing the cargo at the very end where the molecule needs to take effect. But of course, this is only a very specific strategy as I've seen it. There are tons of strategies to bypass the BBB. I mean, you can even totally go, I mean, bypass it, not go through it, like we have the other routes of administration that can just neglected, I don't know how to say it, and then you just have the target. But I don't know if that you were looking for. I think that it's a two-step process to go through and then to release. And stimuli responsive systems are more at the end of that journey. But that's not, of course, the only strategy. I don't know if anyone else wants to add something. Thank you.
Thank you. Any other question? Please.
Thank you all the presenters for excellent presentations, and thank you Professor De Medzos for an excellent book, another excellent book. I'm wondering why don't we use the term biomolecular technology instead of nanotechnology? Because we mainly talk about biomolecules, mainly. For example, Professor Papahatzopoulos, did he use the term nanotechnology back then, 25 years ago, or 30 years ago? So I know it's a trendy term to call it nanotechnology, but it's basically biomolecular technology or biotechnology. Thank you.
Okay, I think that it is not a trendy direction regarding the terminology. I think that nanotechnology gives us the real dimension of particles that we use, because nanoparticles are very effective in the end product. So if we have the knowledge about the nano dimension, we can produce such nanoparticles that could be effective apart from the encapsulated molecule. So in my view is that nanotechnology is the correct definition of this technology, because biotechnology or biomolecular technology, whatever, not clarify what we want to produce. So it's my point of view, it's that nanotechnology is yes, Papahatzopoulos used that term, and used the term liposomes, which combines the word lipos and soma, body, okay, and prefers liposomes and not liposomes as nanotechnological platforms. Okay.
Thank you. Any other question? Okay, I think this concludes the session and concludes also. Yes, please.
Before concluding, θα ήθελα στα ελληνικά να καλωσορίσω τον πρόεδρο του Ελληνικού Ερυθρού Σταυρού, τον φίλο αγαπητό δόκτωρα Αντώνη Αυγερινό, ο οποίος πάντα με τιμά με την παρουσία του σε όλες τις εκδηλώσεις. Ευχαριστώ πάρα πολύ. If you want to say some words.
Dear colleagues and the distinguished speaker, actually on behalf of the Hellenic Red Cross, I would like to bid a cordial welcome to all of you. And actually I'm very happy to see that so many scientists have come together in order to exchange views and information and to discuss issues and problems which are of great interest to our field of specialization. I hope that all events and sessions of this Congress be crowned with success. Θα ήθελα στα ελληνικά τώρα να συγχαρώ τον αγαπητό καθηγητή και φίλο, τον κύριο Κώστα Δε Μέτζο. Προσωποποίηση ύφους, εμνότητος, ιδιαίτερης όμως προσφοράς στο ακαδημαϊκό του καθήκον. Επίσης, χωρίς ίχνος κολακίας, αγαπητέ Κώστα, θα ήθελα να τονίσω ότι είναι ιδιαίτερα δραστήριος, δημιουργικός και βεβαίως διήνυσε, αλλά και διανύει μια επιστημονική, επαγγελματική, αν θέλετε, και κοινωνική διαδρομή, ιδιαίτερα θα έλεγα γόνιμη και δημιουργική. Αγαπητέ Κώστα, λίγοι έχουν την τιμή και τη χαρά εν ζωή να χαίρουν της μεγάλης, θα έλεγα, τιμής και διάκρισης. Είσαι ένας από αυτούς και ειλικρινά θα έλεγα, εάν δεν είχες την ταπεινοφροσύνη και τη σεμνότητα, η λέξη κόσμημα στο ακαδημαϊκό χώρο θα ήταν η πρέπουσα για σένα. Θερμά συγχαρητήρια.
Thank you again. This concludes the first day. I would like to thank you all for being here, and we expect you tomorrow for the second day of the conference. Have a nice evening.